والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Respected colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. It's a pleasure again to meet once again and welcome you on behalf of the Saudi Society of Blood and Marrow Transplantation to the second Ssbmt and SSH combined annual conference. So this conference also covers other events that combined in this meeting: the 21st annual meeting of the Saudi Society of Hematology, the 12th annual meeting of the Pan-Arab Hematology Association, the 9th Hematology Year Review of the Ssbmt, and the 9th Saudi Group for Hematology Research annual meeting. So all of these meetings are combined today under the two societies of hematology and stem cell transplantation in Saudi Arabia. So we'd like to welcome you all and welcome our guests and distinguished speakers who traveled all the way to be with us today. This meeting again aims to enhance our connection and our networking, collaborative work, working together, and also bring update to the region from the various international meetings and various updates in the field of hematology, stem cell transplantation, cell therapy, and gene therapy. The program is comprehensive, and the scientific preparation was led by Dr. Ahmed Absi and teams between the two societies. And I would like to extend appreciation and thanks to the scientific committee for their excellent work. Organization of this meeting was led by, again, distinguished team with expertise already throughout the years in preparation of this meeting. And again, I would like to thank them for the preparation. And a special thanks to our sponsors, especially Vertex and Sanofi, our main sponsors, and the many sponsors that supported this event. And I would like to draw your attention again to the fact that this meeting, it brings update. However, these lectures and talks are kept in our YouTube channel, and you could visit our YouTube channel, which contains all the talks and presentations over the last years. You could listen to these talks anytime, and I would encourage you, while driving in the busy streets and traffics, to tune in and listen to the talks that you need to catch up with and update yourself with. So it's a great treasure, I would say, and I used to do this in my during my trips, and it's very resourceful, actually, channel. Also, the Ssbmt is embarking on opening another YouTube channel for public awareness, which is highly needed. Although we have a number of activities related to public awareness, however, nowadays with the trend listening to podcasts again for the public, this is something that we are starting a series of podcasts tuned and aimed for, again, public awareness. It will be in Arabic language, and we would appreciate, again, volunteers from our experts to participate in these episodes, which will focus on various diseases, various therapeutic modalities, that the public needs to be aware, and probably the decision makers in the country that needs to be aware in terms of importance and update. So talking about social media, again, I would encourage you to engage in reacting to our Twitter posts and accounts, websites, and related, again, social medias. So without further ado, again, I would like to thank you, and I would like to introduce Dr. Ahmed Barifa, who is the new president of the Saudi Society of Hematology, who will again give the address on behalf of the Saudi Society of Hematology, who is our collaborative body. Please.
I need this water. Thank you, Prof. Ahmed. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. رئيس الجمعية السعودية لزراعة الخلايا الجذعية الأستاذ الدكتور أحمد العسكر، رئيس الاتحاد العربي لأمراض الدم الأستاذ الدكتور محمد حسن قايري، رئيس اللجنة العلمية للمؤتمر الأستاذ الدكتور أحمد العبسي، الأساتذة والزملاء ورؤساء الجلسات والمتحدثين الكرام والعاملين في اللجان التنظيمية، الحضور والضيوف الكرام، السلام عليكم ورحمة الله وبركاته. أرحب بكم جميعاً باسم الجمعية السعودية لأمراض الدم في المؤتمر المشترك الثاني مع الجمعية السعودية لزراعة الخلايا الجذعية، والذي يجمع 4 اجتماعات هامة، وهي المؤتمر السنوي 21 للجمعية السعودية لأمراض الدم، والمؤتمر السنوي 12 للاتحاد العربي لأمراض الدم، والمؤتمر السنوي 9 للجمعية السعودية لزراعة الخلايا الجذعية، والمؤتمر السنوي 9 للمجموعة البحثية السعودية في أمراض الدم. يهدف المؤتمر لبحث المستجدات في طب أمراض الدم بفروعها المختلفة. إننا نشهد تطوراً هائلاً وقفزات نوعية في جميع المجالات في مملكتنا الحبيبة، بقيادة خادم الحرمين الشريفين وولي عهده الأمين، من خدمات صحية وتعليم وأبحاث واكتشافات. ولعل طب أمراض الدم هو أحد أهم التخصصات التي تقود هذا التطور الملحوظ الذي يواكب أهداف الرؤية الطموحة رؤية 2030. في هذا المؤتمر الذي يقام على مدار يومين 10 جلسات تحتوي على العديد من المحاضرات من متحدثين عالميين بارعين في مجالاتهم، سيأخذوننا في رحلة لأعماق التخصص على ساحل البحر الأحمر. أدعوكم للاستمتاع والاستفادة والمشاركة بفاعلية في هذا المؤتمر. ولا يفوتني أن أشكر سعادة الأستاذ الدكتور محمد قايري الرئيس السابق للجمعية السعودية لأمراض الدم على ما بذله ويبذله دائما في خدمة طب أمراض الدم والجمعية على مدى السنين الماضية، فله منا جزيل الشكر والتقدير والاحترام. Dear guests, chairpersons, distinguished speakers, welcome to the combined Ssbmt and SSH annual meeting. Thank you.
Bismillah ar-Rahman ar-Rahim, and Sabah al-Khair, good morning for everybody. My name is Ahmed Absi. I'm the scientific meeting chair. This meeting today, first of all, I would like to thank Dr. Ahmed al-Askar, Dr. Ahmed Barifa, Dr. Muhammad Qari for their confidence in the scientific committee I would like to thank my co-scientific committee members. I think without them, this program today would not have happened. I would like to thank all of our speakers, either locally, regionally, or internationally, who made the effort to travel all this to come and be with us today. And I think first and of utmost importance, I would like to thank Noor Kai, she's outside, and her all oral admin assistants who, without them, this definitely would not have happened. So this year's meeting has been again divided into over 2 days. What we've done differently this time is that we made an alternation between benign and malignant sessions in order to assure that whatever your priorities are, that you stay and attend the 2 days. The conference schedule is very rich, but I think it's very informative, and it's excellent until the last lecture. All of the lectures, I think, I personally, and I'm sure all of us, look forward to, and I hope that we all have a very fruitful and enjoyable meeting. And thank you very much all for attending today. I guess without any further ado, we can get started. Our first session of the day is malignant acute leukemias or leukemia session. It's going to be chaired by two of my friends and colleagues, Dr. Ssbmt from King Abdulaziz Medical City in Jeddah, Dr. Ghazi Al-Ataybi from King Saud University in Riyadh. So Dr. Salim and Dr. Ghazi, it's all yours right now. Thank you.
Assalamu alaikum. Good morning, everyone. So I think it's actually a great opportunity to welcome one of our dear colleagues, Dr. Munir Al-Malki, who's coming all the way from Los Angeles. So Dr. Munir Al-Malki is a transplanter. He works at the City of Hope, and he's done actually quite a good job in mainly the transplant, in haploidentical transplant and unrelated match transplants. So Dr. Munir, from very warm LA to very nice Jeddah, thank you very much for joining today. So his topic will be, how do you manage AML in the era of targeted novel therapy? So Munir, the floor is yours.
Good morning, everyone. I'm Munir Al-Malki, Associate Professor in Hematology and Transplant in City of Hope and in LA. I'm the Director of the Unrelated Donor Bone Marrow Transplant Program. And I would like to start by thanking you all for being here and thanking the organizing committee for their kind invite. Those are my disclosure. None is relevant for today's talk. So with this slide, I show you the most known mutation in AML, including the incidence of each. The indication for that is that this disease is genetically heterogeneous, and we get to know this disease more and more. WHO has adapted this in their recent classification also, and included all those mutations that has impact on the prognosis of those patients. Understanding that precision medicine and targeted therapy is becoming very relevant in this era. I'm going to start now with my cases, and we'll discuss those accordingly. So Mr. Rara is a 65-year-old male with history of prostate cancer, diagnosed 5 years ago, and had some treatment with radiation therapy, transferred to from local hospital with new diagnosis of AML. He's initially presented with fatigue and bruising. He underwent bone marrow biopsy, and this shows 10% blast. Repeat biopsy done here, indicating increasing in blast, and WBC was 1.5. Platelet were 10,000, and coagulation studies showed prolonged PT-PTT, low fibrinogen, and increase in D-dimer. Peripheral smear shows this, and as we all aware of this, our rods, and the diagnosis is made for APL. This is the most common, this is the most curable disease that we deal with on daily basis. The main problem with this disease is the high early mortality. It's quoted in this paper to be close to 20%. The early mortality in this is mostly due to coagulopathy associated with this disease. In APL, there is increase in fibrinolysis, increase in coagulation due to tissue factor and damaging of the tissue, and increase in proteolysis. All of those, as we can predict, will lead to unbalanced coagulation and bleed. We do, how do we prevent that? We start ATRA as soon as possible, and we replace coagulation factor. And this is really complicated schema. I apologize for that. This is meant to summarize the management of this disease. But really, to make it easy for us to understand, we confirm diagnosis by translocation 1517. We assess the risk of the disease by looking at WBC, if this is above 10,000 or below. And we start ATRA and arsenic based on this work done in Italy 10 years ago. Adding GO or IDA is optional for high-risk patients. The main issue here is managing the side effects of the disease and the treatment. So we have to deal with differentiation syndrome, fluid overload, CNS prophylaxis, and ATO electrolyte imbalance, and EKG changes. This is what you would do in the first month after treatment. And this was all done based on the published data by the Italian that we are all aware of. So going back to the case, Mr. Orr started on ATRA and arsenic, and on the 8 days of the induction therapy, patient developed fever, increased shortness of breath, and a chest X-ray showed bilateral infiltrate with a drop of oxygen saturation to 88%, requiring some supplement oxygen. So what's the approach in this patient case? This is differentiation syndrome. The pathophysiology we are all aware of is related to excess release of IL-2, IL-6, IL-8, and TNF. This all together will cause fever and increase in permeability, producing all those signs and symptoms. Important to note, time of onset and grading are very important here. With severe form of the disease is having 4 or more of those features. This paper is important. It has some details on management and prophylaxis guideline. I will refer you to it. Move on for the next case, sorry. Mr. Rux is a 35 years old, sorry, Ms. Rux is a 35 years old woman, previously healthy, was presented to local ER with fatigue, bruising, and gum bleed. Her CBC was abnormal, and a bone marrow biopsy was performed showing hypercellular marrow with 50% blast. This was positive for CD13, 33, 34, HLA-DR, and MPO. Cytogenetic results came back, and it was positive for translocation 821. So this is a core binding factor AML. What's the prognosis and what is the management? As we all know, based on the recent ELN, this will be considered to be favorable. And based on those curves, expectation for long-term cure will be in the range of 55% at 5 years. The main issue we deal with here is that patients who have c-KIT mutation will not have the same prognosis. As you can see in those curve on the right side, overall survival is significantly lower in patients with core binding factor and c-KIT mutation. Those patients require transplant. So in this slide, I tried to summarize what we know about options that we use for younger patients who are fit for intensive chemotherapy. So on the left side, you can see induction chemotherapy options. And as we can see, people have been using 7+3 forever, adding now GO for specific subsets, and some data on flag GO. Patient with FLT3 can have a FLT3 inhibitor added, and people with therapy-related can have CPX based on recent data. Other options that have been attempted, including flag antibody drug conjugate against CD33, was first approved in 2000 and was withdrawn in 2010 based on the reports of increase in VOD in those patients treated with that. But in 2017, this was reintroduced with lower dose based on the ALPHA study. In this study, patients received GO, had significant improvement in overall survival. And as you can see, patients population on this study were CD33 positive, AML, aged 50 to 70 years. This was randomized phase 3 clinical trial and was positive, and brought the medicine back again to market. The overall survival in this study was more pronounced in patients with favorable and intermediate risk, and high-risk patients did not benefit from that. Another study incorporating another medicine called dasatinib. This medicine can be used upfront therapy with core binding factor, and this study is CLGB-1081. Is a phase 2 study. It was done in multi-centers and had dasatinib added to the 7+3. And based on those curves, the approach seems to benefit patients with mutated c-KIT, as we can see improvement in their outcome. This is my third case now. Mrs. Vixus is a 65 years old female with a history of chronic kidney disease, breast cancer, had mastectomy and chemotherapy with radiation. She presented with a new diagnosis of AML. Bone marrow biopsy showed myeloblast at 30%, and her karyotype was complex. She had TP53 mutation. So what is the best induction therapy for this patient, and what do we do after? Understanding that she is not a transplant candidate based on her creatinine clearance. This is a very busy slide. I apologize for that. This is coming from NCCN, and it gives you all the treatment option for younger patients. For patients of 60 years old and older. In one of those sections in the middle, you can notice that there was a therapy-related AML and secondary AML, and the recommendation is to use CPX. So CPX 351 is a nano scale delivery complex with 5:1 molar ratio of cytarabine and daunorubicin. The data for this comes from this study, where patients are aged 60 to 75 years with newly diagnosed therapy-related AML or secondary AML were randomized to 7+3 versus CPX on day 1, 3, and 5. Patient, as we can see here, receiving CPX showed significant overall survival advantage. Benefit was seen in all subgroup, including different age group and cytogenetic risk. So she went to remission, and what else? What can we do after that? She completed induction and consolidation, and in this study called COSAR, patients who are not eligible for transplant were randomized to receive maintenance therapy, oral AZA versus placebo. And as we can see on the right side on the curve, patient on maintenance had almost 10-month increase in median overall survival. Case number 4. Mr. Viale is a 77 years old gentleman who had history of hypertension, chronic kidney disease, stage 3, and presented to us with newly diagnosed AML. Bone marrow biopsy again showing 40% myeloblast, trisomy 8, and IDH1 mutation. So what would be our recommendation for this gentleman? Venetoclax is a BCL2 inhibitor which target oxidative pathway through mitochondrial-induced apoptosis. So killing of those cells will happen based on the high metabolic rate. And this was a landmark study where patients above the age of 75, unfit for chemo, got randomized to AZA with or without venetoclax, with venetoclax versus placebo actually. CR/CRi was around 65% versus 30% on those patients who receive azacitidine alone, while CR was 35% versus 17% on this patient population. And as we can see, the primary endpoint is median overall survival on the right side with the curve. It was close to 15 months versus 10 months with aza-ven around 35%. And as you can see on the tail of this curve, 35% of patients are alive more than 2 years without receiving a transplant. In this complicated slide, we are showing response rate per different mutation and molecular predictor that we know of. And as you can see on top, patients with TP53, FLT3, and RAS pathway mutation are the most resistant to this approach. While if you look at the bottom, and you can see those responses approaching 80% to 100% actually with the IDH and NPM1. So this could be a helpful information for us in our choice as those patients with older age has multiple other options. Viale-C is another study that was happening around the same time where patients had low-dose cytarabine with venetoclax versus placebo in similar type of population. As we can look and compare these curves to the prior ones, there's a little bit less impressive, but still showing some difference in overall survival of 3 months. Another option for older patients who are not eligible for intensive chemotherapy could be, again, if they cannot receive venetoclax, could be glasdegib, which is a Hutch pathway inhibitor. In this study, patients above the age of 55 with newly diagnosed AML or MDS with excess blast 2, not eligible for intensive chemotherapy, were given this medicine based on phase 2 study. The treatment plan for this study was cytarabine 20 milligram per meter square on day 1 to 10, plus minus glasdegib 100 milligram daily for 28-day cycle. Median overall survival was improved from around 5 months to 9 months. Again, with some patients around 15% having long-term survival for more than 2 years. But there's a small trick here. Particular combination seems to be more effective in patients with good intermediate cytogenetic risk. As you can see on the right side, the curve showing poor cytogenetic risk patients who did not benefit from adding this drug to only low-dose cytarabine. Remember, our patient had also IDH1 mutation. So another combination that could be valid for this patient is ivosidenib with azacitidine. And this agile trial, patients were randomized to receive azacitidine versus azacitidine and ivosidenib 500 milligram daily. This was a randomized phase 3 European study in patients who are 18 years old and above with newly diagnosed AML with IDH1 mutation. CR/CRi was in the range of 53% versus 20% when you receive azacitidine alone. A median improvement in overall survival we can see on the curve is more than a year. The major critique for this study, though, is that Ivosi was not compared to venetoclax, which is considered to be the new standard of care in this era. Also, as we can see here in those, as we can, compare to the other numbers, CR/CRi was way lower at 50% when we compare with the prior data I just showed in IDH with the venetoclax achieving CR/CRi range of 80%. In case 5, Mr. Ratfi is a 59 years old gentleman, previously healthy, presented to local ER with acute dyspnea and confusion. Blood work is abnormal, WBC at 150,000, and the peripheral blasts were at 70%, making the diagnosis of acute leukemia. Patient presented with TLS, increase in potassium, creatinine, and phosphorus, with a uric acid of 7.5 and LDH of 3,000. Chest X-ray showed bilateral infiltrate, and CAT scan was negative for bleed. So a bone marrow biopsy showed an AML with monocytic differentiation and normal cytogenetics, and rapid AML mutation panel showed FLT3 and IDH2 mutations. So the best evidence comes from Ratfi trial. This is a randomized phase 3 study, double-blinded, patient with the age of 18 to 60, newly diagnosed, FLT3 mutated, got randomized on induction to 7+3 plus minus midostaurin from day 8 to 21. Midostaurin was also added to the consolidation and the maintenance for a year. And as we can see on the curve on the right side, median overall survival improved from 25 months to close to 75 months when midostaurin was added. Again, remember, those patients underwent transplant, and that's why they have very long median overall survival. And on this little graph under the curves, we could see subgroup analysis, and we can see that patient with ITD or TKD both benefited from the therapy. This is mostly due to the midostaurin being a FLT3 inhibitor. When they looked at the disease status at the time of transplant, CR1 patients showed better benefit to midostaurin versus placebo, while patients with more advanced disease like CR2 plus or active disease, they had no advantage taking midostaurin over placebo. Another study was done with quizartinib, which is another FLT3 inhibitor, and showed similar type of improvement in median overall survival. So this could be an alternative based on availability of drug or based on the financial and the insurance coverage. So just to continue our case, Mr. Ratfi attained a complete remission after induction, and while in consolidation had a relapse disease. Again, the rapid mutation, and I do the rapid mutation panel on each relapse. So sometimes you get to catch a mutation that emerge. So this patient did not have any new mutation, still having FLT3 and IDH2. So what is the recommendation for next? Admire trial is the most recent, actually the second to most. Gilteritinib is considered to be more potent FLT3 inhibitor. Excuse me. It was tested in phase 3 randomized study versus best available salvage therapy. So people got randomized to MEG, FLAG, IDA, and others. A predetermined choice that their doctor had to make. And as shown here, with a single agent oral medication, we show improvement in median overall survival of 5.6 when you get salvage therapy to 9.3 months with a single agent. Patient for sure were allowed to go to transplant if they went to remission. And this is similar molecular or genomic map showing that resistant cases in this study were mostly based on the RAS pathway mutation that we mentioned earlier.
2 minutes. 2 minutes.
Okay. So other medicines we have in Ssbmt, and I will go fast on this because I want to get to this medicine. I'm sorry for the too many slides. Revumenib is a small molecule inhibitor of menin KMT2 interaction and is being investigated in patients with relapse and refractory disease, both for KMT2A and NPM1. There is a promising phase 1 study that shows a good response rate, and based on that, this ongoing study that was presented last ASH called Augment, which led to have patients above the age of 30 days with relapse refractory to receive this drug with primary endpoint response rate. And as we can see from the recent data presented, a median follow-up of 6.1 months. Overall response rate was close to 65%, which is significant for those type of population where they didn't have an option before. But overall, you could look at those confidence intervals, and responses were observed across all major subgroup, regardless of the population. Older and younger kids, benefit the same from this drug. This is the median overall survival. Again, 8 months in a very sick population. This is just for future direction, and I'm going to close by this slide. As we see from this table, multiple studies are ongoing to try to incorporate all those new agents in the upfront line. Mostly either backbone of A7 or 7+3, adding all those targeted therapy, FLT3, MLL, NPM1, IDH, all those mutations. Other approaches that, for example, are being attempted, those patients can get the resistant overcoming drugs as like MCL1, CDK9, and PEM kinase, etc. And lastly, on the last novel targeted, now we have immunotherapy in AML, and those antibodies could be against, for example, CD47 with macrophage activation, CD123, CD117, which is a c-KIT a receptor, and CD17. So more data to come soon, hopefully. Thank you.
Thank you, Dr. Munder. We'll leave questions to the end. So it's my pleasure now to introduce our next speaker, Dr. Scott Howard, who is a Deputy Director at the Julian Hematology Center. He's a Senior Advisor at the Pediatric Cancer and Blood Disorder Center of Armenia. He's also an International Development Officer at San Juan Hospital, Barcelona, Spain. Dr. Howard will discuss with us today the optimal management of ALL with CNS disease and how to harnessing high-dose methotrexate toxicity. Dr. Howard, the floor is yours.
Shukran jazilan for inviting me. I was thinking, if I could have my first slide, please, about my last trip to Saudi Arabia. Here's the program from 2020. And the last day of that meeting was the start of the pandemic, and I was on the last flight that was received into the US before it got closed. So I am so happy to be back. You can imagine, like 4 years, how would you feel like Eid al-Fitr after 4 Ramadans in a row, combined. So I really, really appreciate it. And we have so much to talk about. Look, there you guys are. So sweet. So that's why I'm going to take a lot of pictures today, because what if there's another pandemic tomorrow? You don't know. So how long we're going to go. Meanwhile, I have 2 grandchildren since I saw you last. This is my daughter here in the front, and my son-in-law, and 2-year-old Alina, and 6-month-old Emmett. So lots can happen during one small pandemic, right? So I'm very glad to be back. So I have a question for you guys. What is the most important prognostic factor for anyone with cancer? Age. Oh, therapy. Thank you. Therapy, exactly. And how do I know? I'll show you how I know. There's many ways to know. But this is just acute lymphoblastic leukemia in children. And from the 60s to the 70s to the 80s, you see curve A to curve B to curve C, how things improved greatly decade after decade. And what changed? These were children coming to one hospital, St. Jude Children's Research Hospital in Memphis, Tennessee, where I live right now. And they were the same number of Philadelphia positive, Philadelphia negative, the same CNS positive, CNS negative, same number of teenagers versus younger children versus babies. So every prognostic factor you can think of was the same over the decades. And yet the cure rate went from 10% to 90% over this period. So what changed? It wasn't the patients, it was the treatment. So we don't think about that, because when we think of a prognostic factor, we think of, I'm going to give this patient the best thing I can, and then the prognostic factor is what else is left after I give the best treatment. So we're assuming the best treatment, like Munzer showed. If you're giving azacitidine, your result is worse, right? Because you gave a worse treatment when you could have added some other things to it. So the most important prognostic factor is the treatment. And here's the most recent study that came out of St. Jude that had amazing CNS control. On the bottom, this is CNS relapse. So you can't see that curve because it's like hugging the bottom line, and it's 1.5% incidence of CNS relapse. So my job was to talk about controlling the CNS in ALL, and both children and adults can benefit from this strategy. So this is relevant for all of us, and this is a problem that can be controlled. We can eliminate CNS relapse. So we should never have to have a lecture of how to manage CNS relapse. The answer is, don't let it happen, right? So maybe your colleague could send you the patient, so that's the only way you could have a CNS relapse study. So what happened in St. Jude did some crazy things for this total 16 protocol. 30 weeks of asparaginase. Imagine giving pegasparaginase on week 1, 3, 5, 7 for 30 weeks. So that's pretty rough. And that also is the strategy. We actually copied it from Dana-Farber. So they're giving 30 weeks of asparaginase to people up to age 55 years old. But above 55 is difficult, and even below 55 for people who are obese, which is very common in US, people who drink too much alcohol, which is too common. So there's reasons why you can't get away with this in adults, especially older adults. Luckily, we have Taiwan study. What did Taiwan do for us? They studied not doing the first LP when the patient walks in the door. And everybody knows when a patient walks in the door with new acute leukemia, it's always who's going to do this first lumbar puncture, because they're coagulopathic, they have high white count. If you have a traumatic lumbar puncture, you're introducing leukemia into the spinal fluid. So you really don't want to do an LP on day 1. And if you have to do it, then it should be the most experienced person you can find. I don't mean the oldest, I don't mean the most senior, I mean the most experienced. Sometimes it's a resident, sometimes it's the old guys. At our hospital, it's Dr. Ching Han Pui. He's 68 now, and he still has 0 red cells. Every single time, 0 red cells. Because whenever I have 5 red cells, I used to think, oh, it's just bad luck. Nobody can control 5 red cells. And then I, as a fellow, studied 5,000 lumbar punctures at St. Jude, and his was always 0, 0, 0, 0, because I sorted it by the name of the person who did it, and saw so many zeros, so I thought maybe it's not luck, maybe it's skill, and who knew? So these geniuses in Taiwan, they waited till day 10 of induction therapy, 4-drug induction. So Japanese had studied twice delayed lumbar puncture, day 8. They gave a week of prednisone, and then day 8 did the first lumbar puncture, and it worked great. And what did everybody say to the Japanese? Are you crazy? How will you know if the patient is CNS positive? If you give a week of prednisone, maybe they were CNS 3 when they showed up, but now they're CNS 1 a week later because you sterilized the CSF. Sure enough, they did sterilize the CSF, but the patients didn't relapse. So it looks like we've been doing the wrong thing since childhood, which is to do a lumbar puncture in somebody with active circulating blasts. So in Taiwan, they use the most mild protocol imaginable compared to the St. Jude protocol. And look at their CNS relapse right there, right along the floor. They had 0 isolated CNS relapses, like none, and 2 combined CNS relapses. And for me, if it's combined, it doesn't really matter because the hard part there is the bone marrow, not the CNS. So isolated CNS relapse is really what we're going for, and they managed to eliminate it without 30 weeks of asparaginase. Adults and children, just by delaying the first lumbar puncture and not introducing blasts. So I have 5 messages for you today between this talk and the next talk, two speeches later. And these are 5 things that I hope tonight, if you go see a patient tonight, I hope you won't do a lumbar puncture if they're newly diagnosed. I hope you'll wait till day 8 at least, but really wait till they clear their circulating blasts. So these are things we can do today, right now, without money, without anything. Just read this paper, go watch it on YouTube. Thank you, Ahmed, for this advertisement. I like to listen to Bon Jovi on my way to work, but you know, maybe I could do Bon Jovi on the way and YouTube on the way back, right? Because we can all up our game. And there's a whole hour of lecture about this, so I'm not going to have to go into it because I don't have to, because you can just go there and download the whole thing. And if you want a whole hour about just spinal taps, you could do that. You know, makes a great entertainment on your way back home. So here are 3 curves here, the low curve, the middle curve, and the high curve. So the orange curve is if you inject chemotherapy right into the ventricle, like an Ommaya reservoir. So that's great. You get 100%, you get 100% orange curve because you're putting it right there and then you're measuring it in the same place. So that's 100%. If you do a lumbar puncture and let the patient, after you finish the lumbar puncture, the patient say, go home, have a nice day. They get up and they walk out of there. Only 1% of that lumbar puncture will reach the brain. Why? Because the CNS is made in the brain and diffuses down into the spine. So when we do a lumbar puncture, it's going against the flow. So it's like a salmon swimming upstream, trying to make it to the brain, and the flow is against it. Then if you let the patient stand up, now you've got gravity plus flow, and only 1% reaches. The purple there is if you force the patient to lie flat for 1 hour. So, number 1 thing to remember, no lumbar puncture till day 8 or day 10 or whenever they've cleared their circulating blasts. Number 2, the patient lies flat for 1 hour. It's even better if you can do Trendelenburg. My dream is to have boots where you can hang the patient by their feet. And so you do the lumbar puncture, you hang them, slide them down, take the next one. And they can just sit there for 1 hour. Because what if we could get 30% here, just by gravity? No money, just gravity. Wouldn't it be great if, like, we're doing 20 lumbar punctures in the high-risk ALL, you know, children with high-risk ALL, 20. What if we could do 10 if they just hung like this, and we got twice the value out of each lumbar puncture? Sounds really nice. So here's the bad news. It takes that blue level is the average cytotoxic level needed for acute lymphoblastic leukemia. And when I say average, half the people are above average, half are below average. So half of the leukemia cells require a higher level to kill them, half require a lower level. And so that's what average means, right? So if you say, oh, we're all above average, no, that's not math, right? It's a beautiful idea, but it's not going to happen. So we got to get to that level of 1 in half the patients. We got to get higher in half the patients. How are you going to get higher? So I was very glad to share the car with Ala from Iraq, and he said, hey, we're giving IT and systemic high-dose methotrexate, both. And he gets criticism from his colleagues because they say, no, just pick IT or systemic, one or the other. But it turns out IT almost gets us there, and systemic almost gets us there. Here's the problem with IT. Also, I have conveniently put this pictures and many others into your abstract book, so I'm sorry this book is so heavy. It's my fault. Also, I have to raise my, my flag to Noor because the 400 reminder emails, I appreciated every single one of them to get the abstracts in. Dear colleague, please send it in. If I were sending the 400th reminder, I could not have been like Noor. So I admire, yeah, bravo. So it's a reminder is great, and the character, wow, double benefit. So this is what happens if you just do IT. It doesn't penetrate very deeply. So imagine you have a primary CNS lymphoma. It's a parenchymal disease sitting inside the brain. IT is not going to get there, mostly. So parenchymal lymphoma, that's why we use high-dose methotrexate for primary CNS. It penetrates everywhere. So when you do the two together, it's fantastic. When your colleagues doubt you, doubt your wisdom, they say that guy was crazy, it's okay. Just come here to the high-dose methotrexate Research and Care Network. Every single Monday, 5 p.m. Jeddah time, we're meeting to discuss methotrexate issues. And what's great is this guy, Archie Blyer, he's just turned 81 years old, and he wakes up at 6 a.m. every single Monday to come to this meeting because he lives in Oregon, West Coast. So 6 a.m. for him, 5 p.m. for you. I say he's making the greater sacrifice. So please come. He's half of what I'm about to show you, I learned from him in the past year. There he is in the corner there. See how it's still dark up there in the corner. And he did the phase 1 study of high-dose methotrexate. So he practically invented high-dose methotrexate. And you know how it's nice when you meet a smart person? But sometimes when they're young and smart, it doesn't have the same effect because they're obnoxious. And they lack experience. Imagine you've been smart for 81 years. You know, what that brings to the world, what that brings to your colleagues who show up on Monday at 5 p.m. Jeddah time. And his study, look at this, I don't know if my pointer, here we go. Can you guys see that in the back? This green dot up here? See, they're all just falling asleep. Anyway, there's dose levels here. And look at the top dose level. 88 grams per meter squared over 42 hours. So when we complain, oh, I don't want to give 3.5 grams, I think 1.5 is safer. Back then, they had hair on their chest. Even the women, it was really very, very brave. They went to 88 grams. So you think you're going to see toxic death like crazy. You know what the dose-limiting toxicity was? This was hilarious because you can't get this, you can't read this anywhere. You have to talk to Archie. The dose-limiting toxicity, they didn't reach it. At 88 grams, they ran out of methotrexate in the whole United States. So they couldn't keep going, they couldn't go any higher. They could barely stay at 88 grams because of lack of methotrexate. And there wasn't a DLT sufficient to stop. So we just called it at 88. And so you should go listen to this. He presented this 2 years ago. I probably heard this 5 times using the CAR strategy. So here's what's nice is, here's the steady state on the horizontal is the blood level, the vertical is the CSF level. And notice it's a log scale here, so we're going from 0.1 to 1. So when you go 1 bar up here, it's 10-fold more CNS penetration. And what did I tell you? 1 is what we're going for here, so trying to get above 1. So when we give 2.5 grams IV, high-dose methotrexate, it's right here. When we give 5 grams, it's right here. So a lot of times we're going to be below where we need to be to treat a CNS ALL. So, oh yeah, I always count on not having a pointer. And if you give 33.6 grams, which is the best high dose for CNS, then you actually get a level of 36 micromolar in the CSF. A level of 1 is good. A level of 36, trust me, this will kill every leukemia very, very well. How do I know? Archie Blyer, they did a randomized trial, 33 grams versus 8 grams in newly diagnosed children with ALL. And what did they learn? They learned a lot. Basically, the event-free survival was the same. And back in the day, so imagine this, you can give 8 grams of high dose plus IT plus CNS radiation, or 33 grams of high dose. Equal results. Back then, radiation was cheap and IT was cheap. Now we do IT under general anesthesia, so it's a real pain in the neck. And radiation is horribly expensive, and now we know the late effects of radiation are terrible in children. They're not that great in adults when you radiate the brain, whole brain radiation. So back in the day, they said, well, 8 grams is cheaper than 33 grams, so we prefer 8 grams. So 33 grams of methotrexate was left behind for financial reasons. And every single financial reason is reversed now. But it's not coming back. Why is it not coming back? Because none of us knew about it, right? Who knew about 33 grams? Who did not know? I have to assess the comatose rate here. Okay, you guys, how are you doing back there? You didn't know. I know you didn't know. None of us knew, right? I read a lot about high-dose methotrexate. I go every Monday to a whole meeting just about this one medicine. I didn't know till last year when Archie presented it. But 33 grams in patients who had had like 5 relapses. So here's a relapse study of ALL. 4th, 5th, 6th relapse. Every patient had cranioradiation. Every patient had dozens, some had hundreds of IT therapy. High-dose methotrexate, high-dose cytarabine, everything. So what did they do to these poor 20 patients? Not poor. They were poor patients before they got to this study. They got 33 grams, And here's the CSF white count here, anywhere from 10, 50, 100, here's a 10,000. So the highest one was like 5,000, 2,000, 1,000. These were bad, bad relapses. Their whole brain was caked with leptomeningeal disease, spinal fluid, rich in leukemic blasts. They got 33 grams, and that's before, and that green circle down there is after one course, 12 patients had a CR. One course. So then you think, you know, we always talk about, oh, I'll give IT thiotepa, I'll try every kind of trick. It turns out we had the answer right here in our hands from 1987 is when they published this. So who goes back to read 1987, right? Even the YouTube doesn't go back that far, right? So you got to actually open a journal and read it. Not going to happen. Luckily, JCO 2006 published the long-term effects of this study, and it turns out the kids who got 33 grams, the ones in the red box, had better brain function, better school performance, better everything related to the CNS. So it looks like 33 grams is not only equally effective, it's less toxic, long-term and short-term. So what's the most important prognostic factor? You guys nailed it from the start, treatment. And here's something about treatment that is new data. So remember, you're going to have to remember 5 things. And somebody told me you can't remember 3 things, so you've got to stick to 2. You were going to stretch your brain today. So number 1, no lumbar puncture on day 1. Number 2, lumbar puncture day 10, day 15, doesn't matter, just not day 1. Number 2, anybody? Thank goodness, thank you. Trendelenburg, or if you can hang them up, you know, be great. Number 3, urine alkalinization. And so here's a kidney on high-dose methotrexate. You got to be careful because you see the yellow there, yellow. All the yellow is not supposed to be there. That's crystallized methotrexate. So you do not want to diagnose acute kidney injury by autopsy, right? This is terrible way. It's very sensitive, very specific, but not recommended for diagnosis. Luckily, this was an animal study. So this is the kidney of an animal, and we were intentionally causing kidney failure in these animals. So in humans, though, we learned that one way to prevent this problem is to know when they have delayed elimination. So in green here is the 95% confidence interval. The black line is the median, so half are above it, half are below it. That's what the median is. And the green is the 95% of what's normal. So if you see your patient in the blue here, this is free, resonancehealth.org, which is my organization. So everything I tell you is going to be free. If you see Resonance, you know it's free, so you should be using it for your patient. So you just type in your methotrexate levels, and it tells you if it's above 2 standard deviations. So the red line on top is 2 standard deviations. So that's intervention territory. So don't let a patient slip by because none of us with our brain can calculate 2 standard deviations because you have to feed in the age, the creatinine, all the details of the patient, the dose, the infusion schedule. And then we measured acute kidney injury. I'm going to go back here for the photo. Go ahead. Good. And it turns out, look at the bottom, courses with bad urine pH, double the rate of acute kidney injury if the pH dropped below 7 at any point in the first 24 hours. So I thought it was bad when we saw, oh, the pH is 6, give them some bicarb. I didn't know it was really bad, really bad. So doubling the rate of AKI, that's bad. And I want to remind you of one thing that makes the urine acidic, and that is cola beverages. So I was just in Jordan. After 4 years of not coming here, I got to go to Medina last week and had a 2-day break in Jordan and then came back. So in Jordan, it was great because you go to the restaurant and my friend drinks a lot of Coke. So he asked for a Coke. They say no. He says Pepsi. No. Because of Palestine, no Jordanian will drink an American beverage. So I like that. Luckily, there's an Iraqi cola. So thank you, because he could still have his unhealthy sugar. But please, if your patient is on methotrexate, they should neither drink Coke, nor Pepsi, nor Iraqi cola, nor any brown cola. Why? Because the pH of those colas is 2.5. The stomach is like 1 or 2. So the pH is supremely acidic. And in Egypt, they published this a case report where they showed each time the patient was drinking a cola, they had to give bicarb bolus to make up for it. So please just take away the cola and don't try to bicarb your way through it because it's ridiculous. So the patient can drink water, milk, yogurt beverages. There's so many things they can drink, but colas, no. And certain juices, apple juice, 2.7 or something like that. pH of less than 3, apple juice, orange juice. So it's surprising. So watch the drinks. Water is great. Urine pH of 5 versus 6 versus 7. The green box is how much acid. So remember, pH is a log scale, so when your pH drops from 7 to 6, you have 10 times more acid. From 6 to 5, 10 times more acid. So a pH of 5 is an absolute disaster in high-dose methotrexate. But a pH of 6 is also really bad, doubles the risk of acute kidney injury. Doubles. So the third thing to remember, no Coke, and keep the urine alkaline. So now we have to modify. It's not just treatment, it's treatment and supportive care. And so I got to wrap up here, and so the last two things are in the next lecture. But you don't have to worry. I used to worry so much, try to put in 400 slides and talk in 20 minutes, 400 slides. No, just click on resonancelehealth.org/networks, and you can see a lecture like this or better. It'll be by Archie, by really, really good people. So I want to emphasize also this mtxpk.org, because you can actually go there and find out who needs a special intervention. And I'm going to skip to the special intervention since I heard that glucarpidase is now approved in the kingdom. So congratulations on that. How are you going to use your glucarpidase? I'll show you here. And these slides are available so you can download them, but that's why I don't feel like I have to even talk about them. No time. So here is a patient getting high dose who needs glucarpidase. And in the red is every screw up that happened to these patients. Either they didn't get enough fluids, or they didn't get enough leucovorin, or they didn't get glucarpidase on time. And if you're in the red, 3 strikes, 5 out of the 7 patients died who had 3 strikes. It was basically bicarb, leucovorin, and glucarpidase were the 3 strikes. So when you're using glucarpidase, I want you to actually read this paper, but half of it no longer applies. This paper is only 10 years old, and already I have to renounce it. Which is sad, because you spend a lot of time writing these things and then to renounce it 10 years later. Glucarpidase will take that methotrexate level down in 5, 10, 15 minutes. So if your methotrexate level is too high, you give 1 dose of glucarpidase, it will go to 0. Just like resburicase for uric acid, same thing. And there's the glucarpidase out there chopping the methotrexate. But after you chop the methotrexate goes down in the blood. In the blood. It's still in the cell. So after you finish, you got to give a bunch of leucovorin. See all the purple down there? That's leucovorin, leucovorin, leucovorin. So first you get rid of the methotrexate from the blood. Then you give leucovorin to rescue the cell. But leucovorin enters the cell by the same transporter is for leucovorin and methotrexate. And we're out of here. So have a nice day.
Thank you. Thank you very much, Dr. Hayward. It was actually a great talk. So our next speaker is actually a friend of the show, a dear colleague, Dr. Murtada Khabouri. He's an associate professor at the Sultan Qaboos University. He came all the way from beautiful Muscat. So Dr. Khabouri is going to be kind today to talk to us about how do we manage, or how do we actually improve outcome in ALL patients, and how do we minimize toxicity. So Murtada, the floor is yours.
Thank you, Dr. Ghazi, for the nice introduction, and thanks, Dr. Ahmed and the organizing committee for the invitation. In 4 years, I will not have more grandchildren. So what I'll try to cover in this 25 minutes are the following. I'll talk about rituximab in newly diagnosed pH-negative ALL. I'll talk about newly diagnosed pH-negative ALL and where novel therapy plays a role. Older patients with pH-negative ALL and pH-positive ALL, where novel therapy plays the role there. And I will focus on the upfront therapy. So rituximab, although rituximab is not novel, but it's an important, and there are some few learning points by discussing the data. This is the study that probably most of us would know. The question of that study, if you add rituximab to CD20 positive ALL at 20% on flow, whether this would have an impact on the event-free survival or the overall survival. So that platform is similar to the UCAL. What they did, they add 2 rituximab infusions with every intensive block of the protocol, and few in the maintenance, for a total of about 16 to 18 cycles of rituximab or infusions of rituximab. And look at the results. So the first result is that the rituximab group had a better event-free survival. The event-free survival was improved from 43 to 55%, which was statistically significant. If you look at the relapse rate, this is the relapse. So the relapse has decreased by adding rituximab from 41% to 25%, which is again was statistically significant. And that reduction in relapse and improvement in event-free survival led to numerically, at least in that study, where the survival has improved from 50% to 61% in that study. Now, the p-value is 0.1, which means it's not statistically significant. So whether this is unpowered but the trend is clearly there. So that was the first study, and most of us adopted adding rituximab. Now, how many infusions? That's the question. Now, if you look at the other study that investigated the addition of rituximab to the regimen is the UCAL14. And what UCAL14 did is adding only 4 doses of rituximab, 4 weekly doses of rituximab during the induction period. This was a very big study, over 800 patients. So if the GRAL study missed the overall survival because of unpower, you should see it here. And the results, unfortunately, the event-free survival, although numerically was better in the rituximab group, the difference was not statistically significant. If you look at the hazard ratio, it's about 0.88, so that means 12% reduction in the events. And so it was, the conclusion, it was not statistically significant. However, when you look at the group that underwent myeloablative stem cell transplant, you see that the rituximab group did better compared to the standard of care group. And the effect size is hazard ratio of 0.47. So at least 50% reduction in the risk of, in the probability of events if you add rituximab. And to add to it, if you look, these are not a randomized comparison, these are subgroup analysis. And the rituximab group was prognostically worse than the standard of care. So that group was supposed to do worse. So the conclusion here, if you use rituximab, use 16 to 18 doses, especially in those who have higher risk disease that you plan to send for transplant. So that's the rituximab messages. The second is the newly diagnosed pH negative ALL in all age groups. So that study, the E1910 study, it asked that question, whether you consolidate with novel therapy versus if you consolidate with a standard chemo. So the study included pH negative patients who had a BFM induction followed by intensification. And after intensification, the stratification here is by the MRD. So if it was MRD positive, because now it's standard of care that you give blinatumomab for the MRD positive, these were removed later, and they randomized patients who are MRD negative. They were randomized to consolidation with blinatumomab versus standard chemotherapy. And the consolidation of blinatumomab, they had like 4 cycles of blinatumomab. They started with 2 cycles, then 2 cycles of blina, 3 cycles of chemo, 1 cycle of plasma, 1 cycle of chemo, and then 1 cycle of blina. So a total of 4 doses of blinatumomab. And then the maintenance is a standard POMP maintenance. So now with adding blina to the consolidation therapy would make an impact or not. And these are the results. The CR rate overall was 81%, and most of this overall CR is in complete CR, is 75%. If you look at the MRD after intensification, 78% achieved MRD negative, even before receiving the blinatumomab. So those were randomized with the blina consolidation. And you look at the results. So these are, again, baseline characteristics. Almost 20% of patients in each group underwent bone marrow transplant. Results, This is the top curve is the curve with blinatumomab consolidation, and the lower curve is chemotherapy. It's clearly separating early and significant, clinically significant separation. If you look at the overall survival at 3.6 years, it was 83% for the blina consolidation versus 65% for the chemotherapy consolidation. And if you look at the hazard ratio, is 0.4, almost 60% reduction in death if you add blinatumomab to the group, if you consolidate with blinatumomab. So that's, I think one of the major things in the management of patients with pH-negative ALL. Now, the second question is, okay, go to MD Anderson where what they did, they looked at the addition of blinatumomab to the hyper-CVAD protocol. And what they did, after some time, they amended it with adding inotuzumab. So the question is now, you try to, beside the standard chemo, adding blina and adding inotuzumab. So they give 4 alternating cycles of chemo, and then they added 2 inotuzumab cycles in the 2 cycles of the chemotherapy, 4 cycles of blinatumomab. Again, they added 2 cycles of inotuzumab here. And during the pump maintenance, they gave 3 cycles of blinatumomab, a lot of blinatumomab. And what they did now is to compare the cohort that received hyper-CVAD blina versus the later cohort that received hyper-CVAD, blinatumomab, and inotuzumab. And these are the results. Now, this is not randomized clinical trial, 2 cohorts, and there are significant baseline differences, clinically significant baseline differences between the 2 groups. This is the group that received the hyper-CVAD and blina, and the last one is the hyper-CVAD, blina, inotuzumab. Age, older in the blina group. If you look at the prognostic impact, TP53 mutation were higher in this group. CRLF2 were higher also in this group, and bad cytogenetics were also higher in the hyper-CVAD blina group. Look at the result. The rate of CR, almost 80 to 90% in all groups. So again, very high rate of CR. And then when you look at the MRD, you look at the MRD by flow, 97% in the hyper-CVAD, blina, 88% in the hyper-CVAD, blina, inotuzumab combination. So you don't see like a big difference. Actually, you see like this is lower than this. But if you look at the NGS MRD negativity, you see that patients had higher MRD negativity rate if you do it by the NGS versus 50%, so 72% versus 50%. So that conclude maybe now adding INO, blina to hyper-CVAD does improve the rate of negativity. That's probably because of maybe non-specific positivities in the flow, but that's one of the explanation for that discrepancy. We know that this is true, that the MRD is negative by looking at the clinical outcomes. So if you look at the clinical outcomes and you look at the relapse-free survival, you see that the group that got the 3 had numerically better than the group that had the 2, although it was not statistically significant, but it is 92% versus 76%. If you look at the overall survival, it was statistically significant. So 100% of patients who got the 3 had overall survival, but the probability was 84% for the group that got the hyper-CVAD blina. So maybe if you add now inotuzumab to hyper-CVAD blina, if you use hyper-CVAD blina, it does improve the survival in this group. Now we shift to the older patients with pH-negative ALL. This is a protocol that we heavily use in relapse refractory ALL, and I think many of us are using here. This is mini hyper-CVAD, the CVD with the addition of the inotuzumab after capping the inotuzumab to 2.7. But this now take it from the relapse refractory and give it to the older patients who are pH-negative ALL. And these are the results. The overall response rate is 98% and the CR is 85%. Again, high numbers, consistent with the previous novel incorporation of novel therapy in the management. The rate of VOD was 8%, which is not a small rate. Actually, 2 of the fatal cases were in the INO group, but the group that got the higher dose of inotuzumab before capping it to 2.7. And these are the outcomes. This is the 2 curves of overall survival and event-free survival. And if you can, if you see that the median progression-free survival was 35 months, and if you look at the numbers, let's say at 3 years, it's about 50 to 60% overall survival, event-free survival. So historically, this group did really that way, which is historically it was much worse than these numbers. Although these numbers are still in the 50s, 60, but they're way better than the historic data in that age group. So maybe now if you apply this, if you take it from relapsed refractory for older patients, that's one of the way that incorporation of novel therapy improves outcomes. The other approach is, okay, we should not depend on chemo, we just on novel therapies. And that study examines that approach, combination of inotuzumab with blinatumomab. So pH negative in older pH negative ALL patients, induction with inotuzumab at a dose of 1.8. And then if they are in CR, you add another cycle of inotuzumab at a smaller dose. And then you give 2 more cycles of blinatumomab. Now, if they are not in CR, they would not give a second cycle of INO, and they would go to blina and add 1 more cycle. So they would give 3 cycles of blinatumomab. And because of these medications they don't cross the blood-brain barrier, and they incorporated 8 cycles of IT, so you don't need to use the 33 grams of methotrexate. So these are the responses. The CR rates, composite CR 85 after inotuzumab induction and 97% after INO-blina. This is only novel therapies, INO-blina. And if you look at the overall survival, at least now, 1-year overall survival and event-free survival in the range of 75 and 85%, which is very good. Although when you look at the curves continue to go down. So maybe, again, it's not curative, but at least the effect of toxicity and the 1 year, so far 1 year event-free survival and overall survival are reasonable for that age group. So that's the combination. The last thing I'll speak about is the pH positive ALL. And the first thing I'll start is with the maybe time sequence. So forgetting about the traditional way of treating pH positive ALL, standard chemo protocol and adding tyrosine kinase inhibitor, this study, called total therapy sequential strategy, the initial Italian approach, what they did, they took the pH positive ALL patients and they induced them with dasatinib steroids. The steroids were started pre-phase and then continued for about 4 weeks. And then the dasatinib was given at 140 milligram per day for a total of 3 months, about 12 weeks. The post-induction, then this is where they gave the chemotherapy. So they continued dasatinib and 2 cycles of consolidation using clofarabine and cyclophosphamide. 5 days for the first cycle, and then 3 days for the second cycle. And they continued using the dasatinib. By the end of the induction, the complete hematological response was 97%. And if you look at the disease-free survival and the overall survival for this group, around 50% at long-term follow-up. At 5 years, 47%. So again, reasonable numbers for taking the induction mortality. One of the things that we clearly felt after we adopted this in Oman, that induction mortality has significantly decreased for the pH positive ALL. Now, a further improvement to this is the dasatinib-blina approach, the D-ALBA. So what they did in that study, they used the same induction, dasatinib steroids, but instead of the chemo consolidation, they give Blina consolidation. So they gave maximum of 4 or 5 cycles of the blinatumomab, of course, with the dasatinib. Now, look at the responses, the overall molecular responses. So the responses improved from 17% at day 22 to almost 80% after the 4th cycle of blinatumomab. And this 81%, if you look at the complete molecular response, it's almost 50%. And when you look at the clinical outcomes in terms of the overall survival and disease-free survival, the numbers were very good. Again, relatively short follow-up at 14.3 months, median follow-up, 95% overall survival, and 90% disease-free survival. So again, incorporation of blinatumomab consolidation has a major impact on the outcomes here. Now, the next maybe improvement is to use a stronger tyrosine kinase inhibitor, ponatinib, and instead of using steroids with the induction, you use the blinatumomab with the induction. So in that study, they gave ponatinib at 30 milligram combined with blinatumomab as induction. And then the consolidation part was ponatinib 30 reduced to 50 if complete molecular response was achieved, and completing the blinatumomab. And then maintenance with only ponatinib at 30 or 15 milligram. Results, again, ITs, 12 to 15 ITs were incorporated into the results, into the protocol. CR/CRI rates, 98%, very good. Complete molecular response, 84%. And if you look at the overall survival and event-free survival at 2 years, almost 90% overall survival and 80% event-free survival. So relatively higher rates of survival. So at the end, in summary, patients, rituximab improves event-free survival, especially when given in 16 to 18 doses, and in patients undergoing hematopoietic stem cell transplants. Consolidation with blinatumomab improves overall survival in newly diagnosed Ph-negative ALL. Chemo-blina-INO combination decreases relapse and improves overall survival in newly diagnosed Ph-negative ALL. Chemo-free approach, INO-blina, gives higher rates of CRs and reasonable 1-year event-free survival and overall survival in older patients with Ph-negative ALL. And TKI-blina in Ph-positive ALL results in high rates of remission and long-term disease-free survival and overall survival. And with that, I would like to thank you for listening.
Thank you, Dr. Murtada. It's my pleasure to welcome Dr. Howard again in his second talk. So Dr. Howard now will discuss the integrated information systems to support patient care and research. Dr. Howard, the floor is yours.
Thank you for having me back. I love this idea of continuous information collection and continuous adapting. So you saw the last slide, which was 62 patients who, had this event-free survival, spectacular. MD Anderson is amazing to me. And on our Friday meeting, for example, at 5 p.m. Jeddah time, frequently we have MD Anderson speakers because they're so innovative and so creative. What I want to talk about now is how you can have an information system so that you can early detect problems. And actually, one of our MD Anderson colleagues presented 2 weeks ago, and he said, basically, when we first implemented chemo-free, we had too many CNS relapses. We were doing 8 ITs. And so they recognize this. How did they recognize this? Because they were publishing the paper. So as they're writing for JCO, they say, oh, too many CNS relapse. So then they say, we're going to modify. Then the next one, New England Journal, okay, we're going to modify. So you saw 12 to 15 there. And so you think, yeah, we got to prevent the CNS relapse. So chemo-free, if you use blina-INO, it doesn't get to the CNS. So what are you going to do? You better put something in the CNS, otherwise you have CNS relapse. You might have spectacular bone marrow control, but with CNS relapse. And I wonder if you guys noticed on the last slide, 3 out of 62 had a CNS relapse. So it looks like 12 to 15 may not be enough to prevent CNS relapse, and maybe it needs to be 18, or maybe they need to give, a little micro CVAD or something to make sure to get that to 0. Because 3 out of 62, you think, oh, it's only 3 patients. But remember, the whole thing is only 62 patients, so that's 5%. And you can say, well, 5%, it's not statistically simple, blah, blah, blah. Anyway, 3 is too many, right? It should be 0 out of 62, or maybe half of 1 out of 62, ideally. So I'm going to talk about these 4 things, the importance of integration, and 3 examples. So first of all, the importance, this is obvious, right? Life is short. You don't want to be typing the same information 5 places. You don't want to be clicking into 5 computers, one to see your x-rays, one to see your lab, one to see the note, one to see, the WhatsApp message. And our human attention span is also very short. So if I have to spend 30 minutes just collecting the information, maybe I'm going to cut some corners. And have you ever had it where the resident is presenting the patient and they say all this crazy stuff, and then you realize they didn't have time to actually check everything, and so they just started, doing it too fast. The third thing, resources are limited. Even when resources are abundant, they're not infinite. And human resources are always limited, right? Also, it's just cruel to make a human type one thing from one place to another. And automation reduces errors. So here's an example. Let's suppose you were doing a clinical trial. You had to collect all the purple data. And you're doing a cancer registry where you have to collect all the orange data. And you're doing an antimicrobial resistance project with your infectious disease colleagues, the green one. So now you have a purple project, an orange project, and a green project. And the types of data, though, are the same for all 3 projects. There's the demographics, and there's, some diagnosis information and toxicities and outcomes and so on. And you shouldn't have to type the demographics 3 times. You should type it 1 time. So on the far right there is an integrated information system. You do all 3 projects, and if the first person shows up as the clinical trial person, they put in all the purple, you're done. The next one could just put in a little bit of orange about the microbiology data, and maybe the green one. And the cancer registry person might put the laterality or something that is important for registries, but that we don't really care if it's right or left, for a lot of clinical reasons. So between the 3 groups, for me, it's really sad when you visit a hospital, like every single hospital on the planet, and then you say, oh, that's our cancer registry. These 3 people here typing the registry. That's our clinical trials office. These 5 people here typing the clinical trials. Oh, that's the resident doing a special project typing in all the infectious data. All of these people are duplicating their work, and it's a shame. So what about Saphos ALL Genomics? This is a terrific project that started in 2021, and of course it was overlapping with the pandemic, but I admire you guys for getting it done. And here's the integrated information system. And what does it integrate? In this case, it integrates genomes that were collected as part of the project on Saudi children with ALL and clinical data. And which clinical data? The blood counts all through the first year of maintenance therapy. And why the blood counts? Because you want the blood counts to know if there's a genomic predictor of bad tolerance of mercaptopurine maintenance or methotrexate maintenance. So now imagine you have 50 blood counts once a week for 50 weeks, and you've got to type that into some computer. Then you've got to do some math to see if it was too low or too high. You need an integrated information system, right? Because that's cruel to make people do that. Now, they did it, and they got it done, and the results are really going to be interesting. But you want something that will integrate the genomics and the lab data and the clinical data. How often they got admitted for febrile neutropenia? How many got septic? Did anyone die of sepsis? If there's even 1 death, that's 1 too many. So integrated information system could save a lot of typing. And what I love about certain information systems, like the one offered by Resonance for free, is you see how it automatically de-identifies the data here. You see this name, Roba Azab, that's the data entry person. That's not the patient. So it doesn't anonymize the personnel. You want to know who did the data, the entry, but it anonymizes the patient. So you can have 8 centers in Saudi Arabia, and the study coordinator doesn't need to see personal information. They have a study number, so they can always do their audit based on the study number. So this idea, because sometimes people say, I don't want to use an information system. I have Excel, and I love Excel. I also love Excel. It's so useful. It's so great. And half the time, which is why I insisted that this thing would export to Excel. Just click that button, and now you have Excel. But when it exports to Excel, of course, it anonymizes the data on the way out. And why does it do that? Because imagine you have Excel, you have 500 patients, and you have all their names and their birthday and where they live, and then you lose your laptop on the metro. And I know you lose your laptop on the metro, and I try not to lose mine, but when I was medical information officer at St. Jude, somebody did lose their laptop on the metro. And then they confessed, oh, I had 2,000 patients in an Excel sheet. And as a medical information officer, you have to lead this thing called the privacy investigation. And the privacy investigation, you also have to notify all 2,000 patients. And, it's hard to find 2,000 patients. And if you don't notify 97% or more, you have to publish in the major newspapers of the 50 largest cities where your patients are treated that we've had a violation of privacy, and we're happy to buy you special privacy protections and all this data protection as a service to the people whose privacy we violated. So imagine you're St. Jude. You raise $1 billion a year in philanthropy from very kind people who want to support your hospital. And now the top 50 newspapers say how we don't respect the privacy of the patients that you paid for with your philanthropy. So it's bad. Anyway, I had to call Puerto Rico and talk to the neighbor of the last patient to get to 97%. So that's why it was fresh in my mind, even though it's been 15 years now. So no laptop should have private data. One way to prevent that is you don't let people download it by policy, but also by software. Because policy will only get you so far. There's always somebody who has a temporary lapse in judgment. And when it's a resident, I sympathize because they're sleep deprived, and sleep is part of judgment, is having good sleep. So it's understandable there would be mistakes. So we have to prevent the mistakes through systems and through policy. So here we see on the bottom the mercaptopurine, the methotrexate, every dose, the prescribed dose and the dose taken, and the CBC that goes with it, the blood count that goes with it. So what are the next steps? The next steps are to actually analyze the data and then decide, should every patient get genomic data to predict their problems with maintenance therapy? And I ask you, should every patient have a whole genome sequence to predict toxicities of their therapy? Too expensive, right? Well, let's do multiple choice. Yes or no? And then we'll do reasons. So who says yes, do it on everybody? Who says no, don't do it on everybody? Who says do it on some people? Okay, if you can't get everybody, I like you raising your hand twice. If you can't do all, do some. And you say no because too expensive? I agree. However, the price, well, no, I don't agree. I don't know. How are you going to know? That's why you guys did the study. So hats off to Sappho's for doing the work. We'll know maybe by next year, we'll know what to do. And if it's useful, the one thing we can't do though, is make it standard practice and have it sit in a database. Because if it's going to be standard practice, it better affect the patient's care day by day, right? It better be telling us information that we use to save that person's life. Then we'll be enthusiastic about spending the money if we have to, but not before. So they'll tell us whether we should be doing it in every patient. But if we do it, we need to act on the results, which means we need an integrated information system. And finally, so if you said yes, it has to be integrated. So antimicrobial resistance, and this is, it's always fun when other people get into your own area. So the infectious disease people teamed up with the oncology people and had this summit where they were talking about antimicrobial resistance as it affects cancer patients, because it affects everybody, but it especially affects our patients. And so this was a chance to highlight a way to integrate the information system. So now imagine you're the microbiology person, and your job is every year you're supposed to make your antimicrobiogram. And what is the antimicrobiogram? This says every time we grow E. coli out of somebody's blood, what's the chance it's sensitive to cefepime or ceftriaxone or Ceftra or whatever else. And so somebody has to go all through the culture files and all through the bacteria and find those bacteria and find what they were sensitive to and put it into a system. But really, we've already put it into a system called the chart. And the patient's chart has the organism, and it has where the organism came from, blood, urine, spinal fluid, and it has the sensitivities. So you're trying to produce this, and you already have the data sitting in the medical record. So I've been doing a non-scientific survey of the poor people who have to make the antimicrobiogram. And my first question is, how often do you have to update it? And the answer is always the same, every 2 years. So every hospital follows this is a global guideline. Every 2 years you're supposed to update this because it changes. And then the next question is, how often do you actually update it? Guess what? And then usually they say, oh yeah, we follow every 2 years. And I say, oh, when's the last update? Let's find the one you use now. Inevitably, the date on that thing, if you take today's date and minus that date, it's always more than 2 years. Sometimes it's 10 years since it's been updated. Why? It's a lot of work, a lot of work. And so what happens if instead you have an integrated information system where the cultures are sitting right there, but they feed automatically, and it turns out the R statistical language has built in already a package. We didn't even make this package. We downloaded R. R is free. Our software is free. It's all open source. So you just put R into our software, and if you type your culture results, which you're typing in there anyway for your patient, or if you integrate with your medical record, the culture results automatically generate the antimicrobiogram. Even more important, it enables innovation. What kind of innovation? Have you ever looked at your antimicrobiogram and then you say, but wait a minute, this is an AML patient. They've been pancytopenic for 8 weeks. They're on prophylactic levofloxacin and Vori. Do you think the resistance of their bacteria will be the same as a 5-year-old who just got diagnosed with a Wilms tumor? Totally different. That patient's never been admitted, never is going to be admitted, except for one short surgery. So you want to know your antimicrobiogram. Wouldn't it be nice to say, only show me if it's an ICU patient? Well, that's the beauty of an information system. You say, do it just for ICU. All those colors, they'll change because they get a lot more red, unfortunately. There's a lot more resistance in the ICU. Or only show me AML, or only show me patients who have been admitted in the last 90 days. So you can have a patient-specific antimicrobiogram. Talk about precision medicine. You can even have precision microbiology, right, based on that patient's characteristics. And it's like click of a button. So information systems with automation is the beautiful thing on the right-hand side. I have personally applied this to high-dose methotrexate. So I get to do the last 2 points, right? First lumbar puncture, never on day 1. Lie flat for at least an hour. Number 3, if you have refractory CNS, number 3 is bicarb. Number 4, I know we're going to prevent all the CNS relapse, but if we don't, and if the patient's multiply relapsed in the CNS, and if you're about to go explain what is hospice and palliative care, that's the patient who needs 33 grams of high-dose methotrexate right now today. And this was done in the 80s before we had glucarpidase. Now we have glucarpidase. That we had no backdoor, nothing, just fluids, bicarb, leucovorin. Now we have that plus glucarpidase, which is quite magical at getting rid of methotrexate. So I'm not saying to do this front line, definitely not saying that, but I am saying you can't palliate CNS, progressive CNS leukemia or lymphoma. These patients die in horrible pain. And you've all, if anybody who's treated even one, you remember it like it was yesterday, because they're usually screaming and screaming and screaming, and you give morphine and they scream, and you give everything and they scream, and you finally give propofol drip and they go unconscious. But even unconscious, sometimes you see their face twitching, groaning, even unconscious. So for me, I would rather die of anything than that. And what if instead you could not die and have a CR after 1 cycle? So that's the 4th point, which is if your current strategy is terrible, that's the time to pull out an old strategy from the 80s that worked great in the 80s, should work today. And we're going to do it even safer, though, because now we have tools, integrated tools like mtxpq.org, which we integrated into our technology platform, which is called the Resonance Patient Center. So the same thing that's doing genomes and maintenance therapy and the antimicrobiogram is also doing your high-dose methotrexate, calculating this curve, not based on any patient, based on your patient. Your 72-year-old with a creatinine of 1.1 who's male, who got 5 grams over 4 hours. That's what that curve is. If it's a 20-year-old with a creatinine of 0.8 who got 4 grams over 10 hours, it'll be a different curve. But it doesn't matter because you just type in the information and you get what you need. If you see blue, that's a glucarpidase and fluids candidate. And the other thing is we built in here recommendations. So these are recommendations based on the global standard. But nobody likes the global standard, right? You need a hospital policy for your hospital. And many countries don't have glucarpidase. So Iraq, for example, no glucarpidase. So do you want to recommend glucarpidase to people who can't use it? I think it's mean and stupid. You want to recommend the best thing, alternative to glucarpidase. Remember, back in the 80s, we had no glucarpidase. We cured a lot of people and saved a lot of kidneys with IV fluids, leucovorin, and bicarb. So The recommendation here, if you make your own hospital recommendation, it overrides the global one. So nobody's going to force you to see a recommendation that you didn't already approve. If you just do nothing, you'll see this, because this is what the Monday team, the Methotrexate Research and Care Network, developed. So the fifth thing to remember is early clearance. And this early clearance here, you see that blue curve dropping like it should versus the red curve, almost horizontal. We found in our animal model that every single animal who had this bad curve at the first 4 hours, so this, you do the infusion, then you measure the level of methotrexate at the end of the infusion, and 4 hours later. This is pure renal elimination during that very early phase. And the half-life of methotrexate is 1.3 hours. So 3 half-lives is 4 hours. So in 4 hours, it should be half, 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 1/8, about 10% of the level after 4 hours. So if it drops like the blue, that's a 90% drop. That's what it's supposed to do. That means you have normal renal function. This is like a GFR measurement, essentially. It's a perfect surrogate for GFR in that very early period. When the curve is flattening out, that's some biliary excretion, some third compartments, complicated PK. That's not pure GFR, but the early part is pure GFR. So if you see that red line, what that means is you already have acute kidney injury. The creatinine hasn't gone up yet, so you can't diagnose the acute kidney injury, but the nephrons have been damaged. There's methotrexate crystals in the urine, in the nephrons, and the nephrons have been damaged. And you know, because otherwise the methotrexate would be clearing like it's supposed to. Instead, it's not clearing, so you've diagnosed acute kidney injury now before the creatinine's changed at all. And so we named this thing the early clearance biomarker, because every other biomarker to predict methotrexate delayed elimination failed. That didn't fail. You can predict, you say, oh, it's more likely if you're on omeprazole. It's more likely if you're on a TKI. It's more likely if you're old. It's more likely if you got a higher dose. Sure, all of those are more likely, but none of those give you a yes or a no. They give you like a shades of gray. This one's a little more gray, a little less gray. But the really less gray could still have acute kidney injury. So this actually early biomarker is nearly perfect. And the receiver operator curve looks like that. So people who like receiver operator curves, you would be happy, but I don't like them. So we use this PK model for each patient, one by one, just like the patient-specific antimicrobiogram, just like the patient-specific genomic predictor of maintenance therapy. And it tells you if this early thing is delayed, but you have to measure those 2 early levels. So the fifth thing I want you to do, starting today, is after the infusion, measure a level at the end, and measure a level 4 hours later. You feed it in, you calculate the slope. If that slope is not good, then increase the fluids always, and make sure about the bicarb and the urine pH. Consider glucarpidase. Not all of these should get glucarpidase. You can measure another level 12 hours later and then decide, because you don't give glucarpidase that early. Oh yeah, there is the ROC curve. So also, it's fun to treat the patient really well. It's twice as fun to join our research protocol, our global high-dose methotrexate quality improvement program. And these 2 extra levels are, I consider them a study test if you're doing it on a study. I consider it a clinical test if you're not part of the study. You can still act on it to save your patient's kidney, but I would rather you be part of the study, because then also all of us together, many brains are much better than just one brain, so we can all help each patient. So those 4 extra, 3 of those are study levels. This is an unfunded study, so bring love, because all you're going to get back is love, not money. There's the early clearance biomarker. So this is some preliminary data from 2 centers in Spain. We need more data, and we need better data. So there's a subtitle. Look at that, on time and on budget. And I want to finish with this one last thing. Integrated information systems are great, but integrated human systems are more important, right? If we're here together not to see some slideshow, we can see this on YouTube and should see it on YouTube. We're here together to make sure we know each other and can join protocols together, do projects together, treat patients together, come online together on Mondays and Fridays at 5 p.m. and really up our game every single day, every single week, not once a year, not once every 6 months, but integrated human systems are phenomenal. So I was so happy to come back here, and I expected to see these 3 guys, and this restaurant, it's the best samak I've ever had in my life, like unbelievable. Fresh, jumping from the river right into the restaurant. And I expected to see this guy, But I got some good surprises, and I got to meet his family, which I've never met before, even though we've known each other for 15, 20 years. And also got to meet this guy from Iraq, who we were on the same flight together, and we didn't meet on the flight, we met in the car. So I think whenever you're at a meeting, the bus rides to the dinner and the car rides, probably the best time ever, right? Because at the table, you're not meeting each other, you're just, doing your laptop and listening. But in the bus, hey, perfect. So human systems, I invite you to join the human systems that are focused on certain issues, but part of that is just the human system, because half the time we're in here, somebody talks about asparaginase, or about septic shock, or about their patient with second relapse who's, should they get more blinatumomab or not. So being together has so many advantages. Human systems. And if you miss the human system, though, you can just download it, no problem, and watch it in the car. So please join us. And thank you so much for this invitation and this time.
Thank you very much, Dr. Hayward. So I would like to invite all three speakers to the podium. We'll add 3 chairs. So, tough questions only. So we'll open the floor to, okay, please go ahead. At the back.
Back.
Can you give the mic at the
Back.
In the back. Way in the back. So until the mic reaches the end of the room, I can actually start by asking Dr. Malki. So you presented great data on how do we actually, use new molecules. I think there's a tendency now that, everybody, try to avoid induction therapies. In somebody who's 64, 65, they don't want to give them the 7+3, and so they tend to give Vin, Aza. But nowadays we're struggling with relapses on this. So what's your ideal relapse regimen for somebody who just failed venetoclax, azacitidine, and obviously not a transplant candidate?
Thank you for the question. This is too complicated and it has a lot of information into it, but I would summarize. Use your molecular panel, look for the mutation you have, and then see what you are going to choose. A patient who relapses with for example, a RAS mutation, I would avoid a venetoclax-based therapy because its response rate is very low. A patient who's going to go to transplant and your donor is aligned, I probably would use something very aggressive like FLAG-IDA venetoclax combination, which at times in a relapse setting could cause a lot of problems if you don't have a transplant aligned. So it has to do with your disease that you are managing. It has to do with the possibility of you having a transplant aligned and then the patient ability to tolerate all those drugs. A patient with FLT3 mutated AML who has a good potential could benefit from a combination of venetoclax, for example, with FLT3 inhibitor and with or without azacitidine based on the MD Anderson data. So it has to do with what type of leukemia you are doing. As I try to show in my slides, it's a precision medicine era. We should stop using one regimen for everyone. 7+3, 30, 40 years, maybe a little more. Yeah, that's enough for it. We have to be more individualized. Thank you.
So please go ahead.
Yes, okay, thank you. Many thanks to all the presenters for such elite and informative presentations. This is Dr. Abir Hussein, Pediatric Oncology from King Abdulaziz University Hospital. My question to Professor Scott, I have actually a couple of questions. Delaying taking the first diagnostic lumbar puncture and CNS stratification and making today 8 to 10. making the patient be subjected to dexamethasone, which is having high infiltrative power to CNS, and all the anthracyclines and vinca alkaloids and all the induction chemotherapeutic agents may abolish the ability to do the proper risk stratification regarding the CNS status. We may miss CNS3 or CNS2 status, or even that may affect the future plan of therapy. Let's imagine a scenario that on day 10 or day 10, you discover that your patient is CNS positive. So we are missing giving twice weekly intrathecal and cerebral dehydrating measures for which kind of clinical indication at first place. It may aggravate the situation. So, and on the other hand, when you think of what is the impact of traumatic lumbar punctures, you can easily abolish by correcting coagulopathy, raising the platelet count above 100,000 based on your paper with Professor Bui and Howard published before, that you can abolish the traumatic puncture by such things and using the most experienced physician to do it, to prevent it. And even what is the impact of traumatic lumbar puncture? In St. Jude total 15 and total 16, you count the traumatic punctures as CNS2, and they are still really treated on the low-risk arm of St. Jude protocol with extra number of intrathecals achieving the same cure rates as low-risk patients. So delaying this, I'm afraid in the future, we may have the same sitting here telling that that was maybe wrong, missing the risk stratification, which may have poor future impact on the outcome compared to the traumatic puncture risk. This is one notice.
Let's do this one before we go on, because
Okay.
that was a very nice summary of actually 30 years of important data, so thank you. The beauty is, you're exactly right. By day 10 in the Taiwan study, there were 0 CNS3, 0 CNS2, and 0 traumatic with blasts. They had, I think it was 97% were CNS1, and 3% were traumatic without blasts. So every patient was considered CNS1. And what I love about that is then you think, you guys proved it. You obscured the CNS status. You took away a prognostic marker. But nobody relapsed. 0 CNS relapses.
For how long the long-term follow-up of this study?
Yeah, like 7 years. Yeah, JCO, they don't fool around. Okay. So 0 CNS relapses. So what they proved, and the Japanese also, same thing. In the Japan study, they only did day 8 after prednisone. So there were a handful of CNS2. There were no CNS3 in the Japanese, so they partially sterilized. But the Taiwanese really sterilized everything, exactly like you said, because they got the multi-drug induction, asparaginase is great for CNS, and so on. So the point is, we used to think you need the CNS classification to know what to do. They did the same thing in everybody and cured all of their CNSs without knowing. And so that's the beauty of the strategy, is you don't have to know anymore. You don't have to go look at the cytospin. Oh, is that thing a blast? Is it not a blast? It doesn't matter anymore. If you wait till day 10, nobody will have a blast, and that's perfect because they will still be cured with the standard therapy, treated as if they were CNS1. So it turns out we've been introducing leukemia on day 1 into the CNS and actually increasing the risk of CNS relapse. So this whole strategy is all about not doing that. And I don't know if you remember Total 11. Total 11, we did a diagnostic lumbar puncture to make sure to check the CNS, and a day or 2 later did the first IT. And when you do that, you really add blasts into the CNS because there's so much trauma doing 2 lumbar punctures a day or 2 apart. So that's why the strategy came on Total 13, 14, 15, 16, 17, is doing the first LP includes IT therapy. If you don't know if they have leukemia or not, you do a bone marrow by itself and then decide to do the first LP. So we went from 2 to 1. Now we're going from 1 to 0 to get rid of the risk of introducing any blasts into the CNS. So the first LP is late with no circulating blasts. When it's nice, clean, if you introduce some blood, it's clean blood, no blasts. And so it's fantastic that it took us 50 years to go from giving IT and curing a lot of people to getting rid of the IT up front and giving it day 10. So I think that issue is now a closed, finished issue. I hope every new protocol will adopt this. It's hard to change, of course.
Is it applied also for myeloid leukemia? Or not yet?
Too complicated, yeah. So it hasn't been studied. Yeah. So
okay,
personally would wait a week.
My second question. Yes, methotrexate is the most studied chemotherapeutic agent. We love talks about methotrexate. My question is, the HBLC machine that measures the methotrexate level, at some centers it is calibrated to measure the free form of methotrexate. Other centers are calibrated to measure the total form of methotrexate, including the plasma protein pound form, the inactive one, leading to a false high level of methotrexate, false high sense of risk of toxicity, making the physician extend the calcium leucovorin rescue, giving extra doses of calcium leucovorin, which will neutralize the methotrexate effect on the cellular level and may affect later on its efficacy. Was this tackled during the methotrexate talks, the HBLC machine calibration, which is the most correct way to measure whether the free form or the total form? Does it have an impact on overgiving calcium leucovorin rescue may affect the efficacy of methotrexate future-wise?
Yeah, this is a really good question. And so how the methotrexate is measured is very important that it be standardized with the full range of controls. And the lab has to measure those controls periodically. Beyond the scope of today is the details of which is preferable. Both can be used very effectively, either HPLC or immunoassay. And the key is to do those 2 early levels. So the innovation is 2 early levels, end of infusion, and 4 hours later. That is where the story is. Not during the infusion, not 42 hours. The action in the kidney is during the infusion, and the way you detect it is right after the infusion. But you can use either method, unless you've given glucarpidase, which is definitely beyond the scope. Thank you for these questions, really great points.
Thank you. Dr. Absi, I think he has a question.
Yeah, I'm not sure if there were any other questions, but definitely just jumped in. I think one of the important points to look forward in the future is that, at least for myself, you know, the expectation of, I think there is a defining point in history of medicine, which is what I would consider the traditional story of ALL development therapy in kids, where over the last, you know, over 30 years probably, you had 5 medications and you had a long of time to investigate those medications and how to best use them and run a randomized clinical trial to answer every single question of those until we reached, you know, to the early 2000s. That model is never going to be repeated again. And the reason behind that is that there's introduction of so many new therapies into the market that you don't have enough time to investigate in a detailed fashion and a randomized clinical trials every single relevant questions, you know. Montrada, Munzer, and Scott, all of you presented so much data about new medications that are coming in, but then the question is always becomes, what's the standard of care and the benchmark that you're going to measure improvement to? And then the other question is, I think the issue of precision medicine is also is overemphasized. In Nature magazine a couple of weeks ago, they are reviewing a book called Genes Are Not the Blueprints of Lives, and I think it's a very good book everybody has to read, because I think this theory of that genes are kind of codes that encodes, you know, how we act or behave is actually wrong. We understood genes wrong for a long period of time. They interact so much with the environment that if we even take the exact same genetic makeup of one disease, one person, and put it in a different person, the outcome will be totally different, even dependent on very simple stuff. So maybe early prediction models is a very informative way to move forward in the future. What I would like to hear from every single one of you, you know, you talked about ALL, AML, and ALL as well as therapy thinking. How do you see the future is moving in every single one of those diseases? You know, there are so many ALL therapies coming in. Hospitals, countries struggle in taking decisions of which therapies you introduce and you accept and you add to the formulary, but the market is moving too fast, and then at the end of the day, you don't want to deny any patient of a therapy that could be life-saving for them, but on the other hand, you can't justify treating 100 patients for only 2 to get benefit. The question for all 3 of you.
Okay. Maybe then I can approach the standard of care issue and kind of leave the others for the other 2 speakers. the defining standard of care is very difficult. I mean, if you just screen the centers here, either in Saudi Arabia or even in the Gulf, you would have different approaches into the management of ALL. One problem that there are different approaches existing. So, and it goes at least to the place you're trained, the protocol that you know. And once you know that protocol, and your pharmacists know that protocol, and your nurses know that protocol, it's very difficult. I mean, it's not just the tendency of us maybe not to change, but also logistically, it's very difficult to get everyone on board with the new protocol. So that's one difficulty of changing the standard of care. And the second point in the standard of care, most of those trials are single cohort trials in terms of the ALL. And although people in health research methodology cautious us about the indirect comparison, but with this, we will need some indirect comparison. Otherwise, waiting for the randomized clinical trial is also an issue. Comparing to historical control is one way, and adjusting using the statistics to adjust the differences between the different cohorts may be another way to help us decide about which therapy. Now, personally, I think randomized clinical trials also important. Seeing in hematology and in other fields where cohort study showed you something, and then the randomized clinical trials showed you something else, that it did not work. The issue here, we don't need to do the sample size of the MRC, the hundreds and thousands. If you have a good signal, you could pick up that signal with a smaller sample size. So like in conclusion, I think we will need still randomized clinical trials, but we don't need to wait for those clinical trials. Real world data would help. And we don't need to go into very large sample sizes, and maybe smaller sample sizes that reasonable power to give you the answer.
Thank you. Ahmed, I think the main issue which I'm going to comment on is the precision medicine. And as you said, we are just starting to understand some of those details. Well, the truth is very difficult to get. It still need a lot of data and a lot of studies to show. The dream is always about that, CML experience that happened 10 years ago, when there is a originating mutation, was related to specific disease, and then there was a drug that can give you cure in 90+%. And since then, I think been trying to find the same type of mutation. Unfortunately, most of the mutation that we have drugs for are association rather than originating mutation. And I think the search will continue. We'll still have to understand more about the biology. We're just scratching the surface, and I don't think we are really close to anything similar to the CML model that happened before. I think ALL is trying to do the same thing with Philadelphia positive, with the blinatumomab, trying to avoid transplant for those patients. But again, long-term follow-up is needed. I think main message is we are having some drugs who are less toxic, and then we are able to use them to salvage some of the patients. And that's where we are now. I think a long time ago, I used to see patients dying of side effects of chemotherapy after their third or fourth or fifth line of combination for AML. And now we are not seeing that many of those real sick patients with bad hand-foot syndrome, severe mucositis, unable to eat or move due to the chemotherapy they got. I think more drugs are needed, but at the same time, how can you understand what to do with what? One of the cases I showed had IDH2 and FLT3 mutations. So I don't know. At some point, we probably become oncologists, not hematologists, and start to use things, in combination. So you will have 4 or 5 drugs together based on the mutation profile. But at this time, I think we are still in the early phases for that.
I agree.
Well, I would be
Well, so let's take blinatumomab, for example. So this thing is great, amazing, fantastic. Relapsed refractory, improves outcome. First relapse, improves outcome. MRD positive, in first remission, improves outcome. MRD negative, but with high-risk features, improves outcome. Infants less than 1 year old, one block, 15% higher EFS. One block, 4 weeks. So imagine something that brings you up 15%. Of the babies have been studied for decades. It's always 45%, 45%, 45%. Every single study, randomized trial over 10 years, 45%. And this or that change, but it's always 45%. Suddenly 60% with one block. So when are we allowed to say, okay, do I have to randomize every single little group? Now, what about a 7-year-old? Do they go their own cohort? Is it going to be down to each individual person? At some point, you say, if blinatumomab were free, we know we would be giving it to everybody, right? And probably 2 blocks. So my idea is to exchange study drug for data. And so instead of saying, hey, we're going to buy blinatumomab for everybody, nope, we're going to design creative studies with blinatumomab that Amgen wants that data, and we want their free study drug. So the one we are working on right now is called Bridge to Recovery. So it's not a bridge to transplant, it's a bridge to recovering from toxicity. So the idea is you finish your induction, you're waiting 2 weeks to do your remission marrow. Hey, if you're sitting there doing nothing, just give 2 weeks of blina. If you're between high-dose methotrexates, you got a week, give a week of blina. The first week of blina is the best week of blina because the T cells are very active. They get tired. The reason you have to stop after 4 weeks is T cell exhaustion. So the 5th week does you no good. But the 4th week is less useful than the 3rd week, which is less useful than the 2nd. So the idea of giving 8 weeks, but 1 at a time, 2 here, 1 there, 2 here, without changing anything. You're not giving up something else for it. You're just intercalating it to keep killing the leukemia by a new mechanism, surface attack, and while you're waiting for recovery. So I feel like strategies like that, where you say, we can't afford to just give 2 months of blina without justification, the government won't fund it, nobody wants to do it, but if the study drug, then wouldn't it be great? Amgen gets a new indication, then we'll do it, then we'll pay for it. If it works, we'll pay for it. Fair enough. But in the meantime, we could cure a lot of people on the way by the study itself.
We'll have to close. I think for time's sake, we'll have to conclude this session. It was a very fruitful discussion. Thank you very much for attending. And we'll be back at 10:50 a.m. for the second session. Thank you very much.
of a 50% as a cutoff. Anything below 50, that's a deficiency. Above 50, that's unlikely to be deficient. There are situations where you need to do some molecular measurements or identification of mutation before going for defining the deficiency. If we go to molecular test, both the factor V Leiden and the prothrombin, the type of anticoagulants, be it in the tube or when the patient is on heparin, it may affect the testing and cause some heparin inhibitor for DNA testing, and the methodology, type of methodology, and the sensitivity of methodology may affect the result of this. So to make it more easy, I had selected 5 clinical situations, and I'll try to go quickly through these 5 clinical situations where we can see the impact of thrombophilia testing on treatment of these conditions. The first one is secondary prevention following provoked VTE, secondary prevention following unprovoked VTE, primary prevention and relative of VTE, and primary prevention in females going or considering estrogen, and finally primary prevention in female relatives who are going for pregnancy. So before proceeding further, just give you a snapshot of different preferences, and you can see that the highest preference here we can see is the factor V Leiden, which is in between 2 to 7. We had done multiple studies in Saudi Arabia, and we are talking in a range of around 4% in the country. So we are about the middle. While in most Asian country, it's below, even below 2, reaching to 0. So if you look at the preferences, you can see that different preferences depends on the type, and these preferences even are different according to reports from either patients or relatives during acute phase or during pregnancy. I will not go in details because of the sake of the time, but I'll take you directly to those 5 conditions and try to see what are the evidence that we have to support testing or not to test. The first one is the secondary prevention following provoked VTE. Thrombosis following a major provocation, we give 3 months, and that's what recommended by the ACCB and most of the countries, and there is a short-term relative risk of reoccurrence of 0.5. So let's compare to those absence of identification provocation. So if we have a recurrence of 0.5 or less than 0.5, now it's been considered very low risk after provoked VTE. And in many studies, and I had quoted only 2 of these studies, and the ASH, in large prospective registry offered patients with VTE the opportunity to be screened for hereditary thrombophilia. They found that very low risk after provoked and did not differ between the patients with hereditary thrombophilia or no thrombophilia. Another large study, controlled study, they looked at the risk-benefit balance favoring time limited to anticoagulation regardless of presence or absence of thrombophilia. The downside of this one, which has been highlighted by ASH 2020, that there is a potential for patient harm. And that potential for patient harm is if you have a false read or false interpretation of the results and you put the patient for unnecessary risk of bleeding for something not documented. And that's because of that, the ASH had recommended against screening for thrombophilia. So that's the first condition. The second condition is the prevention following unprovoked VTE. And this is where really the most acceptable, I will not go through, again, I'm looking at the time, the most acceptable situation where you need to test for, but that should be in a situation where these tests will be used. There are many, again, larger studies looked at the value of the testing, and they nicely documented that or proven that the anticoagulation or testing for thrombophilia would lead to better anticoagulation of these patients. But again, the pros of testing is negative test of thrombophilia may falsely reassure the physician. Now this patient, and particularly if the patient has a family history, which is considered the most important factor for recurrence is the family history, not the thrombophilia. So if you have a negative thrombophilia and unnecessarily you stop the anticoagulation, now you affect the patient on the other side. So this is the second situation. The third one, which is the relatives of VTE patients, and that's a very common question. Once we identify a patient with factor V Leiden mutation, do we need to screen for the whole family? And that comes from a couple of studies. I will show you the first one, which is a large screening study of family members of VTE patient, revealed that asymptomatic carriers of a hereditary thrombophilia defect were at excess risk of thrombosis, with risk varying by disorders, depends on the type. But they found that the family history of thrombosis alone carries the most important risk, even absence of identifiable thrombophilia risk factor. Again, they noted that negative thromboscreenia does not equate to normal VTE risk and does not or should not prevent you to consider thrombophilia prophylaxis during acute phases. In another cohort of a study, which was over about 9 years, the rate of provoked VTE was higher in group with thrombophilia 0.58 compared to 0.24 in those without it. Again, here now, what is the recommendation is do not test for thrombophilia in asymptomatic family members of patient with VTE or with hereditary, unless there is something will be done to do for relatives, for prophylaxis. This is again another interesting area which usually we get asked about, which is for female patients, relatives who wants to start estrogen. What is the recommendation? She has a family history of thrombophilia. Do we need to screen for thrombophilia? And the answer comes from a couple of studies focused on testing of thrombophilia in general female population, which has suggested little utility and risk of cost effectiveness or a lack of cost effectiveness in these patients. And in that study, which is nicely calculated how much you need to test to prevent a BE or VTE in around 100,000 carriers is $300 million. A lot of money to prevent one. And it could have been done much easier by one question. Do you have a family history? Extended family history of question. Do you have it or not? That could have saved. And the British guidelines recommend again is screening for patients who are going for estrogen, unless there is a strong family history. Okay. Finally, the pregnancy is an area where itself there is an increase 10 times the risk of thrombosis. So do we need to do screening for females who have a relative with thrombophilia? The answer comes again from many studies. Women with a prior VTE that was unprovoked or provoked by pregnancy or OCP merit prophylaxis regardless of the thrombophilia status, and that had been confirmed in many studies. Okay, so that comes to the conclusion of these 5 situations. The first one, do not perform thrombophilia. The second one, the provoked, do it if that will help you to make a decision about the duration. Regarding the third one, don't perform the thrombophilia testing in asymptomatic family members because that would not add much. For the primary prevention for estrogen, do not perform it unless, except for a woman for estrogen use has a first degree relative with VTE, a known hereditary risk factor, then you may have some benefit of doing it. And finally, for pregnancy, the recommendation not to do. Now, we talked today and heard about the biomarkers, the personalized, the how to decide based on biomarkers. I think one of the areas where in hematology not progressing very well is to defining biomarker to detect who is not based on the genetic background who will be more entitled to get thrombosis. And unfortunately, we did not move forward too much in this regard, except for some studies, and just because of the time, several risk models had been suggested. D-dimer. And I got the D-dimer because the D-dimer has many studies. The most recent one, which just been published in 2023, showed serial D-dimer level have the potential to identify patients at high risk and impact the treatment. Thrombin generation, there is some work ongoing. The fibrin monomers, the use of ultrasound to look at the residual is again another area. Just 1 second, just to tell you that there are issues with the thrombophilia, with all genetic testing, that we don't give it much time, which is the psychological, emotional impact on the results. And in a nice study, they looked at, or in a nice meta-analysis, they looked at 6 studies, the impact of the thrombophilia on these patients who are young and may use it for a long time. And as you can see, most participants were found to be carriers, were satisfied with knowing when to use it or not. A participant expressed concern that being carriers of thrombophilia could cause stigmatizations and problem with obtaining insurance, and that's another issue which was emerging. And finally, participants felt that thrombophilia testing was less serious than genetic testing for breast cancer risk or non-genetic testing. And finally, I would like to tell you what happened to my case, just to conclude. She completed 12 months of anticoagulation. During that course, she was started on warfarin because she had mildly elevated lupus anticoagulants. Everything was negative. Lupus was 1.3. The cutoff is 1.25, so just marginal. So because of I repeated that without anticoagulant, because we know that anticoagulant can affect, and it came to be negative. So I put her on rivaroxaban. She developed severe menorrhagia, iron deficiency. She needed to receive multiple iron IV to keep her hemoglobin up. I switched her to apixaban, less tendency to bleeding, still continued to bleed. Menorrhagia in her age of 16 is not encouraged. Then the family came and they said, we know that everything is negative, but we don't want her to continue an anticoagulation. What you would advise us? So I put all the cons and pros of the situation, and putting in mind that we did serial D-dimer 5 times and all negative from the first one, that's reassuring a little bit. I discussed with them all the possibility, and then we came in combined conclusion that we will stop the anticoagulation, but put her on regular follow-up with D-dimer. And by that, I will end my talk. Thank you.
Thank you, Dr. Tariq, for this informative presentation, and we'll proceed with the second presentation.
Okay, so it's my pleasure actually to present our second speaker, Dr. Mervat Matar. Dr. Mervat is a professor of clinical hematology and internal medicine at Qasr Al Aini Faculty of Medicine at Cairo University. Dr. Mervat is the head of clinical hematology department at the Armed Force College of Medicine in Egypt. Dr. Mervat, the floor is yours.
Thank you, sir, for the introduction, and I thank Dr. Al-Askar, Dr. Absi, Dr. Muhammad Qari, Dr. Saad Jaouni, all my friends for inviting me, and I'm happy to have a talk in between Dr. Oid and Dr. Tarawa, and I hope I will be of value. I'm going to present difficult bleeding consultations in our hospital, a single center experience. I'm not the head of bleeding disorders in our facility, but Dr. Mohammed Talat is. And we serve a 5,000-bed hospital, and so we have many hematology consultations. Many of them are bleeding disorders, and we serve adult hematology only. let me share with you some of my cases, and I hope your input would be, because this might not be the right answer to any of these cases. So number one case is a 34-year-old hemophilia B Yemeni female and end-stage renal failure on dialysis, and she is fit for a kidney transplant. And the donor is her 36-year-old sister who still has hemophilia B. So they are both mild hemophilia B cases with an activity of 30%, and they are both on on-demand plasma transfusion, nothing else, and they were in Egypt for a while just for the kidney transplant. So we were really worried, not about the recipient but also about the donor, because the complications in the donor will be grave, and she is donating her kidney. There's nothing wrong with her, actually. We were also worried about recombinant factor 9 in these two patients, because they were having major surgeries, and so thrombosis could be there. But also, there is no real evidence regarding the use of recombinant factor 9 with dialysis patients. And a monitoring of factor 9 activity should always be done, and it should be done very, very closely. Now, what happened is just we looked at publications, and even hemophilia EA, only 9 hemophilia A patients were reported on peritoneal dialysis successfully receiving factor 8. Regarding factor 9 deficiency, one case was followed up by PK evaluation, pharmacokinetics of the recombinant factor 9, and it showed an improved half-life. And so it was really a challenge. So what happened, we looked at, this was a major surgery. We maintained the factor 9 level between around 50 international units per deciliter. We wanted an activity of around 50%, and both received factor 9. Now, I was worried about the donor mainly, so we did an ultrasound post-operatively, and there was only a mild post-operative pelvic collection. During surgery, it was uneventful. Nothing happened. She did not need any blood transfusion. Regarding the recipient, of course, was end-stage renal failure. She already had anemia. She was on ESAs, and she was receiving many medications. She received 3 units of blood, and her post-operative hemoglobin was 7.7 grams per deciliter, but it passed. No major complication was noted, and 6 months later the patient came and said hello. Her creatinine was 1.5 milligram per deciliter. She was off dialysis. Hemoglobin was 10.5 grams per deciliter with no ESAs. So this was a success, but it was barely a success. It was a real challenge. Case number 2 is referred through rheumatology. That was a 38-year-old female, and she presented to them by bilateral knee pains, malar rash, and hair loss, and this rash. Of course, this was bruising, and she also had menorrhagia. So regarding rheumatology, her ANA was positive, DNA was positive, and it was positive homogeneous DNA, so probably this was a case of lupus erythematosus. The rheumatoid factor was negative. And regarding us, the hemoglobin was 10 grams per deciliter. Platelets were a little low. They were 100,000, but not that low to give this problem. PT was normal, but the PTT was prolonged, and there was no rectification on mixing studies. So we had a prolonged PTT, and so lupus anticoagulant, beta-glycoprotein, anticardiolipin, they were triple positive. So this was a triple positive antiphospholipid syndrome. But the platelets were not that low to give these bruises. So I should worry about clotting rather than bleeding. But the factor 8 level was less than 1%, and the inhibitor level was high. And so she had acquired hemophilia. So now we have an antiphospholipid syndrome, which can cause clotting, and on the other hand, we have acquired hemophilia, which is causing bleeding, and what to do? Do I give her a factor 8 with a high dose? What if she clots? So we looked at the acquired hemophilia management. If the factor 8 level is less than 1%, you consider factor 8 transfusion. And you consider rituximab together with corticosteroids, but if the inhibitor level is more than 30 Bethesda units, you consider adding cyclophosphamide. Of course, there are others that can help also the lupus and help the antiphospholipid, such as plasma exchange or immune adsorption. So what did we do? I did not give her any factor VIII at all. The patient received rituximab together with corticosteroids, 4 doses of rituximab 1 week apart, with better bleeding. Then the corticosteroids were weaned. Of course, the PTT still was high, 80 seconds, and I don't think it's going to go lower, probably because of the antiphospholipid, but still because of the acquired hemophilia. And the patient is still having minor bruises with some menorrhagia. Now we are following her up for the past 1 year. She still comes with bruises, but not as much as before. And she still has menorrhagia, but it is acceptable menorrhagia. My problem is the patient is still on maintenance rituximab. Once I stop the rituximab for months, she starts to bleed again. And so I'm keeping her on maintenance rituximab every 2 to 3 months. I don't know if this is right or wrong. I don't think this is, no one has the answer. But we are following up the patient. Last time she came was only 3 weeks ago. She's doing fine. She showed me some bruises on her thighs, but that is all. Hemoglobin is normal. She's living a normal life. Actually, she thinks of getting pregnant again. So this is the third case, and this was referred through neurology. That was back in 2021, and I'll show you why. She's an 82-year-old female. She presented by dizziness and right-sided weakness, and this bleeding tendency, as you can see, purpuric eruptions. And she did the CT, which showed a brain infarct. Her hemoglobin was 9.9, mormocytic. Total leukocytic count was almost normal. Platelets were low, 25,000. And there was a high D-dimer. Corrected reticulocytic count was not that high. We thought maybe this would be a TTP, but the bilirubin LDH were normal. No fragmented RBCs, normal Adams T13 level. So first we thought of thrombotic thrombocytopenic purpura, but probably this was not the case. So we went back and asked her relatives, and she had an Astra-COVID vaccine 1 month before. And the platelet factor IV heparin complex antibody turned out to be positive. So probably this was a vaccine-induced thrombotic thrombocytopenia. And actually, we looked at VITT management, no platelet transfusion, no heparin, and you should give IVIG 1 gram per kg for at least 2 days, which we did. So what happened? The patient responded, the neurological complications went away, platelets went up to 100,000, and then later on reached 160,000. But if you stop the IVIG, the patient relapses with more thrombocytopenia and more bleeding. And now we are following her up to this moment, and she is needing IVIG every 2 months. Up to last month, she was receiving IVIG. I tried to separate, to make the IVIG less frequent, every 3 months, every 4 months. She relapses, the platelet count goes down. I wait until it is around 50,000, or if there is bleeding, and then I give the IVIG. She needs IVIG now every 3 months. Is this only VITT? Is this only vaccine-induced thrombocytopenia, or was the patient having ITP and then there was an association with the vaccine? I don't know. But up to this moment, now she's 85, and she is still receiving IVIG intermittently. So this is another question. Case 4 is an orthopedics case. Actually, we referred it to orthopedics. He is a 40-year-old hemophilia A with a factor VIII level of 3%, no inhibitors, because up to the age of 40, he is only receiving plasma and anti-hemophilic globulin, nothing else. And because we are a referral center, he was referred to us from another city, not in Cairo. And he has been having this problem for 3 years. Recurrent hip and thigh bleeding, and recurrent infections in the organized hematoma for the past 3 years, and fever, and antibiotics, and then back. And no one wanted to touch him. Why? Because the thigh grew so big and a huge pseudotumor was there. And the patient is obese. He's 150 kilograms. He came on a wheelchair. And he was miserable for the past 3 years. So we decided we had to do something. So what we did was we had a combined orthopedic surgery team. And it was decided that there was nothing else, no amputation even. Total hip disarticulation was decided. And this is the thigh after removal. So this very poor person, we had to remove the whole thing from the hip downwards. So this was a bloody operation. So what did we do? We decided to use the extended half-life factor 8. And with the use of extended half-life factor 8, we used the 80 international unit per kg for the first 3 days dose. And then we reduced them to 50 international units per kg. And the patient fared well. The bleeding on table was not that much. He did not need much blood. And then afterwards, there was some bleeding, but not that bad. And the patient fared well. Of course, he went back on wheelchair, but at least he did not have the infections and the fever. And actually, he came 1 year later for another surgery, not in his limb, but in his elbow. Evidence for the use of extended half-life factor 8 is not that extensive. There was one trial using extended half-life in 45 major surgeries and 90 minor surgeries. And they reported that the patient needed 1 or less injection per day with a median dose of 81 international units per kg on day of surgery. And this is exactly what we saw. The patient did not need much blood, was not bleeding that much on the extended half-life. So probably we will be looking at the use of extended half-life with surgeries in this context. This is my last case. Do I have time? Okay. So this is my last case. It was a neurosurgery consultation. He is a 43-year-old male. He presented to them by sudden vomiting and unilateral numbness, followed by disturbed consciousness level. He's a known hemophilia A, and the patient is on prophylactic recombinant factor 8. With some bleeding, elbow bleeding every 3 months, things like that, but never cerebral. And we looked into the inhibitor level, and it was 8 Bethesda units. So probably with the repeated use of prophylactic recombinant factor 8, he went into an inhibitor status. And looking at the CT brain, they found a cerebral hemorrhage for urgent surgical intervention. And at that point, they looked at us and we need to do something. So what we did is we went into recombinant factor 7, and he received 90 micrograms per kg every 3 hours. And he was operated upon, and he went out with a drain. And we were worried about the amount of hemorrhage inside the drain. And we were more worried about repeated hemorrhage inside. But thankfully, nothing happened. The drain was around 100 milliliters a day, and then 50 milliliters a day, and then in 1 week, the drain was removed completely. The patient regained consciousness. He still has numbness on one side. Now he is discharged. And the problem now is what further treatment? This is cerebral hemorrhage, and I'm really worried. This is not a joint with recurrent joint bleed. This is cerebral hemorrhage. This is really serious, and the patient has to be tackled in a different way rather than prophylactic factor 8. So do I go for immune tolerance induction? This is an 80-kilogram male. He will be needing lots and lots of factor 8. Do I go for prophylactic PCC or prophylactic fiber? Maybe 2 to 3 times a week, maybe prophylactic recombinant factor 7. Is this really practical? Because the patient is working, he has to go to work, he has to earn a living, he's 43 years old. Or do I consider imicizumab? And there are some studies considering imicizumab as prophylactic treatment in this setting. So in Egypt, Ssbmt is only used in children below the age of 18. It is not used above 18 as sponsors, for sponsorship. And so I don't know if the patient is going to be sponsored or not, but definitely I'm going to go for Ssbmt if possible. And I think you will advise me the same. My conclusions are a multidisciplinary approach. I think this is the best thing to do. And real-world evidence is always needed for extraordinary situations, because not only trials can give you the good result or the good answer. With that, I thank you.
Thank you so much, Professor Mervat, for your excellent presentation and sharing us these challenging cases. I think we will have a couple of questions maybe later at the end of our session. Now we are moving to the third speaker.
It's an honor to present our colleague, Dr. Ahmed Tarawa. He's the third speaker for this session. He's a consultant pediatric hematologist oncology at King Salman Medical City in Medina. He's the president of Middle East and North Africa Hematology League, and he's the president of Medina Hereditary Blood Disorder Charity Society. Dr. Tarawa will talk about high prevalence of rare bleeding disorder in Al Medina. Dr. Ahmed.
Thank you, Dr. Uthman. Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. First of all, congratulations for the four association for this joint meeting for the second time. Thank you, Dr. Ahmed Absi, for this kind invitation and the whole group. This paper, actually, we have presented in the ASH, last ASH 2023. And I'm going to represent it here again. Before I go ahead, I would like to acknowledge my colleagues in this study. You don't need probably to know about Medina and the geography and so on, but probably you need to know that Medina population, it is 2 million plus. 1/3 of them, they are expat, and most of the expats, as all other places in Saudi Arabia, they are singles and they are selected, so they don't have major disorder or chronic disorders. 4 years ago, the Medina Hemophilia Comprehensive Care Center, it was one center, and currently it has been divided into children and adult side, starting I think from last year, we are dividing the adult even further into 2 sections. So we have 3 sections for the Medina Comprehensive Care. You are aware about the coagulation issue and the cascade, but in Glasman thrombasthenia, we have problem with the platelet aggregation where the where the glycoprotein 2B3A is not functioning very well, or it is deficient enough that the attachment of each platelet to the other platelet is deficient in those patients. And it has been classified into type 1, which is severe deficiency, and type 2, which is milder deficiency, and variant GT, where it is not very well understood whether it is functional or other issues. Some of them, they have normal glycoprotein on flow cytometry or deficient, and we do not know about the function very well. Glasman thrombasthenia, it is, sorry. It's rare, considered rare bleeding disorder elsewhere in the world, where the incidence it is 1 in a million in the Western countries. The matter is different when we consider the Middle East, where you can appreciate that it is in the east of the Middle East. It is a common bleeding disorder rather than a rare, where the prevalence in Iran in 2004, it has been published as the 1 in 200,000. 5 or 6 years ago in the Gulf, Arabian Gulf countries, we have reported 1 in 190,000 of the population. The west of the Middle East, except for Tunisia, they have reported low, and in the Western country, it is low. In Europe, they have 200, I think 260 or 260 plus cases in the whole Europe. Look at the consanguinity rate among the countries in the region. So comparing to the Western countries, the Arabian Gulf countries, the consanguinity rate is very high. And probably those genetic disorder, which is autosomal recessive, is high among our nations, not only the Glasman thrombasthenia. To diagnose Glasman thrombasthenia, it is not very difficult. Probably the flow cytometry is enough to diagnose it after you do the bleeding score, the screening test. Usually we don't go for the platelet aggregation. It is more difficult and more expensive than the flow cytometry. And most of the time we don't need to go for molecular diagnosis, except for specific cases where the diagnosis is a bit difficult, particularly the variant Glasman thrombasthenia. This is the modality of treatment, which is mainly controlling the bleeding, but the curative treatment is stem cell transplantation. People are working on gene therapy currently, and 2 companies, they are working on the prophylactic medication for Glasman thrombasthenia. One of them is nearby to be FDA approved. The other one is still under phase 1. So what we have done, it is a registry. It is about 25 years old, and we cut off this time to the 20 years. For those patients whom they have confirmed diagnosis of Glasman thrombasthenia, and we define that they have flow cytometry or molecular genetic conclude the diagnosis for those patients. In the registry, there is 136 patients, and this is all data, by the way. It is 1 year old data. Over the last year, 2023, we have added probably 15 or 16 more cases. Since I have presented this paper to ASH 2 months ago, till now we have added about 5 more cases. 125 included in this study, as we have full data, or more than 70% of the data we need are available, and we excluded 10 patients where we don't have enough data for those patients. Make the prevalence of Glasman thrombasthenia in Medina 1 in 10,000, which is more common than hemophilia. As other results, as other publication, it is more predominant in female a little bit. And almost all of our patients, they are Saudi but 1. And at the cutoff of the study, most of our patients, they are 5 to 30 years of age, but most of them, they present before the age of 5, and 1/3 of them, they have presented before the age of 1 year. Probably this is related that they have family member whom they have Glasman thrombasthenia, so whenever there is a newborn coming for that family, we will test him for the Glasman thrombasthenia. 98% of them, they are product of consanguineous marriage. And 86%, they have family history of Glasman thrombasthenia. And 60% of them, they have another sibling whom he has Glasman thrombasthenia. 25 families, they have 2 to 5 children with Glasman thrombasthenia. When we report this family pedigree probably 6 years ago, we thought this is the largest family of Glasman thrombasthenia in the world. When we are preparing for this publication, there was a family with 40 patient of Glasman thrombasthenia, and we are studying that for publication. The presentation or the bleeding that is happening in those patients, as all platelet disorders, it is mucocutaneous type of bleeding, gum bleeding, epistaxis, process, and of course menorrhagia in ladies, which I'll come back again. In our cities, we have reported gastrointestinal bleeding, angiodysplasia in 8 cases, hemarthrosis in 4 cases, intracranial hemorrhage in 2 cases. 80% of our patients are type 1, and 3% of them they are type 2, and 18% they are not in record. We do not know which type of them, but I know that maybe 2 or 3 patients they are variant, and we have diagnosed them only through molecular genetic. When we talk about the course of the disease, we are talking about how we control the bleeding. So the mild one, they can control the bleeding at home with the local management, and the severe one, when they need to be admitted, they need to be admitted to BICU, or they have significant drop in hemoglobin, or they need to spend more time, more than 3 days in the hospital. And at that regard, that almost 50% of our patients, they run mild course. And again, more than half of them, they have less frequent bleeding, which is less than once per year. And those whom they have severe, which is more than 1 episode of bleeding per month, 17%. And 1/3 of them, they have about 6 bleeding per year. This is the molecular sequencing for our patients, and this is part of the a study where Dr. Aweda has conducted, and we have the 14 mutation in ITG A2B gene in 65 GT patients, and in ITG B33 mutation in 35 patient. Iron deficiency anemia is very common among our patients, where 2/3 of them they have iron deficiency anemia. Fortunately, they respond to iron therapy, where oral iron therapy, where we recommend IV nowadays. Menorrhagia is a common problem among Glasman thrombasthenia, and the first patient where she had severe one, and as the protocol called in 2009 or 10, to cease the menstruation and to start hormonal therapy. 6 months later, she came back with, again, heavy menstruation. And then simply, she is a girl, cannot be without menstruation. Nobody going to marry her. In 2022, I have presented something as such in ISTH. So our friend in Iran, Pakistan, in India, they have showed the same issue among their patients with Glasman or other bleeding disorder. So at that time, we have developed something in midway. We gave them hormonal therapy, and we allow menstruation to happen, where we control it with tranexamic acid, 7A, and we restart the protocol. Those patients whom they have subsequent 3 cycle, which is heavy, so they exit the protocol and go for persistent hormonal therapy. Later on in 2017, we have found many patients, they have menstruation which is normal or mild menorrhagia, where can control without hormonal therapy. So we allowed those patients to go into an observational period. Then we choose whether they need to go into a protocol or not. 45 ladies and young ladies, they have menstruation. 22, they were in 2014. 6 of them, they have exit the protocol due to heavy menstruation, and 9 of them, they have continued. The 2014, 7 of them transferred to 2017 protocol, and 12 patients, they continued in 2017 protocol. So the idea that all Glasman thrombasthenia patients, they need to be on hormonal therapy to cease their menstruation is not true anymore. There is 10 patients, they are running Glasman, menorrhagia, without any treatment, without hormonal therapy, and life is smooth. 10 ladies, they get pregnant, they reproduce 28 pregnancies, and we have presented as a poster at last ASH. This is the poster. And those 28, they have reproduced a significant number of babies, they have miscarriages, which is higher than the normal population. Astonishing that the parity is 1:6 and the gravity 1:7. Among a Glanzmann patient, this is high. Postpartum hemorrhage is common in 2/3 of our patients. They have postpartum hemorrhage, and we have found in another study that there was no correlation between what we are doing pre-delivery, I'm talking about prophylaxis, or postpartum hemorrhage. This is another study going to be published probably next or month or after. We have tried prophylaxis for those patients whom they have frequent bleeding. So we allow regeneration of the mucosa, particularly those whom they have epistaxis. So we keep them in 7A, 270 mic per kg 3 times a week. And usually it is given at home for 3 to 6 months. And we have found that it was very successful in all the 11 patients we have studied. And we thought about that we are using more amount of 7A, but when we have studied that, statistically, it showed that there was no significance between when they are on prophylaxis or the 6 months before that, so it is the same. Alloimmunization, 11 patients, they have antiplatelet antibodies. 4 of them, they were platelet refractoriness. And when we compare that to the other publication, we found our data, it is very low among the Glanzmann thrombocytopenia. We cannot explain it very well, except that either we are not looking for the antibodies very well, or we are not using platelet as upfront medication, and we are using 7A as upfront medication since 2009 or 2010. Maybe this play a role to have low alloimmunization among our patients. Genotype, phenotype correlation, previously we thought that there was no correlation, and maybe that because we don't have enough number. Now, when we compare 3 type, which is the largest number of patients in those 3 mutations, we have found some mutations, they have more the severe course or more frequent bleeding compared to the other mutation, so that the correlation is statistically significant among those patients. In conclusion, Glanzmann thrombocytopenia is the commonest bleeding disorder in Medina population compared to the others, including the von Willebrand and hemophilia. There is a high rate of menorrhagia, but can be controlled with other modalities except for ceasing the menstruation for those patients. Iron deficiency anemia, particularly in children and ladies, is very common and need to be taken care of and treated promptly. High rate of consanguinity may explain the high rate of the menorrhea, Glanzmann thrombocytopenia among our population. And thank you.
Thank you, Dr. Ahmed, for the nice information given to us. Can we ask the 3 speakers to come to the stage for 5 minutes for questions?
So, Dr. Mervat, please.
We can stand.
Yeah. Sure, okay. So, do we have any questions, please? Yes, the mic is here, please.
Thank you all for this amazing talks. Just a comment for Dr. Mervat regarding the patient who had acquired hemophilia and lupus. In my experience, cyclophosphamide works well for patients with acquired hemophilia, so I would recommend giving a trial of cyclophosphamide, like 1.5 milligram per kg, with steroids for like 6 to 8 weeks, and then monitoring the inhibitor levels, because there is a chance for these patients to go into remission with cyclophosphamide.
Sir, I quite agree with you that cyclophosphamide can be tried, yes. Yes, I quite agree with you. We decided not to give cyclophosphamide at that point, and she worked well. I mean, she's still working well, but on intermittent rituximab. But still, if this does not work, I will definitely try cyclophosphamide, and this is going to help the lupus too. So I quite agree with you, sir. Thank you. Thank you for your observation.
Okay, thank you. Another question? Dr.
Yeah, very interesting, Dr. Ahmed, the Glanzmans and the registry that you have. And I wonder if you want to expand it beyond Al Medina and go even towards molecular genetics. And as you have already done now started, you'll probably, you might, I would say, uncover new disease entities, because there are a variety of bleeding disorders from our experience that we're facing in our country. They're behaving differently from mild to severe. Many were labeled as Glanzmans, and we discovered they are different and they have different molecular genetics, etc. So I think this is worth pursuing, and probably using molecular genetics to probably reclassify those bleeding disorders.
This is a comment, but I totally agree, actually. We have smaller studies done by Tariq and Dr. Zolali, where they have looked into the other bleeding disorder, not the whole kingdom, probably 3 regions. And we hope that this will continue up. Now, I came to know that Ministry of Health, they will start a registry for sickle cell, for bleeding disorder, and one more thing in hematology. And we heard 2 months ago or 1 month ago that it is going to start in 2024. Myself, I am preparing submission proposal to the Ministry of Health IRB to continue the registry all over not only Saudi Arabia, but even the Gulf countries.
Maybe if I can add, I think it's a good suggestion. The molecular studies, as you are aware, that mostly in hematology is focused on oncology part. And there is a real need that somebody sponsor this and uncover all the genetics of non-oncology part, which it needs somebody who initiate, maybe the Ssbmt or the Saudi Society sponsor this and find a place where it's willing to shift a little bit from the oncology NGS to non-oncology NGS.
Yes,
yes,
thank you, Prof. Ahmed, for that nice presentation. I have a comment regarding the platelet refractoriness cases for GT patients. We have 1 family or 2 families in Farasan were follow up with us. Actually, on the level of ER, they give them a transfused platelet, and in absence of hematologists. And on their experience and the patient experience, they told the physician that I was improved previously. Anytime I have severe heavy amenorrhagia, so I'm receiving platelet, and I have a partially or mild improvement during adulthood and childhood. So that's why we have we have patients with GT, they have platelet refractoriness, and as I mentioned, because of absence of hematologists, they don't give, although we provide them maybe 2 years ago, the pharmacy with factor 7. This is, I think it's the cases that we have from our areas. I have for comment for Dr. Prof. Tariq also, we have, we need to make a brainwash for the internal medicine, because we are receiving the consultation considering thrombophilia is mandatory for every patient has VTE, which is, I think, it influenced our colleague to do it. And we did it for more than 3-4 years, and no patient received, I have received 1 patient from Egypt. He did it He's a Saudi, but he did it in one of universities in Egypt, and he has really complex of genes, and prothrombin gene mutation was positive, and another gene was positive. But in our area, we don't, when we screened them, we found them negative, unfortunately. Apart from protein CS you mentioned before, it was also in a proper way. I don't know details of timing and all these things. Really, it is, I think it has no benefit for provoked DVT. Thank you.
No, I have actually, look, everywhere in Saudi Arabia, we are not looking into the antiplatelet antibodies. So I don't want to come with the conclusion that the platelet transfusion only is the factor after the platelet antibodies. And the use of 7A will be lead to low rate of the alloimmunization. We need to look into that. Like every year, we need to test the patient whether he has antibodies or do not. And of course, when we have areas where there is no hematologist, even when there is a hematologist, in many occasions, the plasma thrombocythemia management is difficult for many people to go for. And in many protocols in the Western side, they call for the platelet to be the first line of management, while the Gulf Protocol called for 7A to be the first line of management, though here in Saudi Arabia, many centers, they are using platelets. During ASH, a nice lady, she met me, they are doing a protocol for plasma thrombocythemia management in Germany, and she would like to have our experience to be added to their experience to convince the assurance to use 7A as first line. But testing the antibodies is very crucial in those patients.
Thank you. I totally agree with you regarding the overused thrombophilia workup. Two good news for you. The first, that insurance is coming, and insurance is a bit on the other side now controlling what is unnecessarily being done. So if the guidelines said no indication, the insurance will not approve the testing. So there are two ways: either the patient pay from her pocket or his pocket, or the physician pay from his pocket. And I think the first one will be more likely. The other point, I totally agree with you about the extensive looking at other even rare genetic thrombophilia, which is not being validated, which is not clinically relevant, but there are unfortunately labs who provide extensive looking at the mutations in fibrinogen, mutation in plasminogen factors, pathway, all these being reported and given to the patients, but unfortunately all these are non-clinically significant. And when it comes to the buyer, none of the official buyer will do it, but unfortunately, some people use the patient demand to know what is the problem, because people goes to do the testing to know why I got thrombosis. And some people sell them this information.
Just a little comment regarding the thrombophilia testing. There is choosing wisely recommendations has been approved in Saudi Arabia. It is taken care by this patient, a Saudi Patient Safety Center, and has been implemented in Ministry of Health. We have developed 10 hematology recommendations, among them 2 addressing the thrombophilia testing for pregnancy and for non-provoked thrombophilia. So maybe you can communicate with the Saudi or the champion of the choosing wisely in Jizan area. They might guide you for these recommendations and start implementing it. Hopefully this will lead to some improvement in the unnecessary investigation for these patients.
Thank you, Dr. Athman. So do we have any other questions? So if you allow me only for one question for Dr. Mervat, regarding the case that you presented with the vet who I think that she continued on IVIG until the moment, yeah. So have you tried like other modalities of therapy, like treating her in a similar way to ITP patient? I mean, did you offer her, for example, TPO agonist or other medication? Or no?
I was worried about TPO agonist because she had a clot. So I was worried about that. She presented by cerebrovascular accident at that point. So I was really worried about the use of TPOs. I tried corticosteroids, they did not work. And mind you, she is 82, 83, now she's 85. So IVIG was the safest for her, and she's accepting it. But TPO agonists, receptor agonists, I was really afraid of their use. Because should she go into another clotting episode, it would be me who did it. Well, would you consider it? I think that would be...
Yeah, actually, I think that the incidence of the thrombosis with the TPO agonist is considered like minor. But again, it is a point of view.
I played it safe. I mean, she's okay. I have a question for Dr. Oida, if we have time. What about your patient if she was going to fast for Ramadan or she's going on a long flight to USA? What will you do? You stop the treatment?
Now, fasting in Ramadan, dehydration is a factor. I don't think we have evidence that we can ask her not to fast, but maybe we can put her on prophylaxis. I'm bringing her every month to do surveillance by D-dimer. We did MRI and the clot completely went away. Travel definitely would increase the risk. And this is what I recommend for all patients who have long distance travel, 8 hours and above, to be on prophylaxis 1 day before, 1 day, and 1 day after. And we will come to the estrogen because she may come to get married soon. So the estrogen is an issue, or the contraceptive is an issue. And definitely for her situation, I would not go for estrogen. Maybe we can advise for other contraceptive pills. Again, the situation, as you could see, it was a combined decision. It was not a single. I would love to keep her longer, but she doesn't want it. The family doesn't want it. And they accepted the small risk of having the recurrence. And that happens quite frequently because, especially in young people, they don't want to be on medication for a long time.
Okay, so thank you everyone for your attending, and I would like to thank the speaker, the audience. We conclude our second session. We'll have a break for 1.5 hours. We will meet here again, inshallah, by 1:30. See you soon.
So I guess we'll go ahead and start the afternoon session. I would like to introduce Dr. John Apostolidis. With a great pleasure, I'm presenting him. He's a senior consultant at King Fahd Specialty Hospital in Dammam, where I had the pleasure to work under and learn from. Dr. John is a senior consultant who's actually very well known locally here and internationally as well. He got his training in the most of his training in the UK. He had many publications and work done in the international, in multiple international meetings. With no further ado, Dr. John, you have the floor.
Thank you for your very kind words. So good afternoon, everyone. I know it's a difficult time just after lunch. I mean, in Greece, we would usually have a siesta now, you know, for half an hour, but I hope I can stimulate your attention with my presentation. So, so I would like to start with a case just to emphasize, exemplify the difficulties we face when we treat patients with aggressive lymphoma. So this is a 56-year-old male. He presented to ER with constitutional symptoms, hepatomegaly, jaundice, and the initial, working diagnosis was biliary pancreatitis in the ER, but it turned out to be something more complicated. So he eventually had a PET scan which showed multiple, lymph nodes above and below the diaphragm. The liver, as you can see, was heavily infiltrated by a disease, and he had probably also hepatic nodules. So he had a liver biopsy which confirmed that he had diffuse large B-cell lymphoma, NOS, non-GCB subtype. Despite non-GCB, we did do FISH rearrangements, but they were negative. He had high LDH, and the overall stage was stage 4B. So the patient was treated with 6 cycles of R-CHOP, and he had an endotreatment PET scan, which, you're thinking about it, he had a very good response, but he had 2 residual lesions, as you can see, in the liver. So he was DeVille 5 primary induction failure. So what do you do with patients who have relapsed or refractory disease? The standard of care at that time was salvage and auto. And the CORAL study demonstrated that, first of all, it compared RDHAP with RIs, but this is not the point of me showing it. It's just that 50% of patients 60% of patients respond to salvage therapy, 50 will proceed to auto, and the 3-year event-free survival is 45% in those who have relapsed beyond 12 months, but 20% only in patients who have primary induction failure or relapse within 12 months, as you can see in the figure. So this patient received RDHAP 2 cycles, a PET scan after the salvage was DeVille 5, even though the previous lesions had gone away. He had a new lesion now, as you can see on the PET scan, so clearly progression DeVille 5. So what is the outcome of patients who fail salvage therapy? From the CORAL study, you can see here that the overall response to second-line therapy is 39%. Of these patients, only 31% will proceed to auto, and the median overall survival of this entire group is only 4 months. So it's clearly a group with poor prognosis and poor outcome. What about patients who failed 2 lines of therapy and are not eligible for auto stem cell transplantation? These patients too, as you can see, have a poor outcome. Event-free survival after second-line therapy, 5 months. Third-line therapy, 3.6, and median progression-free survival for the entire group, 4.1 months, and overall survival, less than 12 months. Again, dismal outcome. So these patients, in addition to patients who fail auto, were the subject of 3 phase 2 studies that looked into the efficacy of CAR T-cell therapy in patients with relapsed refractory diffuse large B-cell lymphoma who failed at least 2 lines of therapy. And these were 3 studies that looked at CAR T-cell products which were Axicell, Tisacell, and Lisacell. And I'm clearly showing you the results of the ZUMA-1 study because it has the longest follow-up. And as you can see here, with 5 years follow-up, the progression-free survival is just above 30%. with a clear tail in the progression-free survival curve, which clearly indicates that these patients are cured. So we can say safely now we have adequate long-term survival data to suggest that it is a curative treatment in these patients. And you can see the overall survival in the Zuma 1 at 5 years was around 42%. Now this was confirmed also in a US CAR T-cell consortium study, which clearly is the real-world data patients. And this was presented at ASH just recently. And as you can see, the 5-year progression-free survival was slightly lower, just below the 30% mark, and the overall survival was 40%. We should take into account that in this real-world setting, 42% of patients did not meet the Zuma 1 eligibility criteria, so they wouldn't have gone on to Zuma to receive it. I think we should emphasize that patients die of toxicity, so the non-relapse mortality in this study was 16%, and there is a proportion of patients who develop secondary malignancies, as you can see here. In this US real-world data study, 5% had myeloid. So in 2021, which was the treatment algorithm for patients with relapse refractory, so as you can see, patients who were eligible for auto went on to platinum-based therapy and onto auto if they responded, and if they failed, they would be eligible for CAR T-cell therapy. For patients who were not candidates for auto stem cell transplantation, they would receive second-line therapy, and again, those who failed would be eligible for third-line therapy, which also included CAR T-cell therapy and a variety of agents, as you can see there. So going back to our patient, so he had DeVille 5, so we referred him after failure of 2 lines of therapy at that time point to a center that provides CAR T-cell therapy. The cells were collected and they were sent for manufacturing. The patient came back to us. We bridged him with radiotherapy to this residual lesion he had in the liver. But because there was a significant delay in the cells being sent back, we also gave him a cycle of R-IGIV. He achieved a metabolic CR, DeVille 1, and we got the phone call from the CAR T-cell center, sent the patient, so the patient was sent and he received the CAR T-cell therapy. So as you can understand, since the CAR T-cells worked good in patients who had failed 2 lines of therapy, it was reasonable to think, why not push it to second-line therapy? And this was the purpose of 3 large studies, 2 of which were positive, which compared patients receiving standard of care salvage plus auto versus CAR T-cell therapy. So this is patients who have primary induction failure or have relapsed within a year. And this is the update of the Zuma 7 study, clearly because it has the longest follow-up. And as you can see here, in the progression-free survival in the CAR T-cell arm was 42% compared to 24% in the standard of care arm, which is highly statistically significant. If we look at the overall survival, just recently it was demonstrated that there's a statistically significant improvement in the overall survival in the CAR T-cell arm. As you can see, 55% versus 46% in the standard of care salvage plus auto. One could argue, why is it so good in the standard of care arm? The answer is the study did not allow crossover, so 57% of patients received third-line CAR T-cell therapy off protocol, clearly indicating this, around 50% of patients were alive, which is pretty good, clearly indicating that even as third-line therapy of CAR T-cell therapy works even in these patients. Again, non-relapse mortality in this earlier setting is still there, 10% of patients, around 10%, and there is a risk of secondary malignancies. Now, these are the CAR T-cell indications from 2016 to 2021 as from the IBMTR. And you can see clearly that the majority of patients receive CAR T-cell therapy of patients with large B-cell lymphoma. And on the right, you can see this figure of patients who received CAR T-cell therapy for large B-cell lymphoma. And in blue, you can see the patients who went on to CAR T-cell therapy without an auto before. So this was 33% in 2017, but at 2021, 81% of patients went on to CAR T-cell therapy without prior auto. So this clearly shows the switch in the indication of CAR T-cell therapy. So this is the new algorithm based on the results of these studies, and you can see that patients who fail chemotherapy in the upfront setting within a year, they're eligible for CAR T-cell therapy, but still those who fail beyond 1 year are eligible still for auto stem cell transplantation. And those who fail both categories, they are eligible for second or third line options, as you can see in the figure. Going back to our patient, he received CAR T-cell therapy, but soon after, within 2 months, he progressed. He had developed a soft tissue mass in the upper jaw in the canine tooth, and we did a biopsy of that. It was high-grade B-cell lymphoma, and he received radiotherapy. So the question is, what immunotherapy options do we have for these patients apart from CAR T-cell therapy? The answer is we have the antibody-drug conjugates, polatuzumab vedotin, we have loncastuximab tesarin. We also have tafasitamab in combination with lenalidomide, and the bispecific antibodies that target CD20, glofitamab and epcoritamab, which I'll touch upon these immunotherapies. So this is the pivotal study of polatuzumab vedotin, which is a anti-CD79B antibody, which is conjugated with MMAE, which is a microtubulin disrupting agent that is also used with brentuximab vedotin. And there was a phase 1 run-in study which was followed by a small randomized phase 2 study, 40 patients in each arm comparing Pola-BR with BR. And there was also an extension cohort including 106 patients, which included also 35% of patients were treated as second-line therapy. Now, based on these results, as you can see here, first of all, in the main study, the overall response rate was 62% versus 25% in the BR, and CRs, as you can see, 52% versus 22% in the main study. Progression-free survival, 9.2 months versus 3.7, as you can see here, if you can see it. And if you look at the median overall survival, 12.4 months versus 4.7 months. If we look at the pooled cohort, you can see clearly that the best overall response was better in patients who received the combination as second-line therapy compared to those who received it as third or beyond. And I think this is the most important observation here from this study, is that patients who are non-primary refractory actually have a very good overall survival who are receiving this combination compared to those who are primary refractory. So based on these results, this combination was licensed for patients who have failed at least 2 lines of therapy and are not eligible for auto stem cell transplantation. What about how does polatuzumab vedotin perform in patients after CAR T-cell therapy? You can see here clearly that so there is some activity. The overall response rate is 44%, with 14% of patients achieving CR. And you look at the progression-free survival, it's 10 months, and the overall survival is 17 months. So there is some activity even for patients who have failed after CAR T-cell therapy. What about tafasitamab lenalidomide? Tafasitamab is an anti-CD19 antibody. It works by inducing antibody-dependent cellular toxicity, as you can, sorry. How can I go back? One slide, sorry. Back. Back. Okay, sorry. So, sorry about that, yeah, it's okay. So it also induces antibody-dependent cellular phagocytosis, as you can see here, and direct cytotoxicity after interaction with the malignant B cell. Now, lenalidomide has a direct cytotoxic activity, but it also induces proliferation and activation of the NK cells. So when combining these two, you would assume that you'd get a better increased anti-tumor activity, and this was actually the case. Now, if we look at the study that was conducted combining lenalidomide with tafasitamab, it's the L-MIND study. And this included patients who had relapsed refractory disease, which were not eligible for salvage therapy, for autologous stem cell transplantation, 1 to 3 prior lines of therapy. but it excluded patients who had not received, who were refractory to R-CHOP, it did not include patients who had more than 3 lines of therapy, and none of these patients had prior CAR T-cell therapy. And here you can see the treatment diagram. I think what's emphasized here is the dose of the lenalidomide. It was 25 milligrams for 3 weeks, and each cycle was repeated every 4 weeks. And the primary endpoint of the study was overall response rate. Here you can see the combined efficacy of the TAFA plus lenalidomide. If you look at the TAFA working as a single agent, it induces a complete response of only 6%, as you can see here. Lenalidomide 13.2, but when you combine these two, clearly complete response, as you can see here, 42.5%. This is the duration of response not reached in the study when it was initially published at 64% at 18 months. And there was a 5-year follow-up of this study just published and you can see that the median progression-free survival was 11.6 months, and the median duration of response for the CRs not reached. So those who achieve responses have durable responses, but I must emphasize here, these are not heavily pre-treated patients. I mean, most of these patients had failed 1 or 2 lines of therapy. Actually, most of them was after 1 line of therapy. So we have to be cautious about treating patients with very aggressive disease after failing multiple lines of therapy with this combination. Ssbmt tesarin is a antibody-drug conjugate, which the payload here is a pyrrolobenzodiazepine, which practically, when internalized into the cell, it interacts with the DNA. It's cross-linked with the DNA, and it inhibits the DNA repair mechanisms and leads to cell death. So here, in this study, the LOTUS-2, which included patients who had failed at least 2 lines of therapy, it included also a small proportion of patients who had failed auto or CAR T-cell therapy, as you can see. The overall response rate was 48% with 24% CR, and the median duration of response was 10 months. Here you can see on the top here on the left, the responses depending on histology. And on the right top, you can see the adverse events grade 3 and above of particular interest. I'll just Some of the interesting adverse events is increased gamma GT in 16% of patients, and edema effusion in a proportion of patients, pretty low, 5% of patients. In an update of the study, you can see here that patients who achieved the CR, a significant proportion of these patients still maintained their disease-free status at 2 years, as you can see. Now, what about CD19-directed therapies after failing anti-CD19 CAR T-cell therapy? So, this is a question, how do these agents work? The answer is there is some activity, as you can see here. I mean, most of these patients had received TAFA, 75%, and LONCA was 25%. You can see here the progression-free survival is 8 months, median overall survival 21 months, and you can see the activity, the responses and CR rates of each of these agents. Our question is, do we need to check for CD19 expression in patients who have failed, for example, CAR T-cell therapy, and we would want to give them one of these agents? Because as we know, around 30% of patients who fail diffuse large B-cell lymphoma, the failure is associated with loss of CD19 expression of the antigen. So this study clearly just tells us that you have responses in patients who don't even have a detection of CD19 based on immunohistochemistry. And if you can see on this Wilcoxon graph, so this is the H score. It shows us it's a semi-quantitative assessment of the percentage of CD19 positive cells, and clearly responses were seen in patients with all levels of CD19 expression. Clearly, as I'll emphasize with immunohistochemistry. So they saw responses even in patients who had failed CAR T-cell therapy and did not express significant levels of CD19 on their cells. So The bispecifics. Bispecifics are, as you can see here, two have been licensed, epcoritamab and glofitamab. Epcoritamab is given subcut and is indefinite therapy until failure of treatment, while glofitamab is given is in a 2-1 format. It has two anti-CD20 molecules, as you can see. It's an IV infusion, and it's time limited. It's 12 cycles of treatment. Here you can see the two pivotal studies that led to the approval of these two agents in relapsed refractory diffuse large B-cell lymphoma. Both of these studies have a follow-up around 18 to 20 months. The median number of prior therapies was 3. 20% of these patients had failed prior auto. A third of the patients had failed CAR T-cell therapy, and more than 80% of the patients were refractory to the last treatment. So clearly we have a heavily pretreated population of patients in these two studies. And if you look at the overall response rates and CR rates, I just can mention here that the CR rates were similar. More than a third of patients either they had received CAR T-cell prior or not. So there was no difference in that. In the relapsed or primary refractory setting, you can see that there was a difference. So patients who have relapsed have higher response rates, 70% and 53%, compared to those who had primary refractory, 34% and 30%. The median duration of response, you can see how much it was 18% in 18 months in glofitamab, 12 in epcoritamab. And the median duration of CR was 27 months in the glofitamab compared to 21 months in the epcoritamab. And as you can see, CRs and ICANS were pretty low in both studies. Here's a study, a prospective study, looking at giving glofitamab in first relapse progression after failing CAR T-cell therapy. I mean, the message here is that you have a pretty good response even in these patients. Overall response rate 66%, complete metabolic response 36%, and the median overall survival in these patients was 18 months. What about patients who have late failure of CAR T-cell therapy? This is a registry study from the French group, and it compared the outcome of patients who had received after failure of CAR T-cell therapy, chemo-based targeted therapy, bispecific or radiotherapy. And as you can see here, the 6-month progression-free survival and overall survival looked better in those who had received bispecific. So going back to our case, as I said, he had received radiotherapy. We were planning on giving him polatuzumab in combination with bendamustine, but we found out that there was the registry study of glofitamab, and Roche kindly provided the opportunity for this patient to receive it. And he had actually progressed until we got the drug in our hands. He had progressed with the cervical, the stomach, T7, and muscle involvement. So he received his first 3 doses of glofitamab, and he achieved metabolic CR DeVille 1, and he's just completed 8 cycles of glofitamab and is due to have a PET scan. What about bispecifics before CAR T-cell therapy? Again, there's been a significant number of patients. There is some experience now using it. And as you can see, the overall response rate is 83% and CRs 43%. And there was a propensity scoring matching analysis comparing CAR T-cell without prior bispecific versus bispecific. And as you can see, there was no difference in the progression-free survival since the infusion of the CAR T-cell therapy. So in other words, infusing CAR T-cell, so giving bispecifics before CAR T-cell therapy is safe, and there is no issues regarding this issue. So regarding, dissecting choices between these dual immunotherapies in third-line therapy in large B-cell lymphoma, I think what's important to emphasize here,
2 minutes.
2 minutes, sure, is that, we have solid evidence that CAR T-cell therapy is curative, although for the time being with bispecifics we don't have that, so we should take that into account when deciding. Also, off-the-shelf availability, not applicable with CAR T-cells, but with bispecifics, yes. And of course, CAR T-cell therapy is only available in specialized centers, and bispecifics can be given in the community setting. I couldn't finish without mentioning allogeneic stem cell transplantation, because it is a form of immunotherapy. And here I just want to send the message that even for patients who fail CAR T-cell therapy, there is the option. I'm sure these are highly selected patients, but making this the correct choice, you might be able to salvage these patients. As you can see, the 1-year overall survival in this number of patients, 88 patients, was 59%, progression-free survival 45%, and GVHD relapse-free survival 39% in these patients. Finally, this is the treatment algorithm we have currently for patients with diffuse large B-cell lymphoma. I think it's clear to separate those who relapse within a year with those who relapse after a year, and we have a variety of second-line options, as you can see here, from CAR T-cell therapy to auto stem cell transplantation, depending on when you've relapsed, and a number of combinations and agents for the second-line therapy. And for the third-line therapy, as you can see, we have CAR T-cell therapy for those who are not exposed to it, and all these immunotherapies and agents I mentioned earlier. I think what's important to emphasize is that there are studies now being designed looking at drugs that were in the third-line setting to be moved to the second-line setting, combined with various agents. It'll be interesting to see how this affects the long-term strategies we use for patients we're treating. Thank you.
Thank you so much, Dr. Apostolidis, for the excellent talk. We'll move to the second talk, and it's my pleasure to introduce Professor Pierluigi Zunzani, who's joining us virtually. Professor Zunzani is an associate professor at the Institute of Hematology and Medical Oncology in University of Bologna. Is a well-known lymphoma expert, has published so many clinical trials focusing in non-Hodgkin and Hodgkin lymphoma, CLL, and new drug developments. Professor Zunzani will speak to us about the first-line therapy for Hodgkin lymphoma in young versus elderly. Go ahead, Professor. Can you speak now? We can't hear you, but we'll try to fix the sound problem. Yes, now we hear you. Professor Zunzani, we don't see your slides. No, but I'm not sure if you are able to share the screen or share the slide on the screen. No. Yes, now we see the slides. Okay, perfect.
concerning the real role of the addition of rituximab with conventional chemotherapy in our patient metastasis stage. The second step is which is the role of checkpoint inhibitors in front line. The first step was done several years ago with a cohort B of the Checkmate 205 study. This study included only 50 patients. At the end of the day, only 46 were evaluable for response. It was quite easy because for advanced untreated Hodgkin lymphoma, there were 4 administrations of nivolumab as a single agent, and then there was a 6-cycle nivo plus EBT. At the end of the day, you can see that the data published 4 years ago by Ramchandran and co-workers, the waterfall plot is really impressive in terms of evaluation. And this is the progression-free survival. The median progression is 9 months in 2018 was 92%. On the basis of this trial, there was another trial, of course, using the other checkpoint inhibitor, pembrolizumab. And under the co-workers, first of all, presented this data at ASH 2020, then 2021. This was the final publication of blood. Pembrolizumab, in this case, instead of nivolumab, 3 cycles of pembrolizumab before to start with EBD as a chemotherapy. And this was a very interesting trial because at the end of the day, after 3 cycles of pembrolizumab, the complete metabolic response was 75%. And if I come back to the whole deal of the Checkmate 205, after the first 4 administration nivo, the CR rate was no more than 30%. Quite similar to the data that normally can observe as nivo when we use in relapsed and refractory patients with Hodgkin. These are the median follow-up of 33 months. The 2-year protection visual was 100%. And this was the data at the final publication. Progression to survival 2 years was close to 100%. Of course, only 30 patients. But on the basis of this preliminary phase 2 study, 3 years ago started this huge trial in the United States and in Canada. The X80 study design, and you can see here the untreated stage 3 and 4 Hodgkin lymphoma with the random 1-to-1 comparing DV-ABD to the standard of care for stage 3 and 4 according to the FDA, and only for stage 4 of EMA 7-4 versus nivo plus EBD of 6 cycles on the basis of the coordinate of the Checkmate 205. The primary endpoint are the progression to survival, and as the end of the treatment, it was possible to use local radiotherapy for the residual FPGA disease. These are the hematological toxicity of these 2 different arms. At the end of the day, there was more neutropenia after the EBD because there was no mandatory to use the factor in this arm. There was more growth factor use and more pain in rituximab EBD. At the same time, in terms of infection, there was no increase in factor toxicity in nivo plus EBD. And when you compare the peripheral neurological toxicity, there was only 1% of peripheral neurological toxicity treated nivo versus 8%, of course, in the rituximab. At the end of the day, This is the progression to sugar after only 1 year. These data were presented by Alex Herrera at the last meeting, at the last ASCO meeting. There was the final publication. But you can see here also the stratification according to different subsets. There is an advantage for Nivo plus VD in all the different subsets. In particular, you can see here also that we will select a small subset of pediatric patients. Again, also in this case, the primary point of the ratio to sugar dominance is superior to the Nivo versus VD plus VD. And the same situation also in elderly patients with the definition of age more than 60 years. Again, there is an advantage for Nivo plus 8. And when we move to elderly patients in front line, actually there were 2 phase 2 studies in my state, the same scheme, rituximab plus Nivo, on the basis of the fantastic data of this combination of the 2 different monoclonal antibodies, second line for Hodgkin lymphoma. At the end of the day, in the Chisholm publication, also John Profit publication, the result of Persina, I mean, the CRE is quite interactive. At the end of the day, there are several relapses in the first 18 months. You can see here the phase 2 study published by Chisholm and Walkers, and also the data, these are the data of the other trial, the same study schema, by Friedberg and Walkers published a few months ago in Blood, where you can see here the progression to survive. So at the end of the day, the rate is more than 60%, because it's the progression to survive. This is so difficult to maintain the response. At the same time, in Europe, the German group decided finally, but this decision was done several years ago, to modify the escalated people with the introduction of rituximab. First of all, there was a HD when we studied with pick the winner between 2 rituximab escalated people like regimen, head-to-head evaluation. At the end of the day, the winner was the black card. And on the basis of that, there was the HD21 trial to compare the black card versus the conventional escalated people. The concept was to introduce the rituximab because it's very active on the basis of a lot of data in the labs of characterization, but in particular the frontline on the basis of the heteromaster. At the same time, it was important to reduce the toxicity that is intrinsic to escalating. And there was some modification. There was a reduction of etoposide. There was the addition of bleomycin. There was a reduction of there was a reduction of lacabazine and the deletion of lacabazine to reduce the risk of sterility. And there was also the deletion of prednisone and the introduction of steroids of desmopressin. And the introduction of lacabazine instead of lacabazine. So the tentative was to reduce the lung toxicity, hematological toxicity, and also the state. Of course, the moderation of increasing with the introduction of rituximab in the schema to avoid the neurological toxicity. And you can see here the remodeling the escalated vehicle with the introduction of rituximab according to the concept that I have already show. The other important point here is the study scheme. HD21 freeze randomized comparing more than 1,500 patients which age between 18 and 60 or untreated, of course, advanced classical Hodgkin lymphoma to compare the breakout versus the escalating. There was a two-cycle then, there was an injury at the CT scan evaluation, and for the patients in the breakout arm, for patients who had a PET negative, they continue for two cycles of breakout, but the PET positive, they continue for other 4 cycles. The same situation for the patient included in the ECOG, in the escalated ECOG, if the PET2 negative was negative, 2 more cycles of escalated ECOG, or if the PET2 was positive, 4 more escalated ECOG cycles. And you can see here the demographic elevation characteristics. There are no statistically significant difference in any kind of characteristic when you compare the 2 different arms. And also you can see here in terms of different risk factors like asthma, external tumor, external disease, elevated SCR, or the number of recovered careers, more than 6. Anyway, another important point was to evaluate, first of all, the acute and hematological, non-hematological. In this case, in particular, the non-hematological change-related mortality. You can see here, when you compare escalated ECO versus breakout, in terms of neurological toxicity, grade 3 and 4, there are no difference, of course, because of the function of evidence that they were tolerated, and if there are some neurological toxicities in the majority of the cases, grade 1 and 2, so there are no difference, 2% in this study, 1% in breakout in terms of grade 3 and 4. And also in terms of respiratory disorder, 4 and 3%. And also in terms of cardiac disorder, there are no difference, 1 and 2%. And another important point is the acute hematological component. This was another important point because one of the important consequences with the idea to have a more escalated like treatment was to have a reduction in hematological doses. And with the reduction, there is a reduction of hematological toxicity in terms of anemia grade 3 and 4, in terms of thrombocytopenia grade 3 and 4, and also in terms of white blood cell grade 3 and 4. This was really important to the demonstration in the red card. This is very well tolerated, very well used in terms of hematological toxicity when you compare with the combination of this. There are no difference in terms of infection grade 3 and 4, 19% versus 20%.
2 minutes, Professor Zan. 2 minutes.
The point is the concept of treatment-related mortality, including together the organ toxicity, grade 0 more than 3, and was 17% for escalated ECO, 19% for breakout. At the end of the day, in terms of treatment-related mortality, TRB, there was 59% for escalated ECO versus only 42% in this case. The endpoint was reached because there was a really important reduction of the treatment-related mortality using the breakout steroid escalated in the different statistics. Another important concept when we have to compare these two trials is some clinical implication. So the concept in the real life of red cell transfusion was 53% of spherical Pico, only 24% of the count. Platelet transfusion was 34% for spherical Pico, was 17% of the count. As I said before, in terms of neurological toxicity, we see a quote that only 2% of spherical Pico, 1% of the count, and at the end of the day, the treatment result is quite similar. Minus 1% for spherical, 0% for. Another important point is treatment exposure in the ITT population. This is another important point when you compare the 74 patients that with stated as the 74 patients in the country, and at the end of the day, treatment with either 4 or 6 cycles in deep metabolic response was seen in 80% and 82% of patients in the escalated Pico and breakout of respectively. So this CRA is absolutely the same, 80% versus 82%. And these are the data in general of the primary form, correction issue. If you remember, the primary point of the liver trial from Canada and the United States, the one was at 1 year progression to have this 3 year progression to there is an advantage for the child, and it's 94.9% versus 92.6% for this group.
Prof. Nzani, you hear us?
Yeah.
If you can wrap up in 1 minute.
Yes.
Thank you.
It's the 3 year progression to survival according to the 30 negative. For cycle at the end of the treatment, 30 6 cycles. There is again an advantage in terms of the year progression to survival for the red factor in both situations. And if you check in terms of sample analysis, in terms of progression to survival, in terms of interrelated mortality, there is an advantage for all these different subsets for that. And also the patients receiving full dose of the cycle is another important point. From cycle 1 to cycle 6, there is an advantage also again for that. And finally, is another important point, is the gonadal dysfunction, and again, also in this case, there is another important endpoint to reduce the risk of sterility when we modify the new steroid-like regimen with the inclusion of the functional and also in this case was possible through the gonadal function recorded after 1 year. It is a fantastic reduction of this risk of toxicity when it is reactive instead of so at the end of the day, now we are waiting for the potential registration of the 2 different trials, liver versus and also the correct factor, and the risk it's not the risk, but actually to be a benefit for our patient, also for the doctor, who have in the really next future 3 different treatment for the same subset feature. I mean, stage 3 and 4 advanced and treated Hodgkin lymphoma. Brain functional relative class B, the potential trial now, liver and thank you very much for that.
Thank you very much. I'd like to move to the next session. Okay. So I guess we'll just go with the Q&A session for Dr. Zinzani first, since we have him on the call before we move to the next
question.
Yeah, I guess that's. So if anyone have any questions, please go ahead.
I have a question to Professor Zinzani. Prof, so this is Riyad Dada. So are you going to adapt this pre-card regimen from the German? Have you been using the escalated Jacob and you are now switching to pre-card, or are you going to replace EBVD if you are using EBVD in advanced stages by pre-card?
So it's really difficult because if you check the data, it seems that breakup is more effective in terms of complete metabolic response, reducing internal progression to the body. But for some hematological, particular extra-hematological toxicity and being overall fertility and fertility versus sterility, we need more time to really understand which kind of potential toxicity. And it could be difficult to decide in the future whether there will be efficient application of both of them for our patients. Another important point to remember the potential role of EBVD in patients, because in the breakup, the cutoff of the range was 60. On the other hand, in the EBVD was a possibility to also subset of patients for 60, and there was a very interesting data presenting the advantage of Evo class EBVD versus the class.
Thank you.
Any other question for Prof. Zinzani? Okay. So thank you, Prof. Zinzani. We'll move on to the next talk. Thank you.
Ciao.
So it's with pleasure I'm presenting Professor Riyad Dada. He is a senior consultant at King Fahd Specialist Hospital, or King Faisal Specialist Hospital Research Center in Jeddah. He completed his training in Germany, and then later he was a senior consultant at Aachen University, and he's been here in Jeddah since 2011. He's a very well known in the lymphoma field with many presentations and publication. Without further ado, Doctor, you have the floor.
Thank you very much. Thank you, Dr. Omar, and thank you, Dr. Ahmed. Moderators are caring of us. Dr. Ahmed gave me a big piece of meat during the lunch. I hope you will be generous and give me additional 2 minutes by the end of the talk. So, Bismillah ar-Rahman ar-Rahim. I will start by thanking the organizers, أستاذنا وحبيبنا دكتور أحمد العسكر القائمين على Ssbmt, Dr. Ahmed al-Absi for the invitation. I was given this talk, mantle cell lymphoma, where we stand in 2024, as if it's not difficult enough to speak about mantle cell lymphoma because there are too many unanswered questions, and 2024 has just started. But inshallah, together we'll do the best out of this. These are my disclosures. So this is what I'm going to speak about, risk categories, optimizing of chemoimmunotherapy, novel agents, and future direction. And I will have too many clinical studies running where we are awaiting some answers to be, some questions to be answered. So, likewise, diffuse large B-cell lymphoma, mantle cell lymphoma is not one disease. It's a heterogeneous disease. Mainly, we are distinguishing between the classical mantle cell lymphoma, which is an aggressive disease. It's usually SOX11 positive, unmutated IgG/HV. It has an aggressive behavior, and around 10% of the patients they
having TB53. And the other one, which is the other form, the indolent form, is it could be a leukemic one, non-nodal, or involving just the gastrointestinal tract, or nodal indolent mantle cell lymphoma. These group of patients have usually favorable prognosis, less aggressive disease. They are characteristics by a Ki-67 if less than 10%, and usually they do not express SOX11, and they are EGHV mutated. So mantle cell lymphoma is a disease where it favors males than women. Yani, all women be happy. Your chance to get mantle cell lymphoma is less than females. The median age is 60 to 70 years old, and the majority of the patients when come to us, they are in advanced stages. 20 to 60 to 30% of the patient, they are having a leukemic presentation and having a favorable prognosis. Extranodal involvement is common in this kind of disease. The prognostication of mantle cell lymphoma, as we mentioned, we have a low-risk patients. Ki-67 is less than 10%, SOX11 negative, IGHV hypermutated or mutated. They don't have complex karyotype. GI tract only disease is usually having a favorable prognosis. The high-risk patient, as we mentioned, blastoid and pleomorphic histology, the Ki-67 is 30% and above, and they have a complex karyotype and TB53 mutated usually. The risk categorization of the patients is important because the overall surveillance, as the prognosis of the patient is different. You can see here MIPI, which is age, ECOG, LDH, and WBC. They have the low-risk patient, they have a better overall survival than the high-risk patients, high MIPI score patients. Ki-67 30, and above this, the cutoff is 30. More than 30, less favorable prognosis. Less than 30, prognosis better. But TB53, they don't have a good prognosis. The blastoid variant versus non-blastoid variant, also favorable versus not favorable. So when we decide on treatment, it's not only the disease factors what we are looking for, and patients factors, age, comorbidity, and so on. So, and we have learned in the last few decades to distinguish patient, and this is very important when we start the patient on initial treatment, to distinguish between patients who are eligible for intensive chemo and those who are not eligible for intensive chemo. This is very important at the beginning of treatment. But we have always to, when we look to the patients, we have always to consider one factor, which shall I treat this patient or shall I observe this patient? Early treatment is not necessarily improving the outcome of the patients. The advanced stage patient, as I'm speaking of stage 3 and 4, stage 1, I would treat maybe radiation. But I'm speaking here about advanced stages. If you treat the patient early or late, or later on, the same outcome. That's why some a subset of patients, they might be observed and you don't need to treat them. The advancement of management of Hodgkin mantle cell lymphoma has started 2002 with the introduction of R-CHOP. R-CHOP at that time, it was a magic for all B-cell lymphoma, including mantle cell lymphoma. And advancement continues with the introduction of high-dose RSC and autologous stem cell transplantation. And there are different trials. Here are some selected trials done in patients who are eligible for transplantation, and this is a landmark trial. The MCL Younger trial where young patients were treated with either 6 cycles of R-CHOP versus 6 cycles of R-CHOP alternating with DHAP. DHAP, there is cytarabine, right? The patient thereafter, without randomization, the randomization happened at the beginning, and the patient thereafter, both groups went, if they reach complete remission or a partial remission, for autologous stem cell transplantation. And you can see here in the right side that there was an improvement of the TTF, time to treatment failure, in favor of patients who receive cytarabine containing regimens. And we have been always saying in the last year, yes, cytarabine containing regimen is important. Cytarabine containing regimen is important if you go for autologous stem cell transplantation in patients who are eligible for that. But so far, there is no improvement in overall survival. That's what we have to keep in mind. A subset of patients from the MCL2 and MCL3 trials looked whether the autologous stem cell transplantation improves substantially the outcome of patients with difficult to treat mutation, difficult to treat disease, which is the P53. It doesn't influence too much. The patients with P53 still, they have, without the era of autologous stem cell transplantation, they had also a not very good outcome. Then we want to improve the outcome of autologous stem cell transplantation further. So this trial looked, the LISA study looked to maintenance rituximab post-autologous stem cell transplantation, also for patients who are eligible for intensive chemo, versus observation. 3 years of maintenance rituximab versus no rituximab. There was a progression-free survival improvement and overall survival improvement, and these data were really striking, and even the follow-up data just recently published beyond 10 years and beyond, you can see that the progression-free survival is increasing from around 20% now to 30%, and the overall survival benefit is also increasing from roughly 9% to now 11%, which means rituximab maintenance is really something which we have always to think on when patient is getting his autologous stem cell transplantation. But this study did not answer the question whether bendamustine, rituximab, prior autologous stem cell transplantation is as good as cytarabine containing regimen. And this was addressed here in the randomized trial, the SWOG trial S1106. And you can see here that the progression-free survival and overall survival, if patient was receiving BR, prior autologous stem cell transplantation, it was not bad. It was as good as hyper-CVAD and cytarabine. But the study was terminated because of the toxicity of higher CVAD. And another question, another answer, what we getting for the answering this question is from the retrospective data collection from British Columbia, where they collected their data for patients who received RB, rituximab, bendamustine, followed by autologous stem cell transplantation, followed by maintenance rituximab, and compare these data, cross-comparison, retrospective and randomized trial, and they didn't find any difference in terms of progression-free survival and overall survival if patients receive bendamustine and rituximab. So why to go now for cytarabine? Why to go for cytarabine-containing regimen? Because it's toxic. So moving forward to patients who are not eligible for autologous stem cell transplantation, and we have a couple of trials. The first two trials are the STEEL trial from Germany, from Rommel, then the BRIGHT trials, and both of them conducted in follicular lymphoma and mantle cell lymphoma. They showed clearly that bendamustine rituximab is superior to R-CHOP, and since that time we have been using for elderly patients bendamustine and rituximab. But these two trials did not answer two important questions. The first one is
whether in elderly patient, bendamustine and rituximab is as good as low dose of cytarabine containing regimens. And this is being answered maybe in the data collection from the Flatron records with more than 4,000 patients. And you can see here in the upper part of this cartoon that patients who received bendamustine and rituximab, they did as well as patients who received cytarabine containing regimens. Another important question which was not tackled and answered in the BRIGHT and the SEAL trial, can I use rituximab maintenance? Is it beneficial after bendamustine? And this was also addressed in this retrospective data collection where the red curve is the bendamustine rituximab followed by maintenance rituximab. You can see here that this group of patients are doing the best in terms of progression-free survival or time to next treatment, and the overall survival was not different. So science is moving forward. Now we have a new era of PTK in the management of CLL and mantle cell lymphoma. And these agents are being now incorporated in area line. And we have plenty of studies where we got some trials results and other are still running. In treatment-naive transplant-ineligible patients with chemotherapy as backbone, as a novel agent with chemotherapy, or treatment-naive transplant-ineligible patients with chemotherapy as backbone, or even without any chemotherapy. So we'll see it together in the next slides. Triangle, recently published, and I think all of you are aware about this, R-CHOP, RDHAB, followed by autologous stem cell transplantation. That's what we have been doing it for a couple of years, versus R-CHOP, RDHAB, plus ibrutinib, and ibrutinib here was given only in those patients who received, during the cycles where a patient received R-CHOP. As when they received RDHAB, the 3 cycles, they didn't receive ibrutinib. Followed by autologous stem cell transplantation, followed by 2 years of ibrutinib maintenance, versus the same regimen as an IE, but without transplantation. So the event-free survival, you can see that the ibrutinib arms, they are better, by far better, in terms of failure-free survival than patients who receive autologous stem cell transplantation without ibrutinib. Overall survival is still, I think, premature, and we have to wait a little bit in order to make a final decision. Ibrutinib with R-CHOP and RDHAB, it does well in all high-risk subgroups, with the exception of MIBI. It was good in all MIBI scores. Then, and this is a very important trial is currently running. It will answer a very important question, whether do we still need cytarabine-based or cytarabine regimens to be integrated in the management of patients with elderly patients. And in this trial, BR and rituximab cytarabine will be compared with BR and rituximab cytarabine and acalabrutinib. We know acalabrutinib might induce less arterial fibrillation and so on than ibrutinib, versus pure PR and acalabrutinib. This is a very important trial, and we are waiting for the results of this trial. This study will also address the MRD negativity rate, and the MRD negativity, or MRD, is being discovered now in diffuse large B-cell lymphoma and follicular lymphoma, and we have it also in CLL and mantle cell lymphoma. And this is another very important trial in transplant-eligible patients, acalabrutinib and CHOP without vincristine but here bortezomib is being replacing vincristine, alternating with acalabrutinib, rituximab, and cytarabine. Cytarabine is still here incorporated. Another study, which is the BRIDGE trial, is looking to R-CHOP alternating with R-DHOX. Platinum was removed and replaced by, cisplatin was removed and replaced by oxaliplatin, together with zanubrutinib. Autologous stem cell transplantation was optional, and still optional, and patient receive zanubrutinib. Then, in patients who are not eligible for autologous stem cell transplantation, the SHINE trial, which is a phase 3 trial, randomized ibrutinib plus bendamustine and rituximab versus bendamustine and rituximab in patients who are not eligible for transplant. And you can see ibrutinib improved the progression-free survival. Arterial fibrillation rate increases with ibrutinib up to 14%. Although the endpoint of the study was met, but unfortunately the study did not lead to first-line approval of ibrutinib because of the toxicity, as you can see here, and there was no overall survival benefit. And this is really a good one. This hopefully will lead to approval of acalabrutinib. We don't know in patients who are ineligible for autologous stem cell transplantation. This is the ECHO trial. As of bendamustine rituximab plus acalabrutinib or placebo, and we are awaiting the results of this trial. Hopefully we will have less side effects because acalabrutinib has, in terms of cardiac events, less events than ibrutinib. And this ECOG E1411 trial is looking whether we can enhance the efficacy of BR by adding Velcade, which is bortezomib, in the induction treatment, and another 2-arm, in this 4-arm randomized trial, is addressing whether we can add lenalidomide to the maintenance. And you can see here, Velcade did not improve the outcome of the patient, although the overall response rate and the complete remission rate is exciting in both arms. Regarding the maintenance, it's too early to decide and to say whether the adding of rituximab and lenalidomide post this regimen will improve the outcome of the patient. And this is also another very important trial currently running, is an MRD driven. And this might help us in saving money and saving toxicity for the patient. Patients who are MRD negative after induction regimen, if they are MRD negative and reach complete remission in the images, they will be randomized to receive rituximab maintenance or autologous stem cell transplantation and rituximab. This will really address the question whether those who are MRD negative, they don't need autologous stem cell transplantation. And we have the novel agent now are introduced slowly in the upfront setting in different groups of patients with mantle cell lymphoma. This is the BOVEN trial, where this is dedicated for TP53 mutated patients or those with P53 overexpression. Zanubrutinib will be here used together with obinutuzumab and venetoclax as a pure chemotherapy-free regimens. We have some data really striking overall response rate of 95% and the 16 months progression-free survival in this really very difficult to treat population is very encouraging with 75%. Acalabrutinib, lenalidomide, and rituximab. You can see here the overall response rate, and with this pure chemotherapy-free regimen is really very high. Overall response rate is 100%, complete remission rate is 83%, and the response was not associated with MIB score, Ki67, and TB53. I think the PTKs, introducing the PTKs in the upfront setting will lead us to write the risk categorization of mantle cell lymphoma in you. And this is another study of ibrutinib rituximab in the first line, also encouraging overall response rate, but the atrial fibrillation, grade 3 atrial fibrillation was high, 22%, and this is something what we don't like in ibrutinib, and we don't understand fully all the mechanism of action leading to these adverse events, but in ibrutinib, the atrial fibrillation might be related or attributed to inhibition of the PI3 kinase. Very important studies which are currently running in upfront setting is a Ssbmt trial. This is in treatment-naive patient and relapsed refractory patients, where ibrutinib will be combined with venetoclax versus ibrutinib and placebo. And another really not less interesting study is the Alliance trial. And this is the study, the design of the Alliance trial for untreated patients who are 60 years and old. Zanubrutinib and rituximab will be given as induction, and the patient will be thereafter randomized to continue zanubrutinib, or if they reach a complete remission, to stop zanubrutinib and take it after progression. This is also another interesting study, which is money saving and saving complication for the patients. The history and the story of interesting studies not ending. Enrich trial is also currently running. Our chemo versus ibrutinib and rituximab, and we have some data with encouraging overall survival. The Mangrove trial is also another very interesting study, which is challenging the bendamustine and rituximab versus pure chemotherapy-free regimen, zanubrutinib and rituximab in patients who are 60 to 70 years old. These data from lenalidomide and rituximab, I think I have to hurry up because of the time. Another very important trial here running, pure chemotherapy-free with encouraging results. And there are many other trials running here just from the MCL network, the Carmen trial, rituximab, ibrutinib, followed by CART, up front. Really very strong one. The Enrich, which will finally answer the question, rituximab and ibrutinib is better than R-CHOP and bendamustine, and so on. And the direction is in the last few years is like in CCL and CLL is to try to stop treatment once the patient reach or have MRD negative. We haven't reached yet there, but there are encouraging data. And in terms of relapsed refractory patients, there are different options, including CART, Ssbmt, with improvement of overall response rate and complete remission rate, duration of response, and progression-free survival in relapse and refractory patient. And we have many options for the second line. We have acalabrutinib, zanubrutinib. As I have focused my talk in first line, we have the non-covalent BTK inhibitor as pirtobrutinib in the third line. And as you can see here, the non-covalent BTK inhibitor, they are binding in a different region in the BTK than the first and second generation BTKs. The most acquired resistance for BTK I'm finishing. In CLL is the mutation in C481. But this is not the case in mantle cell lymphoma, so we have to be cautious. And we have novel antibodies which are being currently studied in mantle cell lymphoma. This is the scheme how we may manage mantle cell lymphoma, and because of the time, we'll go to the conclusions, which are more questions than conclusions, because this is the nature of the mantle cell lymphoma. It's really, there are many questions that are still unanswered, and some of the studies are running in order to answer this question. What is the role of BTK inhibitors in transplant-eligible patients? This is being currently addressed. The triangle, we saw it in the BRIDGE trial and the A1804 trial. Can we improve BR in first-line setting without transplant? The ECHO trial, we have seen it, incorporating also novel other agents. Can we reduce use of chemotherapy as initial therapy for patients with mantle cell lymphoma? We are awaiting the results from the Ssbmt trial in the first line. There is Ssbmt on the second line, and there is Ssbmt on the first line. And we have to choose between BR and rituximab plus BTK inhibitors in the first line. This is being addressed currently with the Mangrove and Enrich trial, as we could see. Should we be using BTK inhibitors in first line or save them for subsequent lines? This is still unanswered and unaddressed. Can we stop BTK inhibitor in patients reaching a complete remission? And this is currently being addressed in the Alliance trial, as we could see with the acalabrutinib. And lastly, MRD-driven treatment is going to be standard of care, and I hope that the EA415 study will address that. With that, I would like to thank you, and the question at the end, right? Will I know? Thank you very much.
Thank you, Dr. Riyad. It's my honor to introduce the last speaker of the session, Dr. Murtada Al-Khabouri. He is an associate professor at Sultan Qaboos University, and he is a senior consultant hematologist at Sultan Qaboos University Hospital. He will speak to us about updates on CML. Go ahead.
Thank you, Dr. Ahmed, for the introduction. Again, thanks the organizers for the invitation. By now, after lunch and the last talk in the session, your melatonin level must be like very high. Anyway, to compensate, inshallah, it will be shorter than 25 minutes. So what we will try to cover in this talk about those 4 questions. What are the updates in the classification, the WHO classification of CML, and the view on the therapeutic targets? The second is the value of low-dose dasatinib in the newly diagnosed CML. The third is asciminib in newly diagnosed CML. And the last talk is, sorry, the last question is the value of the combination therapy. So we start with the WHO classification. So if you compare, if you look at the WHO classification in 2016 and you compare it to the 22, the difference when it comes to CML is the disappearance of the accelerated phase. In 2016, we called CML accelerated phase if there was persistent splenomegaly, leukocytosis, thrombocytosis, and responsive to therapy. Persistent thrombocytopenia not related to therapy, basophils more than 20%, blasts more than 10%, and additional clonal abnormalities either at diagnosis or on therapy in the PH clone. Those were the definition of the accelerated phase. Now the accelerated phase now disappeared from the current WHO classification, and all of these factors plus additional factors came into the risk classification. So now those are high risk features in CML. So that's one change. When you look at the therapeutic targets, the therapeutic targets stayed the same. So to start therapy, the early risk stratification, the 3 months, 10% at 3 months, 1% and at 6 months, and 0.1% 3-log reduction, what we call MMR, at 12 months, stayed the same. There is no change. Also, the failure definition did not change, which is about 1 step higher. So like when it comes to 10%, instead of 3 months, now it is at 6 months. And that applies to 12 months and at any time. So these did not change. The next is the value of the responses. So we know some responses are associated, these are molecular lab responses. They're associated with clinically important outcomes. And the first outcome that we know is important is the CCYR, what was called as the safe haven of CML. Once you achieve you go into CCYR, your risk of progression is very low. So again, the view is the same, that CCYR at 1 year correlates with the better overall survival. Also, when you look at the MMR, the 3-log reduction, also the MMR correlates with better progression-free survival and also better overall survival. Also, when you look at the deep molecular responses, these deep molecular responses, the value of these responses are more to do with attempting the TFR. So these views on these targets stayed the same. So the only change is the disappearance of the accelerated phase. Now, the second question is in the therapy of CML is the use of low-dose dasatinib. Many of us kind of used low-dose dasatinib, like 50 milligram, in patients who could not tolerate 100 milligram. This study examines the value of that approach. And the rationale for that study is trying to decrease the toxicity of patients with CML. So what they did for newly diagnosed CML, there were 83 patients who were enrolled into that study, and they were started with 50 milligram. In patients who had suboptimal response in the study, they were increased to 100 milligram daily, and those were based on the ELN guideline. Those who had significant toxicity, they were decreased to 20 milligram daily. So there was dose escalation and dose reduction based on efficacy and toxicity. Now the endpoints are, you have the lab endpoints, the CCYR, CMR, MMR, and MR, deep responses, MMR 4.5, and the clinically important endpoints, the failure-free survival, the overall survival, and the other survival endpoints. Results. So if you look at the baseline characteristics, the median age was 47, but it included patients from 20 years of age to 84 years of age. The other thing to highlight in the baseline characteristics is the so-called risk category. There were like 64% of patients were low risk category. However, the 30% were intermediate and 6% were high. Even those with intermediate and high risk so-called category were enrolled into this study. Results. So the study was, the results were presented earlier, and that's the long-term follow-up at 60 months. And if you focus on the box here, the CCYR at 60 months, almost 100%, 98% achieved CCYR. That's safe haven. The MMR, again, very high, 95%. The deep responses between 70 and 83%. The complete molecular response was 70%. Again, very good for either the safe haven, decreasing the risk of projection, or even if you plan a TFR later on for that patient. So even when you look at the overall survival, the other clinically important endpoints, they were also very good. But these tend to be well in patients with CML. Now, what happened when you look at the toxicity was also probably lower than what is reported in the 100 milligram studies. If you look at the high grade toxicities, most of those toxicities were between 5, 7, and 1 and 2%, so they were generally low. And when you look at any grade toxicity, they were reasonably lower than what was reported, but not that bad. Specifically, when you look at the pleural effusion and grade 3 to 4 toxicity, only 2% of patients had grade 3 to 4 pleural effusion. So overall toxicity may be better than what was reported in the 100 milligram daily. Now, what happened to those patients? 9 out of 81, you had to increase to 100 milligram. And most of, so you had to increase to 9 because of these indications. Now, 20 out of 81, you could decrease it to 20 milligram once daily, and this is mostly because of the adverse event. When you look at the change to TKI, 10 out of 81 had to be changed because between adverse event, suboptimal response, and physician discretion. Also, for the treatment-free remission, there were 8 who attempted TFR, and only 1 of them lost the MMR. So all important goals of therapy may be achieved with that approach. So that's the low-dose ssbmt. The next question is the use of asciminib, the new TKI, in the management of patients with CML frontline, upfront therapy. So this is a phase 2 study that addressed that question. They included patients with newly diagnosed CML and gave them 40 milligram BID of asciminib, and then they continued. Now, if they had suboptimal responses, again based on the ELN, the early response targets, they may be increased to 80 milligram BID, so almost doubling the dose. And if they fail, they could be changed to ninoltinib, dasatinib, or imatinib. So kind of you go asciminib and I don't have a response, you go to imatinib. But that's the protocol. You look at the baseline characteristics, almost like 56 or 57 years was the median age, again included a good range of age. When you look at the ELTS score, again similar to the SOCAL score in the previous study, almost 67% were low, but then they were like 30% and 5% intermediate and high risk. So there's a good proportion of patients that are not low risk category. Let's look at the results. The early molecular response, which was the primary endpoint, 93%. So again, very good response, and this is early molecular response. When you look at the MMR, almost 50%, and the MR 4.5, 14%. So impressive responses. And then when you look at, that was at 3 months. When you look at 12 months, again, the responses where the MMR was here improved to almost 80%. You look at the toxicity were not as we initially thought of asciminib. So 11% thrombocytopenia, hematological toxicity, and when you look at the, this is 11%, so almost 100 patients, and 5% grade 3 to 4. When you look at the lipase elevation, and I think one of the patients or more had clinically acute pancreatitis in that study, not much, but still, 16% lipase elevation and 6% grade 3 to 4. So, and fatigue lethargy 18%. And again, the people who stopped it because of lipase, amylase, and pancreatitis. So it's important to look at this category when you try to administer asciminib to those patients. So when you, I know from they have a phase 3 trial now comparing asciminib versus the other standard, versus actually nilotinib, again, two Novartis drugs. And what we hear that the study met its primary endpoint, and maybe now asciminib is getting into the approval in the first-line therapy, but it's yet to be confirmed. The last question is the combination therapy. So this study looked at the value of combination therapy, but in patients who like in CML who did not achieve deep molecular response at 1 year. And this is the design of the study. Those patients who at least 1 year of the first-line imatinib had a BCR-ABL on international scale between 0.01 to 1%. And they had four or five, actually four, that imatinib, it was later stopped, between asciminib 40 milligram combined to imatinib, so they will add asciminib 40 milligram. They will add here in the second group 60 milligram of asciminib to imatinib, switch to linotinib, or increase the dose of 80 milligram asciminib. The baseline characteristics were also morely balanced, but there were significant differences in some of the areas. So when you look at, let's say, the median age, 48 years for asciminib 40 milligram with imatinib, which is higher than the rest. And the median prior duration of imatinib was also slightly different between the groups. And those who had MR2 and MMR were also different between the groups. It's a small study, so you expect some differences in the baseline characteristics. Responses. So the primary endpoint 4.5 at 48 weeks, but here this is 24 weeks, and the other one is 48 weeks. 14% for adding asciminib 40 milligram, the 19%. And then when you, for the, again, adding higher dose of asciminib, 60 milligram, and when you look at the 48, this has slightly increased from 14 to 19 and from 20 to 28%. Compared to the other, this has kind of stopped, so about 10% for those who use switch to linotinib, and 5% at 4. So it looks like if you add combination with either 40 milligram and or 60 milligram, you get numerically better responses than if you switch to nilotinib. So when you look at the median, also the median was much faster for patients who had combination therapy. And the rationale for combination therapy here, I mean, both the imatinib and the asciminib works on two different sites of the BCR-ABL. So this is why you are able to get into your primary endpoint with much faster median times. Toxicity. When you look at these are high toxicities, but it's similar between the groups, whether you would start 40 milligram, 60 milligram, or you switch to nilotinib, the toxicities were the same. You look at the serious adverse events and adverse events leading to discontinuation or interruptions, again, they are similar between the different approaches. So whatever approach you choose in this group, you get similar adverse events. When you look at the patients who had at least 15% adverse event, you see that this is where maybe that additional combination increases the adverse event. The nausea, the diarrhea, the myalgia, and the the pruritus, but mostly the GI side effects. So, good, I finished now in almost 17 minutes. So what we covered in the last 20 minutes or so is to talk about updates on the classification of CML between 2016 and 2022, the approach of using low-dose dasatinib in newly diagnosed CML, asciminib in newly diagnosed CML, and we look for the approval in the primary, in the first-line therapy, and the value of the combination therapy. And with this, thank you for listening.
Thank you, Dr. Murtada, and that will give us extra time for the discussion. So I would like to invite the speakers, Dr. Riyad and Dr. Abustelides, for the discussion. Any questions? We have a question from there.
Thank you. Thank you very much for comprehensive talks. So, Dr. Dada, my question, where you put the auto transplants? So in the presence of the phase 3 trial, using ibrutinib maintenance for like 2 to 3 years. So where you put auto transplant multiple lymphoma in 2024? Thank you.
I want to see on the shelf, but I can't see on the shelf. You can see in the two arms, the IE arm and the I arm, that there was no difference in progression-free survival in both arms. They are equal, but better than the arm with auto without ibrutinib. The question what's needed to be addressed on this is for the question for the future, and that's why the triangle concept, I don't know whether we can adopt it from now. We have to wait. We need at least 5 to 10 years in order to see whether there is a separation of the both corps, the arms, the I arm with ibrutinib without autologous stem cell transplantation might be non-inferior, continue to be non-inferior in terms of progression-free survival and overall survival to the auto. This has to be, I think, looked at in the future. But we have to think, I think, a little bit out of the box. We have to look differently. The triangular trial adopted, it was initiated by the way 2016, adopted a backbone of R-CHOP regimen, which is meanwhile, I would say, maybe outdated. We know that bendamustine is doing a good job and better job than bendamustine rituximab, and there are future studies which are challenging not R-CHOP with BR, they are challenging cytarabine containing regimen with BR. And this is, I think, the question in the future. Is BR going to replace the cytarabine-based regimen? My feeling, yes, but we need more data and follow-up time, more follow-up time. Good question.
Any other questions? I have a question for Dr. Apostolidis. With the more use of T-cell related therapies, like immunotherapies with CAR-T and bispecific, are we going to see in the future trials that will use storage of T-cell before even starting therapy in patients with diffuse large B-cell lymphoma to remove the query T-cell exhaustion after the chemo?
Sure, that's a very interesting question. I mean, there's no doubt that the more treatment you receive, the more you reduce the ability of these cells to expand and to preserve what we call the T-cell stemness of these cells. And I don't know if it's cost-benefit, what the cost-benefit of doing this is. I mean, you have a very good point. I mean, you could actually store these cells from diagnosis, you could say, but before they're even exposed to any kind of chemotherapy, which would be very interesting. But I'm sure it stumbles to logistics and costs because it would be a problem. But I mean, I understand that this is a very important issue, the stemness of these cells, and there are actually some studies running now looking at boosting the production of these CAR T cells using a platform which is called a T booster. One of the pharmaceutical companies is doing this. And actually what they do is they expand the cells in 48 hours. So they guarantee door-to-door 10-day delivery, which is quite impressive. I mean, the other thing is, going further is looking at universal CAR T cells, allogeneic, stored in the blood banks. I mean, there are very nice studies looking at T cells knocking out the T cell receptor and other antigens which could trigger rejection or graft versus host disease, and there have been a number of phase 2 studies looking into that. And we also have a very nice presentation by Dr. Asvani at ASH last year, which looked at NK cells, and which showed very promising results of using these cord blood as a source of these NK cells. So, there's a lot of things that we can do. I mean, the future, I think, is brighter. We should be optimistic. And as biotechnology and cell therapies expand, I'm sure in the near future we'll be probably curing more patients with any of these cells, either stored allogeneic, either storing them earlier, as you said, or using more targeted agents, on the surface, using dual CAR T cells or triple CAR T cells, targeted CAR T cells in the future. There's many companies actually looking into this now. Thank you.
Prof. Ahmed, question to Dr. Murtada. Very nice talk, all speakers. So do you see imatinib as a first generation coming back, although it never went away in my practice? However, now with the combination, would you foresee the combination as a front line, and then for a quicker response and quicker in achieving deeper response, and then possibly TFR later on, or de-escalation?
So even with us, imatinib did not go. Even with the data of those second generation in the nilotinib, dasatinib introduction into the first line management, although they were like better CCYRs, earlier CCYRs, earlier molecular responses, earlier deep responses, we did not shift patients to a second generation. We continued using imatinib. However, the justification, despite the better responses with the second generation, is we do early stratification. So we do every patient would have at a baseline and 3 months and 6 months. And if they don't fulfill the criteria, like 10% and 1%, they will be switched to second generation. So that allowed us to give a significant number of patients imatinib and to continue on imatinib. I mean, cost is one issue. The second issue is the long history of safety. So this is why still a good proportion of our patients are on imatinib. Now, if you think of maybe TFR, then there is where you could justify the start of a second generation. However, when you look at the criteria, still the differences in the time to achieve deep responses between imatinib and second generation is not that much different if you incorporate it into the time span of the requirements to start a TFR. So I think imatinib would stay if you think of that approach, yeah, as a first line.
Thank you very much. Great talk. I have just one question for you, Dr. Murtada. Thinking or proposing that the ssbmt will go in a first line, knowing that it works at a different pocket than the other TKIs, do you think it still have or follow the same rules for the TFR when we do the TKI, or no?
Allahu A'lam. So it's really difficult. But I think if you look at the responses, so now the responses are unified, whether you use a first generation or second generation ELN, and whether you use it as like a first line or second line. I think the time points would still stay the same. But the only thing now, you will be able to achieve it earlier. So whether you would have the requirements of being on a TKI for some time, that is to be proven. But unless studied on a clinical trial, I don't think people would know.
I have a question to the audience. So who has started to adopt triangle or shine in his patients? Ibrutinib in first line. I guess no one, right? No one. Because I mean, ibrutinib is really toxic, and I think acalabrutinib will be making it.
Yeah, go ahead.
Okay. Thank you very much for all of the speakers. I do have a question for Prof. Riyad. So in a facility that lacks the auto stem cell transplant service, or where the patient is not being eligible for the transplant, but with the presence of the high-risk profiles like the pleomorphic features or the blastoid morphology or the presence of the TP53, would you still incorporate, based on the SHINE study, the ibrutinib plus the chemoimmunotherapy And if that's the case, then what would be your second line of therapy if patient progress on this?
Yeah, this is very good question. Still, we don't have any of the BTKs approved in first line, even in Saudi Arabia. No, and none of these agents approved in first line. And I think once we have one of them approved, I will be the first one who using it in the first line. But I don't think that ibrutinib will be approved. SHINE trial, also the data are positive, progression-free survival improvement. There is no overall survival benefit. And the study, the company, they pulled back their request for approval. So it's not going to be approved in the first line in elderly patients. The triangle study still, we need more follow-up data. It's not clear whether we will rely really only in BTK with R-CHOP alternating with RDHAB. This is some approach what we don't like. We don't like to bombard our patients with high-dose RIC if there are other regimens that bendamustine rituximab, which looks in my eyes a potential replacement for high-dose cytarabine. But future research has to address the question. We don't have still, the question will be remaining what to use in the second line if patients were exposed in first line to BTK inhibitors. And we have the chemotherapy options, we have the CART, but we do have also the non-covalent BTK inhibitors as bertobrutinib and other data with encouraging overall response rate approaching 50% in patients who were previously exposed to BTK inhibitors in previous lines.
Okay, thank you so much. We'll like to close this session. Thanks for the speakers. We'll have a break for 15 minutes. We'll come back at 3:45. Tonight, you're all invited for the Satellite Symposium at 7:30, and we'll have the gala dinner afterward. So please join us all.
afternoon. First, I will introduce my co-chair, Dr. Abdullah Al-Zaid. He's a consultant in hematology at Al Qatif Central Hospital and program director of hematology fellowship. Our last talk will move to the more benign hematology. We'll start our session with first beyond malignancy hematological manifestation of Gaucher and ASMD. This is satellite symposia sponsored by Sanofi. It will present by Dr. Mohammed Nabulsi. He's a director of hematology unit at King Abdullah Medical Complex in Jeddah and internal medicine program director. Dr. Mohammed will spend with us around 25 minutes talking about the manifestation of Gaucher and ASMD. Dr. Mohammed, the floor is yours.
Assalamu alaikum. Thank you very much for this nice introduction. And also I want to thank Sanofi for inviting me to highlight about very rare disease which can help you in the diagnosis of lysosomal storage disease. So if you see this slide, you will see a lot of symptoms and signs. And first things, commune differential, could be malignant hematology, could be metabolic causes, infectious causes. But also what I want from you to consider the very rare disease like lysosomal storage disease. So this is our objective. We'll talk about the ASMD, pathophysiology, subtype, symptom and signs of ASMD, and what is the similarity and difference between Gaucher and ASMD, and why we are considering parallel test with Gaucher, and how the symptom management. So ASMD is acid sphingomylase deficiency. It's known before as Niemann-Pick disease. They have three types, A and AB and B, and it's lysosomal storage disease. It's very rare disease. It's estimated around 0.4 to 0.6 in 100,000 people. It's affecting multi-systems like spleen, liver, lung, and also hematological. It's affecting also both male and female and both children and adult. So the pathophysiology of ASMD, it's caused by pathogenic variant of gene Ssbmt1, which coding for the enzyme, which acid sphingomylase, which have a role in breaking down the phospholipid sphingomyelin, which is in lysosome. So deficiency of this enzyme can lead to accumulation of the sphingomyelin in the hepatocyte and monocyte macrophage system, which can cause progression and multi-system progression in the spleen and liver and lung and bone marrow. So how this disease is inherited? It's autosomal recessive. So if the parent is carrier, so we have for each pregnancy chance 25% affected and 25% carrier and 50% is normal. So very important to screen and educate the family about the disease. So as I mentioned before, they have three types, type A, and overlap between type A and B, and type B. The onset of type A is in early infancy. It's rapid progression, it's affecting multi-organ, and they manifest with CNS manifestation. The life expectancy from 2 to 3 years. Regarding type AB, it's onset from infancy to childhood. It's slow progression comparing to type A. It's also manifested with multi-organs and CNS manifestation, and the life expectancy is childhood to mild adulthood. Type B, which is the most common type, the onset from infancy to adulthood. It's also slow progression and affecting multi-system, but here there is no any CNS manifestation. And the life expectation from childhood to late adulthood. And this is again showing the life expectancy. As you see, type A until 2 to 2 years, AB until 10 years, and type B until 35 years. And the most lead complication lead to death is liver disease and respiratory disease, and you'll find bleeding as one of the reasons of the disease is thrombocytopenia. And the failure to diagnose early of ASMD can lead to these complications. So what the suspected time? Usually there is delay in the diagnosis of the ASMD almost 5 years. And that's why early diagnosis can help the patient to manage the patient early and before the complication progress. So what is the symptoms of ASMD? As I mentioned before, they can present with a shortened breath and character of interstitial lung disease, can present with the splenomegaly, hepatomegaly, and also increasing in the liver enzyme, and also one character is hyperlipidemia. Also can present with GI symptoms, and in the hematological can present with thrombocytopenia and anemia. CNS, as I mentioned, it's present in the type A and type AB, can present with hypotonia, ataxia. One character in the ophthalmological and the ASMD in type A and B, it's present of cherry red macules. They also can present with a cardiac symptom, but it's very rare. Also, they can present with a skeletal, like bony pain, osteopenia, and osteoporosis. So here in this slide, you will find the most frequent presentation in the ASMD. You will find around 90% they can present with the splenomegaly, 70% they can present with hepatomegaly, and 80% can present with the interstitial lung disease, and 50% they can present with thrombocytopenia, and 75% they present with the GI symptoms. So if you have this symptom, you put your ASMD and lysosomal storage disease in your differential diagnosis. So as we mentioned, in the splenomegaly, they can present in 90%, and the most reason why spleen is involved because of infiltration by lipid-laden macrophage. So the patient they can present with abdominal pain, and also they have a risk to rupture of this spleen and cause bleeding. Hepatomegaly can present in 70% of the patient, and the reason is because of lipid accumulation in the hepatocyte. So they can present with abdominal pain, elevated in the liver enzyme, and elevated in lipid profile. And finally, they can progress to fibrosis and cirrhosis. Interstitial lung disease can present in 80% of the patient, and they present with a short breath, repeated chest infections, and they will have restricted pattern in the pulmonary function test. Hematological presentation, they can present 50% of thrombocytopenia, and also they can present with anemia, around 20 to 30%, especially in type A, B, and B. GI symptoms found in 75% is general symptoms, abdominal pain and vomiting and diarrhea, and it's also common in the type A. CNS manifestation, as I mentioned in the first slide, it present in the type A and type AB. It's account around 30%, and the patient they can present with development delay, peripheral neuropathy, psychiatric symptoms, hypotonia, and ataxia. And the other character, ocular abnormality, as you see in the pictures, they can present with molecular cherry red spots. So what's the similarity and difference between Gaucher and ASMD? So here in the pathophysiology, you will see in the left side, deficiency of acid sphingomyelin enzyme can lead to accumulation of sphingomyelin. In the Gaucher, we'll see that there is deficiency of glycocerebrosidase and lead to accumulation of ceramate in the system. So, Gaucher and ASMD, it affects all children and adults, occur in all population. Both of them, the cause is deficient in the enzyme and can also diagnose by measuring this enzyme. And also they can present with anemia, thrombocytopenia, hepatosplenomegaly, and also skeletal manifestation. Here we go to the types of Gaucher and ASMD. The more severe phenotype, type 2 in the Gaucher and type A in the ASMD. Both started onset in the early infancy. Both is progressive, affecting multi-organs, including the CNS manifestation and the life expectation until the 3 years. Intermediate phenotype in the Gaucher is type 3 and type AB in the ASMD. The onset from infancy to childhood, it's slower progression comparing to type A and type 2E. It's also affecting CNS and also affecting the skeletal manifestation. An attitude phenotype, type 1 in Gaucher and ASMD type B. The onset from infancy to adulthood, it is also slow progression. Both of them, they have no CNS manifestation, but also affecting the multi-organs. The character of Gaucher also is affecting the skeletal manifestation, but in the type B in the ASMD, there is no any skeletal manifestation. So what is the clinical feature for both? So they can do bone marrow infiltration, can cause hepatosplenomegaly, can cause portal hypertension, can cause lung disease and bone disease and CNS manifestation. But in the liver, cirrhosis and portal hypertension will found in ASMD more than Gaucher. In the skeletal osteopenia, they can found in both, but osteonecrosis will found only in Gaucher. Interstitial lung disease will find more in ASMD, more than Gaucher. Laboratory cytopenia is more in Gaucher, more than ASMD. High liver enzyme you can find in both. Low HDL cholesterol also found in both. Hyperlipidemia in ASMD and cardioprotective hypolipidemia in Gaucher disease. And this is a picture that can summarize the clinical signs and symptoms, the similarity and difference between ASMD and Gaucher disease. So, if you have these symptoms, hepatomegaly, splenomegaly, anemia, thrombocytopenia, you will consider as hematology malignancy, like acute leukemia, lymphoma, some cases multiple myeloma or MPN. And when you screen for this disease, some patient you will get negative for this disease. That's why we have to consider the lysosomal storage disease in your differential, ASD, ASMD, and Gaucher disease. So in the ASMD can be sometime overlap with Gaucher disease. That's why you are asking to do parallel test. So we can do parallel test detecting the enzyme in all patients suspected ASMD and Gaucher disease. As a guideline, recommend to do the parallel test. So, if you have a patient with splenomegaly and hepatomegaly, first, with the suggestion of ASMD in this septum interstitial lung disease, thrombocytopenia, low HDL, pathological fracture, test for ASMD. And if not, test for Gaucher disease if you don't have any symptom of, but even if the Gaucher disease is negative and the other cause is negative, again test for ASMD to rule out ASMD. So the test is it's very easy. This is the card. We can do the test, and you will see here in the bottom there is Gaucher and ASD disease. Just what you need, just to put the drop of blood to test for the enzyme activity. And if one of the enzyme is low, they will confirm it by genetic test. Here we'll just focus on what you need for this patient. You need multidisciplinary team to provide supportive care to help manage some of the symptoms. Like we need to maintain nutritional to control fluid retention, advise the patient to don't do any hard sport to avoid rupture of spleen. If the patient have low oxygen, so we need a supplement of oxygen. Need sometime intervention by ENT to control the bleeding, especially most of the patient present with epistaxis. Need dietary and life intervention, and education support and physical therapy. So in summary, just what I need to consider is to consider the ASMD and the Gaucher disease in your differential and in the labs. So when you have these symptoms, test for confirmation and treat the patient if they suspected ASMD or Gaucher disease. Thank you very much.
Thank you very much, Dr. Nabilsi, for this amazing lecture. And we'll move now forward to the second lecture, which is going to be presented by Dr. Sultan Al-Mutairi. Dr. Sultan Al-Mutairi is a consultant adult hematologist and bone marrow transplant. He had his fellowship in hematology at McMaster University of Canada in 2014 and 16. And also he had a specific fellowship in hemoglobinopathies program in the same institution. So Dr. Sultan is going to give us a talk about the sickle cell disease, the current therapies. Dr. Sultan, the floor is yours.
شكرا. السلام عليكم. مساكم الله بالخير جميعا. So thanks for the organizing committee and all the sponsors to invite me to this event. So in this 25 minutes, I will go over the current therapies of sickle cell disease. We'll go to talk about hydroxyurea role and still, which is from the past up till I think up to the future will be a key line of therapies. The blood transfusion roles in sickle cell disease, the FDA approved medications in sickle cell disease, the bone marrow. I will not talk about the gene therapy. I guess the next lecture will be about gene therapy. So as you see, hydroxyurea from probably from the mid-80s was considered a therapy, and this is based where they observed that patients with sickle cell disease who have high hemoglobin F tend to have less severe disease and better survival. And this is that time that drugs were being used for myeloproliferative neoplasms, and one of the observation that it was increasing hemoglobin F, and this is where it comes to use hydroxyurea in sickle cell disease. And as you see, up till mid-95, where it's approval for adults happened, it's been used until now 23, it's around 20 years, and hydroxyurea is still the key therapy for patients with sickle cell disease. And the drugs, as I was mentioning earlier, the main mechanism that it works by increasing hemoglobin F. It has other mechanisms, either improving the RBC hydration, decreasing the blood cells counts, the red cells, the platelets, and the white blood cells, which may play an important role in initiating the process of vaso-occlusion by adhesion to endothelium. This is the MS trial that's in 1995 led to approval of hydroxyurea in adults, patients. And as you see, there is looking at the annual pain crisis around, it's close to 50%, all crises or crises requiring hospitalization. In initial study, there was no survival benefit were observed. So they came as, if you remember earlier in the times, the indication for hydroxyurea was if you have 3 pain crises or 1 episode of acute chest syndrome, but this is totally changed now with longer follow-up of MSH trial. It's appeared to be showing survival benefits for patients with sickle cell disease as time goes, and especially those who have a robust response with hydroxyurea with persistently high hemoglobin F. Initially also there was questionable, and up to now, about how it really affects the organ damage. Is it protective of organ damage? And all the studies were really non-randomized studies, but most of the evidence came for patients with nephropathy and retinopathy, as you see. In nephropathy prospective studies, around 150 patients, and it seemed decreasing the risk of macroalbuminuria if started earlier for patients. As the same goes for retinopathy, it appears to be a reduction in those who are on hydroxyurea compared to the patients who were not on hydroxyurea regarding of their sickle cell disease genotype. The cancer risk. This was a very limiting point for especially among patients to take the drug for the past 20 years as the potential risk of cancer. But really the potential risk of cancer patient hydroxyurea, when we used for MPN, due to the MPN by itself, are really increasing the risk for leukemia. Here, as you see in this last trial, around 17 years follow-up patients, around 130 patients with sickle cell disease, no cases of myelodysplasia or cancer. So this is a point that we should reassure patients about the absent risk of cancer, and probably they are similar to the general population in cancer development. This is one also of the key things we are asked about it, the influence of sickle cell hydroxyurea and infertility. But just keep in mind that sickle cell disease itself, it will affect the process of spermatogenesis in patients and reduce the sperm count. Also hydroxyurea may be contributing to that. Generally, it might reduce the sperm count, but they are able to father kids. However, if a couple have been trying to get a baby for a year or more, then this time probably you should do semen analysis and stop hydroxyurea. And it's usually reversible effect on spermatogenesis, the hydroxyurea effect. The second aspect, the role of transfusion. So also you see patients with sickle cell disease, they tend to have lower hemoglobin levels. And this is vary between the genotypes. So usually their baseline hemoglobin between 6 to 9. And we see 6, especially with SS and Ssbeta 0, and probably SC, you see up to 10 hemoglobin levels. But the main thing and the benefit of transfusion is not increasing their total hemoglobin and pushing their hemoglobin from 7 to 10, is basically reducing the viscosity by lowering the hemoglobin S. So there are types of transfusion. We use tube-up transfusion. This is kind of rarely being used as in adults. Maybe in pediatric they use it for patients on high TCD, manual partial exchange transfusion, and automated exchange transfusions. This is manual. It's used in peripheral line. It's a slow process, but you don't need a central venous access. This is a kind of standardized protocol, but there are some centers, they will do simultaneous. At the same time, they remove blood, they give fluid, but this is kind of more widely adopted. And this is the apheresis machine. The benefit of apheresis machine, it's rapid process. You can give more blood, you can remove more blood, but eventually you need central venous access to use it. And if you compare both either simple transfusion, manual exchange transfusion, and automated wrist transfusion, there are 2 points to focus on it in these tables. You get the lowest level of hemoglobin S when you go with automated red cell exchange transfusion because you are removing more blood, and the risk of iron overload is way less as well because you are replacing blood with another blood. For acute indication for transfusions, in acute stroke, The main important is really exchange transfusion. In pediatric, there is no role for thrombolytic therapy. In adults, it might be considered, but you should do exchange transfusion before you're giving thrombolytic therapy. And as you see, it really reduced the MCA flow velocity by 20% immediate when you give it to patients. And also patients after that, the risk of stroke recurrence, which is really quite high, up to 70%, reduced significantly. Aplastic crisis, we see it as patients with sickle cell disease, they have shorter lifespan of red cells, up to 21 days. They are more prone to effect of the viral infections, so they may have pure red cell aplasia, aplastic crisis more than others. But see, as you see, 70% of them develop immunity, so you might have recurrent infection of parvovirus infection in patients with sickle cell disease. In generally, or the recommendation is to give hemoglobin when it's below 5. Splenic sequestration crisis in pediatric, or hepatic sequestration, which fortunately rare in adults. This is where other indication where patient will go into hypovolemic shock. However, this is the role of transfusion, and the main thing is to give 1 unit at a time, because whatever blood was pooling in the spleen or in the liver will be back into the circulation at the end of the sequestration. So you don't want to induce hyperviscosity by giving, like example, patient with hemoglobin of 5 or 4, you give them like 4 units or 5 units. You end up like after a few hours or several hours, you see their hemoglobin going to 13 or 14. You would not be surprised because it's just distributed again. Acute chest syndrome, it's the #1 cause of mortality in patients with sickle cell disease, and we can give TOBAB transfusion. Also, there is some data about it, or exchange transfusion. In general, in practice, if patient really severely hypoxic, less than 90 oxygen saturation, we go for exchange transfusion. A patient, for example, coming with hemoglobin of 6 or 7, you might go with TOBAB transfusion if they have evident mild of hypoxemia, but keep in mind, he might progress and you need full exchange transfusion. So just be prepared to insert central venous access and do full exchange. The sickle cell intrahepatic cholestasis, which is kind of the response to transfusion is kind of interesting and unique. So you might have these patients coming into you in ICU. They are hospitalized with acute liver failure, bilirubin shooting in the 200 range, coagulopathic, thrombocytopenic, and usually these patients, due to non-sickle cell disease, they may end up needing liver transplant, but they have really remarkable response to exchange transfusion, and they are really, most of them, the majority will survive just by doing full exchange transfusion. As a prophylactic indication, it's been used as a preoperative transfusion, and if you look at the TABS trial, they looked into low-risk procedure or a medium-risk procedure, and you see most of patients with sickle cell disease, they will undergo orthopedic surgery or abdominal surgeries like cholecystectomy throughout their life. And the point of it is really to target hemoglobin of 10, not much about lowering hemoglobin S in this group of patients. The high stroke risk, those who are coming, either they have prior stroke or they are transferred from pediatric with high TCD, also continuing transfusion, either pediatric they do TOBAB transfusion, adults we tend to go with exchange transfusion, trying to lower hemoglobin S of 30. However, there are subsequent studies looked into after 4 years or 5 years, you might be relaxing the target level of hemoglobin S to below 50%, and you might manage just doing peripheral partial exchange transfusion in your outpatient day case. I mean, what is important is the number needed to treat to prevent one stroke with full exchange was 1 in 6, which is around 92% reduction of stroke risk. The pulmonary hypertension, it's really just observational data, so it's one of the high morbidity complication of patient with sickle cell disease, and it have to be proved by cardiac cath. As majority of those who have high TRGV, only 6% of them really have actual pulmonary hypertension. So what is really is that what will exchange transfusion do is probably stabilize it and prevent the progression. it's likely to reverse the damage that already happened. This is an inappropriate indication for transfusion, and I emphasize on these multiple things because we should not see really patients with sickle cell disease who have iron overload. However, due to inappropriate indication giving transfusion because they tend to have lower hemoglobin, especially below 7, as for other patients who are non-sickler, when they tend to have lower hemoglobin below 7, they get blood transfusion, and eventually you end up with patients with sickler who have iron overload, and you have to give chelation. And the only way they get iron overload is just simply by transfusion, unlike thalassemia where there are other mechanisms of iron overload. Alloimmunization, it is one of potential issues with frequent transfusions. As you see, the RH group, the E and the C, when of the importance. So if you, the phenotyping is really a prerequisite for every new patient who coming into your practice. However, if you want to pick minimal matching, you should go with ABO, RH, and KIL as the minimum requirement for transfusion. Now, with all the new medications with attentions in the last 20 years to find drug therapy, targeted therapy in patients with sickle cell disease, here is the caveat. The sickle cell disease is not one mechanism of the disease. There are pathophysiologies, events, which is quite different from each other, leading to all the spectrum of complication of sickle cell disease. So they're trying to look about a drug that targeting the adhesion step, which is the initial step of vasoocclusion. Also, there is a lot of reactive oxygen species, so they tried antioxidant. Antiplatelets, usually platelets are really activated in patients with sickle cell disease in in vitro studies, trying to go anti-sickling and hemoglobin F induction. Also, anticoagulants have been tried, and this is kind of sample of what drugs being used, but unfortunately, majority of drugs, they die in the preclinical phases, and some of those who reach phase 2, or sometimes as we saw recently phase 3, eventually proved not effective. So I will talk about three medications that got FDA approval, US, and this is also Saudi FDA approval. Voxelotor based on HOPE-3 trial. It is when they tried 2 doses, 1500, 900 milligram versus placebo. Their primary endpoint was increase in hemoglobin by more than 1 gram. And also there is other medication that's trying to look at this. I think the rationale that's all either for Voxelotor or other new medication that target increased hemoglobin based on meta-analysis that showed patients who have low hemoglobin, which means brisk hemolysis, tend to have more prevalence of complication like pulmonary hypertension and leg ulcers, nephropathy, and such other complications. So they did not, it wasn't powered enough to detect vaso-occlusive crisis prevention effect. As you see, there was, the drug is bound to the alpha chain of hemoglobin S, and that's the way it really interrupted polymerization of hemoglobin S. So as you see with Voxelotor of 1500 milligram through week 72, and they also up to 96 now weeks, you see there's sustained increase in hemoglobin up to 1 gram, which is main endpoint they were looking for versus placebo. And here you look at around close to 90% of patients really achieve 1 gram increase in hemoglobin, and you see also 3 gram in around 20% of patients hoping on Voxelotor. There is a favor of decreased annual pain crisis, which had a trend also were observed. And this is looking at, they looked into hemolytic markers, indirect bilirubin, absolute reticulocyte, and LDH, and you see there is remarkable reduction of hemolytic markers. As this one of the medication that looks up high in the pathophysiology of sickle cell disease, not trying to target downstreams mechanisms. Crizanlizumab, which is probably a sad story here. When it came in the SUSTAIN trial, phase 2, it was looking at the B-selectin inhibitor, and it was really looking at this, maybe encouraging the result at that time, decreasing the pain crisis by 45%. FDA approved, and Saudi FDA approved at the time. However, sorry. The phase 3 trial showed there is no difference, even when they went with higher dose 7.5 between crizanlizumab and placebo, so it's really off market. The third drug, it's USA FDA approved, it's not Saudi FDA approved yet, is L-glutamine, and it is an antioxidant. This is an oral medications, 2-to-1 randomization, around 48 weeks follow-up. They included patient of age of 5. Foxilitor approved in the kingdom, by the way, from age of 12, but in the USA it's approved from age of 5. Also they were targeting pain crisis in general, and as you see, they did the reanalysis of their data, which show 45% reduction in annual pain crisis and rate of acute chest syndrome. Okay, I just put this slides for, it's not the USA FDA approved, and this is, they are recruiting for phase 3, but I think this is interesting drug. They were looking about mitapivat. The mitapivat have been approved for pyruvate kinase deficiency, USDA approved for it, but now there are studies in both, in sickle cell disease and thalassemia, and the goal of that is really just to increase their hemoglobin, and similar to way to Foxilitor with different mechanism. And it seems that around 46 of patients really achieved their goal of around 1 gram increase in hemoglobin. Now I will move to the last part, which is bone marrow transplant. I mean, it's one of the only cure therapy now. We have gene therapy and other curative options, but bone marrow transplant has been used in children and adults, and in adult as I'm an adult hematologist. As you see, there are kind of indication we give. We select patients who need bone marrow transplant. It has to be match-related siblings, allogeneic transplant, but now there is a rising use of haplotransplant as another way. And all this, the data looked into this international survey of result of HLA matched siblings. As you see, the event-free survival and overall survival were both lower with increasing age. And also the overall survival was lower for peripheral blood transplant recipients. So it's really better to be done in pediatric, but in adults it's still a reasonable option to be used. And for every 1 year increase in age, there is around 9% increase in hazard ratio for treatment failure. And also there is 10% increase in hazard ratio for death. The myeloablative has been, I mean, probably more in pediatrics, kind of has a lot of toxicity for if they are adults, because when you are growing in adults with sickle cell disease, you tend to have comorbidities, either related to sickle cell disease or unrelated to sickle cell disease, which make patient prone to more toxicity due to myeloablative regimens. Then it comes the non-myeloablative regimens as a potential really alternative for allogenic transplant. So studies have explored multiple conditioning regimens for bone marrow transplant, including alemtuzumab, fludarabine, melphalan, sirolimus, and low-dose radiation, and also trisulfan-based conditioning has been shown to promise in ensuring graft. The use of cyclophosphamide also have been investigated to improve engraftment in patients with severe organ damage undergoing haplo transplant. But as you know, any conditioning regimen is influenced by multiple things relating, including patient tolerability and the donor type. But goal of mixed chimerism is really acceptable in patients with sickle cell disease. I'm just sharing our colleagues Riyadh National Guard Hospital, where they did use this regimen, which is alemtuzumab, TBI, and sirolimus, and peripheral blood collection. They discontinue immunosuppression at 1 year when the CD3 chimerism more than 50%, around 122 patients. And this is a slide that's showing patients around 122. Eventually, 103 are alive with a stable donor chimerism. Few of the patients really didn't work, and they tend back to receive sickle cell specific therapies. So in summary, hydroxyurea remain essential drug. It was in the past, it is in the present, and I think it will be in the future for a very long period. And it should be to every patient with sickle cell disease, regardless of their pain crisis events. L-glutamine can be used with or without hydroxyurea for pain crisis prevention. Voxelotor, it's probably in a way, its mechanism is a new disease-modifying therapy. However, we don't have any data about organ damage. I think maybe years from now, if we might have. I think the ultimate goal will be combination therapy. There's multiple mechanisms of sickle cell disease. We should have multiple drugs at the same time work in these patients. I think this will be also the future for it. And that's it. Thank you very much.
Thank you, Dr. Sultan, for this excellent talk regarding the option of treatment in sickle cell disease. Before we proceed to the next lecture, we just have a minor change in the program. We moved the gene therapy lecture to be the last. The next talk will be thalassemia, but unfortunately, Dr. Hafiz Malhan, he apologized in the last minute, and we thank Dr. Abdullah. He agreed to do the talk despite the shortest notice. Dr. Abdullah, as we mentioned, Dr. Abdullah, he's a consultant in hematology in Al-Qatif Central Hospital and program director of hematology fellowship there. He has multiple effort in the field of hemoglobinopathy in the eastern region. Dr. Abdullah will present beta thalassemia, what is the new? Dr. Abdullah, the floor is yours.
Thank you. Thank you very much, Dr. Matab, for the nice introduction. And I hope Dr. Hafiz he's okay and he's doing well. My talk will be about the beta thalassemia and what's new. So here are my disclosures. So this is the outlines I'm going to go through, a brief introduction followed by the nomenclature of thalassemias, and then the lines of management followed by the approved novel treatments and ongoing clinical trials. So we know that the epidemiology of beta thalassemia is really widespread among the globe, and most of these data we are collecting it from the Thalassemia International Federation. It's estimated that about 56,000 infants are born annually with thalassemia. And in Saudi Arabia, the total carrier prevalence for beta thalassemia is about 1.2%. And there is a predicted number of thalassemia newborns is about 130 each year, and hopefully this is going to go down as we are doing the premarital status screening. And it's always estimated that about the 9,000 thalassemia patients in our country. Talking about the pathophysiology of thalassemia, we know that there are two types of thalassemia, the alpha and the beta, and when there is a deficiency in one of them or absence of one of them due to a mutation, there will be decreased in the manufacturing of the beta globin chain or the alpha globin chain. So what happens in beta thalassemia is basically the beta globin chain is being reduced or absent, and the alpha, on the other hand, is getting more, and that will lead to more excess. It's really very deep pathophysiology, but I will come and revisit this topic later on. I would not go deeper here, but to summarize it, we have basically a hemolysis that will lead to chronic anemia. We have ineffective erythropoiesis, and that will lead to iron overload, either due to the absorption increment of iron or due to the blood transfusion. I still remember when I was a medical student reviewing this table, the classical teaching, when they told us about thalassemia, it might be major, minor, or intermediate. And memorizing all these numbers the night before the exams was really important to me, not to miss the MCQ that will be going to appear in the exam paper. So what I do, I always review this just before the exam when I was a medical student. So interestingly, when I was preparing this talk, I come across two papers which were published in New England Journal of Medicine. The first one was in 2005, and you can see the typical distribution or classification of the thalassemia, the classical manifestation, as well as the criteria for beta thalassemia syndromes. And the second one was in 2021, and again talking about thalassemia syndromes. And if you focus clearly here, you can see the main difference is basically looking at the blood transfusion here. So from practice point of view, and I think this is really very important to address here, that basically we have to classify those patients based on their requirement of the blood transfusion. We have patients who never require blood transfusion and they completely have no symptoms. And we have patients who have mild to moderate symptoms, and those are basically the non-transfusion dependent thalassemia. So these are basically the beta thalassemia intermediate, the mild or moderate hemoglobin E beta thalassemia, or even the hemoglobin H with regards to the alpha thalassemia. Some of them, they are basically have seldom required to be transfused, or they sometimes get occasional blood transfusion, specifically when they have stress conditions such as infection or going to surgery or during pregnancy. And some patients who require intermittent transfusion that will lead sometimes to poor growth and development specific comorbidities as well. These are basically the non-transfusion dependent thalassemia, the NTDT. The last one, which is basically the whom are having more severe disease and more symptoms, are basically who are really dependent on the blood transfusion, and they require a lifelong transfusion regularly on the daycares for in our hospitals. So these are basically the beta thalassemia major, the severe hemoglobin E beta thalassemia, or the hemoglobin Bart's hydrops fetalis for alpha thalassemia. Talking about the clinical manifestation, in pediatric age, you may not see any of the clinical manifestation apart from the anemic symptoms, and especially if they are well managed. And the classical or the typical features that we usually being taught in the medical school, that they will have what's called the chipmunk facies. And the chipmunk facies is probably nowadays is not acceptable to be developed. And if we see this, it's either indicating that the patient is non-compliant to the blood transfusion, or the patient is basically, unfortunately, mismanaged. So with regards to the complication, we know that those patients will require more blood transfusion. They will develop iron overload and other complications, including endocrinopathies, as well as the osteoporosis, thrombosis, and other end organ damage. With regards to the standard of care of transfusion-dependent thalassemia, we know the main goal and the main important goal here is to monitor the complication, try to prevent it, and if it happens, to manage the complication. At the same time, if we have patients who are eligible for blood transfusion, then we should get them into the, if they are eligible to clinical criteria, then we should encourage them to be enrolled in clinical criteria. There are some patients who are eligible for stem cell transplant, and here we are talking about those patients who are having matched sibling or match unrelated sibling, and especially if we are talking about less than 12 years of age, so we can consider them for stem cell transplant. Those patients who are above 12 years of age and they are well chelated and they have also matched sibling donor, then we can consider them for stem cell transplant. And we'll come to the gene therapy part later on whenever we come to the gene therapy. So those patients who are above 18, they are either going to transfusion, or we may consider the novel therapy such as luspatercept. This diagram here outlines the management. We know that some patients may require actually splenectomy in order to tackle the anemia, and that to improve the tissue hypoxia, to improve the bone marrow expansion, and to prevent the extramedullary hematopoiesis. At the same time, which is the cornerstone of the treatment, transfusion is really important, and that's basically is to overcome the ineffective erythropoiesis as well as to treat the anemia symptoms for those patients and its complication. And this transfusion will be, unfortunately, becoming more complex, and this will lead to secondary iron overload. That will really necessitate to start iron chelation therapy, either to treat the secondary iron overload or to treat the primary iron overload due to the increased absorption of the iron. Here it's really important to emphasize on the timing of transfusion. The lower the hemoglobin level, the more association with more complication, regardless of the type, the transfusion dependent or non-transfusion dependent. Now, moving to the novel therapy, we know that there are curative treatment, which is basically the stem cell transplant or gene therapy, and fortunately, they've been already approved. And in those cases, we have at least 2 gene therapy approved for beta thalassemia. And talking about those patients, they are either going for a lifelong transfusion-dependent life, so they will require blood transfusion all their life, or they can go for allogeneic stem cell transplant if they have a matching sibling. The good thing here is that we do not really need to have a graft versus leukemia or graft versus malignancy in this situation. So even a minor accepted chimerism is really appropriate in those cases. The gene therapy will also similarly will require stem cell collection from those patients that will need to be processed either to go for a gene addition or to CRISPR-Cas9. And here you can see which one of them there are basically two main processes are going at the same time. There is the patient who will require to be stimulated to get the stem cells from the patient, that these stem cells will go to the processing, and at the same time we give this patient the conditioning regimen in order to prepare him for or her to receive the bioengineered cells. So these cells will go to the companies. We have two main companies at the moment, the Vertex and the Bluebird Bio, which is dealing with the thalassemia patient stem cells, and they can either go with lentiviral vector that will go with the Bluebird Bio company, or with the CRISPR-Cas9, which is the Vertex company. And ultimately, once the patient is being conditioned, these cells will be sent back to the center, and the cryopreserved cells will be thawed and given to the patient on day 0. And gene therapy was already integrated in the second edition of the TEF guidelines, and you can see here that beta cell, which is the Bluebird Bio product, is being approved in this edition, but at the time this edition was published, the Vertex product was not yet approved. It was only approved last November in UK, but it's not yet included in the guidelines. Probably it will be included in the next version, and it was already approved last December by the US FDA, and thankfully it was also approved in the Saudi FDA as well. So moving toward the novel therapies, we know that there are really multiple targeted points in talking about the novel therapies, and many of them are still either did not show really significant difference, or some of them are still on the clinical trials. Talking, for example, about the JAK2 inhibitors, it's been already tried in phase 1 and 2, but it did not go through phase 3. Unfortunately, it did not show a clinical improvement. Talking about alpha-globin mutation-targeted treatment, trying to make that balance between the alpha and beta to fix this imbalance between both of them. There are also some studies on this. We have also the gamma globin, basically the hemoglobin F, that's also being used in the past and still used for hydroxyurea in those patients. So some patients, they may get improvement with this. There are also thalidomide and other novel treatment are being tested. We have also the metabivat, Dr. Sultan Moteri was talking about a while ago in sickle cell, but it's also being used in the thalassemia. And there is also the hepcidin mimetics targeting the iron overload, and there are multiple medications still under investigation. And the most important part of this, which is the only approved medication here, is the luspatercept. So luspatercept, in order to understand it, we have to go and look at the pathophysiology of the erythropoiesis. And we know basically that the erythropoiesis is basically two parts. The first part is controlled by the erythropoietin, while the second part is basically controlled by the TGF-beta superfamily ligand. And to make it more easier, you can see here the normal erythropoiesis. You can see in the upper half of the slide, you can see that this is basically is the proliferation of the RBC precursors, where only erythropoietin exerting the effect. And you can see the maturation goes on in the second phase, which is the late stage phase and of the erythropoiesis that will lead to erythrocyte homeostasis and managing the level of hemoglobin. While in the second half, the lower half is explaining the ineffective erythropoiesis, and you can see there is elevated numbers of the erythropoietin level. Despite of this, the RBC or the erythroid precursors are not maturing because there is an overactivated SMAD2/3 signal that will lead to the impairment of the erythroid maturation, and ultimately this will lead to the anemia. So luspatercept is basically was the first-in-class erythroid maturation agent that target basically the TGF-beta superfamily ligands. And basically you can look here, you can see the TGF-beta superfamily ligands comes and attached to the activin receptor 2B, and that will lead to phosphorylation and SMAD2/3 complex that will lead to inhibition of the erythroid maturation. And what luspatercept does is basically comes and inhibit this TGF superfamily ligand, leading to inhibition of the cascade and removing of the inhibition or inhibition of the inhibition that will lead to stimulation of the red blood cells. There are two main landmark clinical trials on the luspatercept and beta thalassemia. The first one is the Believe It trial, which is published in 2020, which is basically for transfusion-dependent thalassemia, and was published in New England Journal of Medicine. The second one was the Beyond the trial, which was specific for non-transfusion-dependent thalassemia, and was published in 2021. The first one is the Believe It trial, which is basically a randomized, double-blind, placebo-controlled phase 3 study on the luspatercept, and the inclusion criteria for those patients who are really transfusion-dependent thalassemia, aged 18-year-old or above. They were randomized in a 2-to-1 ratio. The first arm is the 2 ratio, which is the luspatercept arm, which is 1 milligram per kg every 3 weeks, with also bed supportive care. And the second arm was the placebo arm. And those patients were monitored over 48 weeks as a double-blind period. Then those patients are allowed to go crossover permission, and then followed by an open label up to 5 years of follow-up. And the primary endpoint, I'm focusing here on the primary endpoints, which is 33% or more reduction in the burden of red blood cell transfusion at weeks 13 and 24 of the trial. And here it was met, the primary endpoint was met by reaching 33% or more reduction in the transfusion at weeks 13 and 24. And the side effects was comparable to the placebo. There was no really side effects that prevent from using luspatercept in those patients. The second, and this was already integrated again in the TIF guidelines, and you can see here that luspatercept is being added for those patients who are 18-year-old or above. The second trial was basically is the Beyond the trial, and it was basically for the non-transfusion dependent thalassemia. Those patients are basically whom require less than 5 or less than red blood cell units in the past 24 weeks prior to randomization, and there was no RBC transfusion within 8 weeks before the randomization, and their hemoglobin must be 10 or less, and the number of patients was 150. The randomization again was 2-to-1. The first arm was luspatercept 1 milligram per kg over every 3 weeks, and the second arm was placebo with best supportive care. And the end point, they were followed up over 48 weeks, and the end point was basically the increment of the hemoglobin concentration of at least 1 gram or more, and at weeks 13 to 24 weeks from the baseline. The secondary endpoint was also evaluated, including the symptoms, the quality of life, as well the activity and chelation and ferritin level and liver iron concentration. And very amazingly, the primary endpoint was met. 77% of patients on the luspatercept arm has achieved the 1 gram and more in comparison to 0 in the placebo arm. And again, luspatercept was also included in the guidelines for those patients who are non-transfusion dependent thalassemia, and was added in the guidelines in the version of 2023. Moving to the mitapivat, basically mitapivat is first in class and oral. It is an oral medication, and small molecule is basically activates the red blood cell pyruvate kinase. And the idea behind it is that we know that thalassemia patients red blood cells are having low ATP level. So what we are doing with the mitapivat is trying to get more energy, is basically trying to get more ATP for the red blood cells in order to prevent the hemolysis of the red blood cells. And with this, we can improve an effective erythropoiesis and improving the anemia. At the same time, this will lead to decrease the iron overload and absorption. There are 2 clinical trials, the Energize 2 and Energize trial. So the Energize T is basically for transfusion-dependent thalassemia, both alpha and beta, and they plan to enroll 240 patients. And the Energize T is already started in November 2021, and the completion will be this year by June 24 expected. And the second one is basically the Energize, which started again November 2021 and supposed to finish or completed by last December. And probably we are going to hear about the result in the coming few months. Overall, we can see over the past few years that our patients are getting really a longer life, and this prolonged lifespan tells us that we are probably in the right direction for those patients, and hopefully we are going to get them the normal expected lifespan for all the patients. Thank you very much. Now we move to the last but not least, as we saw in Arabic, khitamuhu misk, and moving to one of the novel treatments is basically let's say the satellite symposium of the Vertex company, and the topic is one of the most lovely topic, at least to my heart. Talking about the gene therapy. And I would like just to remind all the audience that there is a survey questionnaire on the tables. Please, we need your feedback for those questionnaires. So the topic is, as I said, the gene therapy, and our guest speaker is one of the renowned physician, Professor Josu de Lavanti. He is a professor practice cellular and gene therapy at Imperial College London, and director of the bone marrow transplant program at St. Mary Hospital, London, UK. In addition to this, he was really very involved in the gene therapy as a principal investigator. And he's going to enlighten us about gene therapy, and his talk will be about gene therapies, an era of innovation in hemoglobinopathy. Professor Juzo, welcome in Saudi, and please, the floor is yours.
Well, thank you very much for the invitation. It is a real pleasure to be here among friends and colleagues. So, salam alaikum, everyone. And I just want to start by letting you know that I'm going to be exploring the latest advances of a variety of products as late as what it was presented at us this year, both in the field of thalassemia and sickle cell disease. And of course, this is a symposium which is funded by Vertex, and you have all the disclaimers there. So I work at St. Mary's Hospital in London. Some of you may know it because it's this place where penicillin was identified by Fleming, and that is his laboratory involved that blue plaque there, which I have to pass every morning when I go to work. That reminds me that the advances that we do today are only limited in comparison to the number of patients who have been saved by the discovery of antibiotics. Sorry, those are my disclosures if you want to have a look at them. Now, the gene therapy doesn't come on its own, but in the context of all the other approaches that we have to obtain a cure. And that involves conventional transplantation, both matched and alternative donors. And although we don't have much time to discuss it in greater detail today, at least I can tell you, supporting what has just been said, that in the field of thalassemia, both related and unrelated matched donors have equivalent outcomes, at least during the pediatric years. And that in the field of sickle cell disease, whilst we don't have an alternative donor that appears to be better than the others, we did see at us the results of the 1507 trial following the outcomes that we already had presented as part of the Vanderbilt Learning Collaborative, indicating that haploidentical transplantation is very effective in adults, where you can obtain overall survivals of 95% and disease-free survivals in the region of 90%, which I think it is remarkable. But it is with a reduced intensity condition approach and using PTCI. Now, in addition to that, of course, we have the correction of the disease by using the different gene therapy techniques. So this is autologous correction, either by addition of functional genes with viral integration or by gene editing. I'm particularly going to focus with the addition of a beta-like globin in the case of the Bluebird bioproduct, and the induction of fetal hemoglobin by disrupting the BCL11A enhancer, which is the product of Vertex. And I will also mention the early stages that we have of HPFH creation with the Editas product. There is the possibility of gene repair, but the use of homologous recombination is at the moment paused because it's not at a stage where it can be delivered to patients. Now, this gives you an overview of the clinical trials that have occurred, both in thalassemia. In the next slide, you will see those for sickle cell disease. And what is interesting is that they started in 2013, which is exactly the year where we created the Learning Collaborative to be able to optimize haploidentical transplantation for hemoglobinopathies. So they have gone hand to hand, and it would be nice to have a discussion later on as to how we are going to deliver these treatments, for which patient, whether there are any benefits of one or the other. But effectively, you can see that increasingly there has been both not just gene addition, but also editing of the genome, and that there are a number of different companies involved. And this is great because we're going to have increasing number of avenues to be able to cure our patients. And this is exactly the same in the case of sickle cell disease. And I'm going to pick from those the ones where there has been relatively recent data and where there is promise. So I'm going to start with gene addition with the use of lentiglobin, what is now Lobocel or Beticel, depending whether you approach thalassemia or sickle cell disease. And this is the insertion, the random insertion, but with self-inactivating viruses as safety, of a functional hemoglobin, the T87Q, which in the case of thalassemia allows you to follow its production with electrophoresis, and in the case of sickle cell disease, it has the benefit that it contains the same mutation that leads to the hemoglobin F avoidance of sickle polymerization. So the patients with sickle cell disease will get both the benefit of having a functional hemoglobin, but also the possibility of stopping the polymerization in the same way as the hemoglobin F. Now, this helps me to show you the approach to gene therapy, and no matter which product you choose, it goes in the same stages. Initially, we need to be able to collect cells that are going to be modified. That is done by apheresis, and it's not as simple as it might sound, because it has its own challenges in the cases of hemoglobinopathies. We have a hyper-expanded hematopoietic compartment, which is very inflamed, and so that reduces the quality of the stem cells. In the case of thalassemia, we can mobilize the cells with G-CSF and plerixafor. In the case of sickle cell disease, we can only use plerixafor because G-CSF will provoke crisis. And when Bluebird Bio started studying this, they have to go through a process of optimization of the product. Initially, they were using bone marrow because they were concerned about the feasibility of doing peripheral blood stem cells in sickle patients, but indeed, that did not allow the collection of sufficient stem cells for the product, and they have to move on to a refined use of mobilized peripheral blood cells with an optimized processing. And that is why there were Group A, Group B, and Group C, and many of you will be aware that Group A and Group B were suboptimal, that there wasn't good engraftment of those cells, and that allowed clonal expansion and some cases of clonal evolution, which have not occurred in the optimized product where there is good engraftment of the modified cells. So you have the collection of the hemopoietic stem cells, then the patients undergo a busulfan condition autograft, so a single myeloablative agent, and then after the infusion of the product, you have to wait for the engraftment, which, because the cells have been manipulated ex vivo, tends to be slower than you will expect with a normal autograft. But eventually you have, as you will see, a correction of the situation. So it starts with the patients with transfusion-dependent thalassemia, where we have data from both pediatric and adult patients. You can see the ranges are from 4 to 35 years of age, and we have 63 patients whose data has been disclosed. And if we focus on those who have the optimized product, so the phase 3 studies, you can see that 37 out of 41 patients, so 90% of the patients, achieve transfusion independence. And what you see on the left-hand side is the distribution according to age. And so there has been some concern, particularly because of the experience of the ticket studies, as to whether there will be a differential ability of the engraftment of the cells according to age, but actually you can see that the transfusion independent has been achieved independent of age across all of them. And this was supported further by the fact that there was improvement in quality of life. The safety of the product is consistent with an autograft that has used busulfan as a myeloablative agent. Now, in relation to sickle cell disease, it's slightly more complex, and you can see that on the graph on the right, where you have the total hemoglobin as a combination of the hemoglobin T87Q that has been transfected, that is in blue, with the other hemoglobin, which is on its majority sickle hemoglobin. And that is because the new hemoglobin that has been introduced in the genome, well, a new beta chain, has to compete with the sickle hemoglobin for the alpha chains. And so the situation you then get is one analogous to a sickle cell trait, where you can see the new hemoglobin accounts for more than 40% of the total hemoglobin as a proportion, and then the total hemoglobin that the patient achieves is normalized. On the left-hand side, you can see the red dots of the vaso-occlusive crisis that had required medical attention. Whereas if you look beyond the blue bars, where the patient has already received the autograft, there's a very substantial reduction. So 30 out of 34 patients did not have any vaso-occlusive crisis during the period of analysis, which is the darker blue in the middle. And you can see that the vast majority of the patients are free of vaso-occlusive crisis. There are a number of patients who still have painful crisis, and that just shows you the complexity of dealing with sickle cell disease in an adult population, where there may be other aspects like chronic pain or socioeconomic or mental health factors that can impact in the perception of pain. Now, the compound is undoubtedly safe, as you can see in the safety profile, but it's interesting to note that there are as many adverse events during the process of the apheresis as there are during the transplant process. And that just brings us to mind that to deliver safely these products, we need to have very strong and close collaborations between not just the transplant team, but between the transplant team and the doctors who look after hemoglobinopathy patients. In some centers, that may be the same kind of doctors, but often it's not, and so this has to be a team effort. Because there is likelihood that once you do the apheresis, or once you are in the early stages of the care of the patient, that there may be sickle-related or thalassemia-related complications. But if we focus on the group C, so these are patients with sickle cell disease, you can see that the side effects that were reported were mainly abdominal pain, anemia, nausea, vomiting, the kind of side effects that we encounter with maloblation, and that there have been no cases in the sickle cell patients, unlike in the thalassemia patients, of veno-occlusive disease. There are two patients who have long-term anemia. Both of them are, have 2 alpha gene deletions, and that is being studied further as to whether, at least with this product, the double alpha chain deletion has less efficacy in correcting the patient. And there have been 2 cases of AML reported, but I want to reinforce the fact that these were on the early product that hadn't been optimized, so it didn't lead to good engraftment of corrected cells. And this is something that we also see in reduced intensity transplantation, that if you are not able to reestablish normal hematopoiesis, there is a clonal effect pressurizing abnormal clones to then develop either MDS or AML. Now, there is an alternative approach, and that is using gene editing. And the reason why gene editing works is because we have the ability with nucleases to create cuts, and once you have created cuts, I'm sorry, yes, I thought I had gone over one of the slides, but I can go back onto that, sorry. Once you have created cuts, then those can be repaired either by homologous recombination, where there will be a complete correction of the gene, but we are not in a position to deliver this to patients. But what we can do is inactivate genes by allowing non-homologous end joining to create either deletions or insertions. And that is exactly what the gene editing technology does at the present time. So on the left-hand side, you have the BCL11A gene, which is key to move from fetal hemoglobin production to adult hemoglobin. And we all know that patients with both thalassemia and sickle cell disease don't have manifestations of the disease in the early infancy period, and that medication like hydroxychloroquine aims to increase that hemoglobin F level. And so what we do is modify the way that the BCL11A or the actual gamma globin genes themselves work in order to be in a situation where we produce hemoglobin F again. And so in the case of Exacel, the product by Vertex, what happens is that we use CRISPR-Cas technology to create indels in the erythroid enhancer, which then doesn't allow it to interact with CATA efficiently. and therefore you have reactivation of hemoglobin F. And the fact that it's in the erythroid enhancer is very important because BCL11A has other functions in the human body, like for example lymphocyte development, and this gives us the assurance that we are only going to affect it in the erythroid series. Now, there are other techniques other than the use of CRISPR-Cas, and so we can use zinc finger nucleases to achieve these effects. So what we're interested in is in the fact that we have a nuclease, in this case FOC1, which is derived from Fablobacterium, and is directed to a specific site of interest by the zinc finger domains. And zinc fingers are groups of 30 amino acids which are joining a zinc molecule, that's the reason it's called a zinc finger, and has the ability, each one of those zinc finger domains has the ability to recognize 3 nucleotides. And so you are therefore very specific as to the area that you are targeting, because you have quite a substantial period. You have 18 nucleotides by the zinc finger, you have the spacing in between, so altogether you have 18 base pairs that you are recognizing, and you have the certainty that you're going to create a cut in the desired place. So this has been done not just in the laboratory, but we have an early trial by Sangamo, by which on the left-hand side you can see in patients with sickle cell disease we have the ability of obtaining hemoglobin F levels of approximately 45%. The last patient, the 5th patient that has been tested, did achieve 93% with the optimization of the product, and this is the BIVV003 study, which at the moment is paused awaiting further funding and development. But it does give you the possibility to see that there are other approaches other than the use of CRISPR-Cas technology. Now, CRISPR-Cas, for those of you who are not familiar with it, is the adaptive immune response of most prokaryotic cells. So we have the Cas9 protein that is able to create cuts and degrade DNA, and CRISPR that recognizes particular sequences to be able to keep bacteria free of bacteriophages. And so what we have done with the CRISPR-Cas technology is that we have created a single guide RNA by truncating and bringing together all the components of the RNA so that it's a simple device, and that is able to recognize a particular target zone, which then the Cas9 endonuclease can cut. And so using this, we are now in a very advanced stage of the phase 2-3 trials of exa-cel, and indeed, as you know, the studies for those who are more than 12 years of age are completed, and the product has been licensed, and we are currently doing the children between the ages of 5 and 12, and we're hoping to be able to do the children between the ages of 2 and 5 later on in the year. And so the aim of the trials for sickle cell disease was to assess the number of patients who were able to be free of vaso-occlusive crisis for a period of at least 12 months. In the case of thalassemia, the primary efficacy endpoint was to be transfusion independent for at least 12 months. And so this is the data for sickle cell disease. So you can see in blue the number of vaso-occlusive crisis requiring medical attention on the left-hand side. Then you have the actual autograft procedure. There is a washout period of 60 days where we don't count it because they were still receiving transfusions. And then in the period of green is the area where we can assess the patient, knowing that if there is efficacy, it's due to the use of exa-cel. And so if we focus on the orange part, because that has the number of patients who have been followed up for at least 16 months, so that it allows us to see whether they have been free of crisis for at least 12 months, you see that the primary endpoint was met in the vast majority of the patients. So in 28 out of 29 patients, given a 96% efficacy. Now, there are 2 patients which you will notice quickly that they have blue dots beyond the period of the transplant. One of them, the one at the top, had a parvovirus infection which led to anemia. That was a single event. The second patient is a patient that has had chronic pain and other mental health socioeconomic factors associated. And so it just leads you onto the situation where there is great complexity once you deliver this form of treatment to patients who have established disease. But as I'm going to show you, there is efficacy across the ages. So whether in the adolescents or in the adults, we have correction of the number of vaso-occlusive crises, and most importantly, we have lack of hospitalization. So you see that the only patient that has required hospitalization after receiving the product is the one who had the parvovirus infection. So even the patient with chronic pain, at least those episodes, unlike before being treated, are not leading him to require being an inpatient in a hospital facility. Now, what that shows you on the left is the total hemoglobin obtained, and we have both data for the adults and the adolescents to show you that the efficacy is the same no matter the age. And so you have the total hemoglobin at the top, and you see how many grams per deciliter of that total hemoglobin at the bottom is due to hemoglobin F. And it represents on the right-hand side that we achieve more than 40% hemoglobin F production, so that the patient has a situation analogous to being a trait, and we know that this is a pancellular distribution of hemoglobin F. The safety shows very similar to the Bluebird Bio data, side effects that are in keeping with myeloablation with busulfan, and you can see very clearly on the right-hand side that the majority of the adverse events occurred in the first 3 months, which is what you will expect in someone who has had a transplant procedure, and then they tail off. The case of thalassemia, very similar graph, but in this case the dots indicate transfusions, and you see that if we focus on the primary efficacy set, so patients who have had sufficient follow-up so that we can determine whether they have been transfusion-free for 12 months, that was achieved in 91% of the patients, in 32 out of 35 patients. And indeed, the 3 patients who didn't achieve that primary endpoint have had a very substantial reduction in the requirement of transfusions, and today all of them are free of transfusions. It did take longer than the period of follow-up for the initial assessment, so that's the reason they hadn't met the primary endpoint of 12 months continuous, but if we wait for another year, the likelihood is that they will achieve that time point. Safety, very similar to what we have seen for sickle cell disease, with the adverse events focused in the early point and in telling off as the transplant procedure has been completed. In relation to mortality, the Bluebird Bio product has had a death, but not related to the actual intervention, but a patient who had cardiomyopathy with pulmonary hypertension before the procedure, and that then went on to have its own natural history, and despite of the correction of the sickle cell disease, that led to his death. In the product from Vertex, there's been a death 8 months after having finalized the treatment due to COVID, potentially in a patient who had had a degree of pulmonary damage by the use of busulfan, but COVID was the actual cause of death, and there's been no fatalities during the actual period of treatment. Now, something that is incredibly important and which we often fail to look at when we do other form of treatment is the quality of life achieved in these patients. And as you can see by the multiple scores on the left-hand side of the adults, on the right-hand side of the children, this has been done very in-depth in the exa-cel trials, because we want to really understand what is the impact of this form of therapies on patients. Now, what I want you to focus on is on the bottom line, that is the minimal clinically important difference. So you have to go, you need to reach at least that point difference for it to be meaningful. I was not very familiar or experienced with quality of life questionnaires, and so I guide myself by that. So that is the minimum that you have to increase. And so you can see that if you take any of the means at any time point on the different scores, and you can see whether you look in the adults or in the pediatric patients, or in the adolescent patients, apologies, that the improvement that is being achieved is above the minimally clinically important difference. But what is more extraordinary is that the younger you are, the better the improvement it is. So you can see if we take, for example, the total score, that at month 18, you have a 9.1 improvement in the adults, and you have to have at least a 3 to 7 improvement. But if you look at the younger adolescents, you can see that the improvement is 14.1, whereas you only have to improve by 4.36. So you are improving 3 times the minimum improvement. So to me it's very important, because what this is telling us is that if you want to ensure that a patient derives the greatest benefit of this form of therapy, you ought to do this treatment at a younger age if you want to obtain the very best result. So finally, there is a different gene edit approach to create hemoglobin F, and that is the product from Editas, in which they actually edit not the VCL11 erythroid enhancer itself, but the region of the gamma globin to create HPF8. And there are 2 studies, Ruby and Edithal, so Ruby for sickle cell disease, Edithal for thalassemia. And you can see that the design is very similar to the other studies. And they were able to present at us the very early results. You can see that the number of patients that have been treated is very small. There is only 1 patient whom in sickle cell disease has reached 18 months, and they are only in fact, in the total number of patients with thalassemia treated is only 5. So we're still at the very early stages. But you can see that the amount of hemoglobin F that is being achieved is equivalent to what I have shown you with exa-cel, and that in the case of thalassemia, we're getting good total hemoglobin levels, of which the majority is hemoglobin F. And we look forward to have an update and to see what happens with this product. What is in the future? So we have the advent of base editors. So this is the ability not just to create a cut, but be able to change the nucleotide. And the earlier work that we have is by Beam Therapeutics, which is editing the genome so that the sickle mutation turns out to be something called hemoglobin Makasa, which is functional, and there are individuals worldwide with this type of hemoglobin without any clinical deleterious effects. This is at a very early stage, and what I'm showing you there is laboratory work by which creating hemoglobin Makasa, which is the blue, allows you, at least in the laboratory, the correction of the sickle cells onto a more normal phenotype, and it's interesting to know how this can be translated into patients. The base editing technology still is being refined so that there are no off-target effects, but it's potentially one of the things that we might see in the future. So I hope I've been able to show you that these techniques are able to deliver cure for the patients. We do have the challenge that we now need to determine better how we are going to measure what we're trying to achieve. I mean, it's easy to say that we want our patients to be cured, but what exactly do we mean by that? In transfusion-dependent thalassemia, are we talking about hemoglobin level? Are we talking about care utilization? Are we thinking about the avoidance of complications later on in life? In the case of sickle cell disease, what do we mean by vaso-occlusive crisis? Do we mean that we want to abolish then not having to go to a medical facility? Are we expecting not to have any neuropathic or chronic pain? What happens to the rest of the organs that might have been damaged before you provide the therapy. For example, there was renal dysfunction or pulmonary hypertension. So these are things that, as a community, we're going to have to evaluate very carefully so that we know the true effect of the treatments that we have provided. But I do hope I have been able to show you that with gene therapy, we are able to have rapid, robust increases in total hemoglobin to normal or near normal level, that whether we use a gene addition or a gene editing approach, that we're able to truly modify early stem cells, and that long follow-up is demonstrating that this is persistent in its functional curative effect, that there is a safe way to manage these patients, that the profile is consistent with having had an autograft, and that whether we do this to adults or adolescents, that we get a correction in both of them. So this gives us an opportunity to provide a one-time functional cure for our patients. And I'll be very happy to enter into a discussion.
Thank you very much, Prof. De La Fonte. And I would like to invite all the speakers here, if you can please come over, so we can open the floor for discussion and questions and comment. So any questions, or yes, please.
Thank you. Thanks for all the wonderful talks from the wonderful speakers. Mohammed Al-Hulaini from Oman. I have two questions. One question for Prof. De La Fonte regarding the lentiviral trial. The two deaths, the AML, the two patients who developed the AML, where I did not get the full understanding of the evolution. Is it they failed the transplant and this is their primary that developed secondary to the busulfan exposure, or is there any other explanation for it? And the second question, if you allow me, is for our colleagues from Saudi Arabia. Regarding, this is not directly related to the talks, but it's a general question. We are trying to implement back home premarital testing, and it is ongoing for years as optional, and I don't think it's working very well. Also, there is gradual improvement in its implementation. So I just want to know about the experience in Saudi Arabia. I know that our colleagues in Bahrain, they had, I suspect, a better success in their premarital counseling. I'm not sure whether it's in Bahrain optional or compulsory. So I would like to hear the experience in Saudi Arabia about that. Thank you very much.
So you're absolutely right. The two patients who developed the AML had not had good engraftment. And in fact, a lot of work has been done to be absolutely certain that the lentivirus was in no way implicated in the AML, and it was not. It was at the time where they were using bone marrow, they were not achieving the over 80% rates of transfection that they're achieving now. And they were not able to have sufficient cells to establish good hemopoiesis. And in fact, very much at the same time, we realized that the proportion of the patients who were having the reduced intensity approach of alemtuzumab TBI were having the same problems. And we have subsequently also identified this in a small proportion of patients transplanted for thalassemia. So any situation where you don't achieve good engraftment, establishing normal hemopoiesis in hemoglobinopathies is actually a rather dangerous situation, because you then have a microenvironment which is hypoxic, very inflammatory, and you're putting a small amount of cells having to repopulate the entire system, and that leads to the clonal errors.
Regarding the question about premarital screening, it's mandatory here in the kingdom. They for both tested for electrophoresis for every patient having carrier of sickle cell disease or thalassemia. So if there is a chance of having an affected child, the couples are usually counseled about that. However, this may be given give an opportunity for a physician to give counseling if they want to, some of the couples really wanted to go through with a marriage, about other options including IVF selection for selecting of healthy egg. But generally it's mandatory, and I'm not sure if there is any data, Dr. Abdullah, that we have about the influence of that. But we are, detecting a lot of cases, but mainly usually kind of sickle cell carriers or thalassemia carriers at that aspect.
So the screening is mandatory, but whether the couple will get married or not is not compulsory. So they can decide whether they want to get married despite of the result they are not compatible. But every couple must do the screening before they get married. And as a matter of fact, if they go to the court to register their marriage, they have to bring this paper that they did the test and the test is so and so. So I think this is a good step to be implemented in Oman. You don't really need to force people to not to get married, but at least to do the test. Just do the test, get the counseling. The counseling will be more of explaining all the bad outcomes from this marriage, and then they can decide. And what we do sometimes in our center, if they are insisting, we get the female, like the woman who is going to get married, and let her come to the pediatric ward and see those sicklers who are really in agony and pain, and then they can change their mind.
Unfortunately, it's not mandatory, the testing. But it will be nice to bring one of you to convince our Minister of Health. I'm just kidding, to make it mandatory. Thank you very much.
Any more questions, Dr. Tarawa, Professor Tarawa?
Actually, just to add very quickly, before, maybe when you were, Abdullah, in the secondary school, there was a pilot has been proposed in Al-Hafuf, and it was like what you have there in Oman, that it is not mandatory and people, they have the option to do the test and sit with the physician, and then they decide, and they have the other option not to do the test. 25 or 27 years ago, from the Royal Cabinet, it came to be mandatory for everybody. Based on that pilot done in Al-Hafuf, that the government have been convinced that this should be done. Now, at the beginning, it was mandatory, of course. Everybody need to do it. This is by law. And people, they were not responding very well, and all over the kingdom. The test alone is not enough. We have to have the education. We have to propose the BGD, which is starting this year. And at that time, you will see more result. 3 days ago, I had a meeting with the Prince of Medina to discuss this issue. In Khyber, this is one example that 15 years, the Medina Association, the Inherited Blood Disorder Association, we were conducting very intensive education to the whole community in Khyber, not only for the patient, the teachers, the students, the al-mashayikh, the mosque, and so on. We have published a paper 2 months ago. Over the last 3 years, we have 0 sickle cell newborns. And in Saudi Arabia, we start to have newborn screening program probably 9 months ago. And I have reviewed that before that meeting, and it was 0 in Khyber. So this program is very effective if we conduct it in a very well way, but not to do it and leave the people. I don't know what is sickle cell anemia, and now you're telling me that I am carrier. As simple as that. I don't know whom from the Ministry of Health, they have published a paper 4 or 5 years ago. They are comparing, when we started, 96% of the people, they go for the marriage. And after 15 or 20 years, 15 years, I think, it has been reduced to 40 something. So there is effectiveness. And maybe somebody from Ministry of Health can meet the people in Ministry of Health in Oman to make it obligatory. Thank you. Sorry.
Thank you very much. Any questions? You want
Just,
to ask?
Prof. Fenty, regarding the event of parvovirus in sickle cell group, what do you think the mechanism and will be challenged in the future for other viruses like influenza virus?
So I think the problem was that it caused very severe anemia. And at that point, it probably did not allow sufficient oxygen carrying capacity to continue. But that patient recovered within a week extremely well. And there is, I think, sufficient number of patients there to see that none of the other viruses have caused a problem. From an experience point of view, it's a relatively easy form of transplantation to the liver because there is no immunosuppression, there are no alloreactive complications. So my patients all have returned to work or study 3 months after the actual autograft procedure. The challenge comes in the collection of sufficient cells and being careful with the busulfan PK and dosing things correctly. But if you evaluate the patients correctly, then the post-transplant care is relatively easy.
Any questions? I'm having a lot of questions to the gene therapy, but I don't want to be dominating here. But one of the questions in my mind actually is related to selecting those patients who are candidate for gene therapy. You know, the price is really is not only expensive, it's like ultra expensive, and we are starting this experience, and we want to get it really a successful project. So which patients, like, you are going to make them priority, because we have really large number of sickle cell disease patients in comparison to thalassaemic patients. So would you have like a selective criteria whom should be prioritized to be sent for gene therapy?
So we ourselves are also having the same difficult conversations and discussions. I can't say that we have reached an agreement, but at least I can give you my opinion. We are not exceedingly worried about the situation. I mean, we are worried, of course, about the cost of the product and whether the government will allow its wide use or be restricted. Of course we are. But the reason why we are not exceedingly worried is because we realize that this is a novel therapy and that there is always a relatively slow uptake until people gain confidence that a number of patients are having it. And so it may not be so real, the theoretical consent, that we have lots of patients and only a limited ability to provide it, because it may well be that there are not many patients to start with that they want to put themselves forward. But if we are in the lucky situation that we have a large number of patients who want it and we have the ability to do it, my view is that we should be selecting relatively young people who are going to derive the best benefit. I think if you have evidence of organ damage, whatever that may be, we know that a haploidentical transplant with PTCI is very safe. The approach is reduced intensity, so the likelihood is that even if you have cardiomyopathy or renal dysfunction, you're going to tolerate it well. It is true that it's more complex with immunosuppression for a minimum of 9 to 12 months, but I think it's only fair that if you already have organ damage and you know that you already have risks that you have acquired, that you are the person who has the technique that may have a slightly greater risks, and that you reserve what may be bespoke but expensive to that patient that doesn't have any underlying organ disease, and so is going to derive the most benefit out of it. If you're going to invest, you ought to invest it onto the person who is going to derive the best benefit.
Great. Any questions? Dr. Tarawa.
One more question about the gene therapy. There is any age limitation in thalassemia? For example, those whom they have exceed the age of 40 to do or not to do?
So probably not. I think the problem is that you reach a point where the reality is that there will be organ damage. And so we know, I don't know what is your data in Saudi Arabia, but we have analyzed very carefully the English data. And despite of the wide use of MRI scanning and combination therapy were necessary for the management of iron load, the reality is that once somebody has had transfusions for 25 years, 90% of them have at least one organ affected. And once you get into the 30, the majority of the people will have 2 or 3 organs, and we know that at least 1 in 5 patients have arrhythmia or have failure, that a third of the patients have diabetes, and that at least 40% of the patients will have different endocrine dysfunctions. So I don't think in itself there is a complete contraindication to offering a 45-year-old or a 50-year-old this form of treatment, and I am delighted that the licensing didn't specify an age. But realistically, the truth is that a quite large proportion of patients, once they reach that age, will have organ toxicity where it is, fibrosis in the liver or cardiac complications that might make it difficult to deliver it. And the problem is that when you have a new therapy, everyone's risk is that you will say, oh, because I have a very complex patient for whom nothing else works, I'm going to give them gene therapy. And I think that is the wrong approach. If you have a very complex patient with lots of organ damage, probably you should accept that that is what the situation is and reserve this for those patients who are teenagers, who are early 20s, maybe early 30s, who are still in a very good performance status, who have not suffered from the disease, and you are going to be able to offer them a long-term cure.
Great. I think we do.
If no more question, we can conclude our session. Thank you so much for our speaker for their excellent talk. Thank you for our audience. Before we conclude, just remind our colleague, we have the satellite symposium at 7:30. It's 3 talk, then followed by gala dinner at 9 o'clock. All of us, we are invited to attend this satellite symposium.